morning, everyone. Come on in, take your seats. We're about to get started. Good morning. It is such an honor to be here with you today. Thank you so much for joining us. It's a very exciting opportunity to be at this Health Summit, and I am particularly excited to be here with you. When we started this process and we came up with the title of The Politics of Change, I don't think any of us had any idea just what we were about to face. And so it became quite apropos that today, in the face of a very short election, we are here today talking about the politics of change. We are thrilled that so many of you have joined us, both in person and also I believe there's 500 more of you who are online with us. And that's amazing because this is a powerful group of people, of physicians, of health leaders, of people with lived experience who are going to make a big difference in this election and beyond that. So being here in the national capital, in the middle of a federal election, in a campaign that will be like no other, in the face of shifting political landscapes faster than I've ever seen in this country, is going to make this summit more important than ever. And so we hope that as you learn over these 2 days that you will take that on and make changes wherever you live, with the people campaigning where you live, and make an impact in your own community. During the summit, we're going to explore a lot of different topics in the context of health and healthcare and ways, for example, to mitigate the impact of US health policy, because we know that it's going to be impacting Canada. We're going to talk about how to harness the different AI and other technology innovations to try to spur economic growth and make a difference for health and healthcare. We're going to talk about how we navigate through safe and responsible AI, and talk about other technologies or innovations that aren't even technological and how they can impact health and healthcare and the economy. And we're going to talk about how to advance Indigenous self-determination and improve Indigenous health, because we know the gaps are still far too large between Indigenous and non-Indigenous people in Canada. Yeah. We talk a lot about how do we keep health and healthcare at the top of the national agenda, and we will do our best to equip you, each and every one of you, physicians, medical learners, people with lived experience, to go out and use tools that we can give you to influence decision makers at all levels of government. So we're talking about in your community, the decision makers within your health system, the politicians at the provincial level, the federal level. We want all of you to be able to take the things you know from your experiences in healthcare, from your own experience, from your training, to be able to make this system better for all of us. And so some of you already started that yesterday. You were at the advocacy session with Dr. Mathani, which was a wonderful pre-conference option that people could participate in to learn how to do that, but we are going to build on that. So even if you weren't there, we're going to have some great sessions about how to build on advocacy and really affect change in our communities. If you are interested in getting involved in our advocacy, I would ask you to go to our Stay Informed page on the CMA website, because we do have a section, in the mobile site, the app that we've got, because there is a section where you can sign up, you can get event updates, receive updates about our advocacy initiatives, and just get involved in the work that we're doing and the impact that we're trying to make at the CMA. There's a lot more that you can do as well to get involved with our election. We have an election webpage. You can scan, I think there's a QR code. So you can scan the QR code there and learn either about what we're doing in the election or get connected and get involved, because the more of us who are speaking the same language, pushing the same messages, the bigger the impact we can have. As individuals, we can be strong voices, but together we are a force. And so whether it's during this election or beyond, I hope that everyone in this room gets involved and that we push things in the same direction. I'll also say that we do have staff from the CMA's government relations team here in the room. I can't really see with the bright lights, but if they want to wave, you can probably see them. I don't know if I can't tell if they're waving or not, but if there's government relations people here, give a wave so people can see you. If they're not here, we will connect you. If you can find any CMA folks, we will connect you to our government relations team if you're interested in participating either with our work during the election or after the election as well. We want to make sure that we have that opportunity to connect with you. So for today, I just want to thank you all for coming. I also want to acknowledge that we are on the traditional lands of the Anishinaabe Algonquin Nation. And for those of you online, I also want you to take a moment to think about the lands that you are on, particularly with the apology that we issued this year on behalf of physicians across the country. it is really important that we start these types of summits by reflecting on and framing all of our conversations around the impacts that Indigenous people feel in our health system from historical and ongoing trauma that they experience regularly, and what we can do to make that better. Because like I said, the gap in life expectancy and health outcomes is still so large. And so as we talk about how to make the health system better, I always want us to be thinking about that with the Indigenous health frame, because that is who experiences the worst of our health system. And so that's something that we need to be thinking about every time we're talking about the health system. So I think that's enough from me. We're going to get the day started. I know there's a lot of people you're looking forward to hearing from. So I want to welcome Dr. Carl Ulysses to the stage somewhere. And welcome all of you, and I look forward to chatting with you. Please pull me aside if you want to chat. I want to meet as many of you and learn from as many of you as possible. But let's start this event.
Thank you so much, Dr. Reimer. For those who don't know me, I'm Carl White-Ulysses, a proud CMA member and pediatric anesthesiologist at the Hospital for Sick Children in Toronto. I'm also a reformed business student, a foodie, and an avid reality TV fan. You can find me at the break if you want to talk about any of those. Ayant grandi à Montréal,
I grew up in Montreal. I do speak French, so I'll be happy to answer your questions in both official languages.
As well as the moderator for a panel discussion. Because this is an accredited conference, you will see the slides for each speaker, including me, who will need to acknowledge their actual and perceived conflicts of interest. Just waiting for the slide to show up. And in the context of CPD accreditation, I have declared the affiliations projected on screen. For people who are observing Ramadan on site, the CMA has set aside room 204, one level below, as a prayer room. We ask that everyone be respectful of those who are fasting. I hope most of you have logged into our mobile event site. Your link and login credentials were emailed earlier this week. If you need help, please see staff at the registration desk in the foyer during the next break. The event site contains all the information you need to keep track of the sessions and is your ticket to engaging with panelists, whether through interactive polling or by asking and upvoting questions. A reminder that when engaging on the event site, both the live chat and the Q&A through the Q&A function, we ask everyone to be respectful, professional, and collaborative in all conversation. Questions and comments that are discriminatory, defamatory, abusive, or offensive, or that violate privacy or confidentiality will not be addressed. I now have the honor this morning to introduce Jenny Tenasco, who will be delivering a blessing. We kindly request that you refrain from taking photos or videos during the blessing. Jenny is a proud Anishinaabe Algonquin Kokum, or grandmother, from the Kitigan-Zibi Anishinaabe community north of Ottawa. She is a residential school survivor and a retired child and youth worker who has dedicated her life to working with Anishinaabe children and youth. Kokum Jenny, welcome to the Health Summit.
I will be going around the room outside the tables so everybody can experience this smudge and to keep this positive energy going that I'm feeling inside this room. And then I will be doing my opening prayer on stage when I get back. So we're thanking the Creator. We're sending our prayers up for everyone that needs it, and also to have a positive day and meeting. Miigwech. Kijimadado. Mujak, ni wanike min kijime migwechwea. Kijimadado je kakanake go ka kijendam. Migwechonje kijimadado. Jeben jigech. Onje aki. Migwechonje netawging. Mishashking. Uyagajig. Kaimitagog. Kakanamashki kaemijim. Migwechonje wensisak. Kabamodejig. Kanewakadejig. Kabamisuajig ke majimewajig. Migwechonje nesewin. Kamijien kijimeno pemadazian. Migwechonje skude. Kamijien kijimeno abjatoyan. Migwechonje kisis tibikisis ke nangushag. Migwechonje mijim kai ton wisnawagan injeba. Onje kisis kagisasige jonje nongom. Widoka wishin kijinwakayan. Widoka wayakazijig. Shawenem nebojig. Kitamakazijig ke wa wisnajig. Migwechonje kakana onde jenongom. Migwechonje nibi. Zaigoning zibing. Kakana awensisak. Kabamodejig. Kaneokadejig. Kabamisuajig ashijmaji mejig. Migwechonje onje mino pemadazuin. Mie kichimigwech. We're thanking the Creator this morning. Sometimes we forget to thank the Creator for the beautiful sunshine that we have today and every day, and the air that we breathe, the water that we have in the lakes and the rivers, and the little animals in the water, the fire that we need for survival also, but use in a good way. We ask the Creator to take care of those who are less fortunate, who are struggling in their lives, or the sick. We also thank Him for everyone that's here today to make a change for everybody. Miigwech. So, like I was introduced as Jenny Buckshot Tenasco, a member of the Anishinaabe Algonquin Nation from Kitikan Zibi. My mother, my grandmother, and great-grandmother are residential school survivors. My community is located approximately 140 kilometers from here. This conference is being held within the heart of the nation's traditional unceded territory. I welcome you all to the Algonquin and Anishinaabe territory. As with starting this with the prayer in my language and a smudge, it's a tradition that's been passed on. But with today's smudge and a prayer to the Creator, I will open the session together in a good way, in a sacred way. Let our hearts, our ears, and minds, so that we collaborate and work together in a respectful way within this gathering. This conference is focused on all forms of health. Work in this area is very important. The COVID-19 pandemic has shown us how mental health is connected to physical health. Traditional ways of maintaining good health and healing must be included in today's healthcare system across this beautiful country. Health practitioners in Canada, in fact, all health practitioners from around the world must know that First Nations, Métis, and Inuit people have always had their ways of maintaining good health and healing. Indigenous healing was and is holistic and involves the mind or intellect, the heart of emotions, the soul or spirit, and the body of physical state. Our healing has always been organized in a circle, medicine wheel, or sacred hoop. Our healing is not clinical, cold, or rushed. Our healing does not work in silos. Our heart focuses on building relationships and maintaining good relationships between the healer and the person or family in need of support. I personally believe that non-Indigenous medical professionals can learn a lot from the First Nations, Métis, and Inuit healers, knowledge keepers, and Anishinaabe Algonquin grandmothers. If we can't work together now and into the future, if we can sit in a circle and share our knowledge and lived experiences as First Nations, Métis, and Inuit people with medical professionals, our collective future in Canada's medical system would be very bright. I work part-time also with Algonquin College and Ottawa University here in Ottawa. And there was a panel at Algonquin College called the First Peoples Panel who spoke on healthcare, and this was just last week. They felt that mental health issues, late diagnosis, and a lack of access to healthcare practitioners were a common theme still today. Another problem was the small number of Indigenous researchers and data collectors. They didn't have a lot of Aboriginal researchers. So it's important to train people in our communities to gather this data so people will know what each community needs. They see a trend towards a need for people who have the skill set to conduct research which can help access funding and be presented to the academic community. I wish you all Minope Madazewin, the good life and a healthy life. Miigwech.
Miigwech Kokom Jenny. Before I introduce our first presenter, I want to tell our in-person guests about our interactive exhibit space at the back of this conference room and in the foyer. We encourage you to explore CMA's work on Indigenous health, including our Apology and Reconciliation Action Plan. Learn about other CMA advocacy initiatives and how you can get involved. And meet the team from Healthcare for Real, a CMA initiative that helps make sense of the healthcare system and combats misinformation. We also have 2 interactive displays, a ping pong pole and a reflection collection wall where you can share your thoughts throughout the conference. Please note that Cultural Counselor Lisa Dock-Stader will be at the Indigenous Health display throughout the day for anyone seeking cultural or emotional support. We also have an Indigenous safe space room in room 201 on the level below us, and a separate wellness room for all participants in room 2D. As Dr. Reimer mentioned, these are uncertain times in Canada due to both internal and external pressures. But those pressures have had the remarkable effect of bringing people together to protect our sovereignty, our economy, and all that is uniquely Canadian, including healthcare. After all, what is more made in Canada than our healthcare system? Okay, sounds like we have a bit of a delay with our next presenter, but it should be only a few more seconds.
Hey guys, today we're going to do a quick trivia question here with Gordon Ramsay. It's going to be amazing. We're going to find out what his knowledge is about Canada and Canadian trivia.
Do you need a pee? Are you okay?
I was doing your thing.
Oh, that was me.
What if you maybe can't wear a mask because you suffer from one of the following conditions? Science-itis, acute wussness, selfish syndrome, chronic dickishness. Private healthcare is a great business to be in if you are serving a large, affluent market who can pay premiums for priority and premium service. What happens if you don't live in a large, affluent market? What if you live in a small, flatulent market? We're going to see how this plays out. Yeah, I mean, what happens if the Carpathia sinks? We'll get another ship to rescue us. Oh, there it is, a never-ending line of ships that we have to get on. Pathetic. Don't you think? Jack? Jack?
If you like schools and hospitals and smooth driving roads, then make a list and go get pissed at the LCBO.
Well, that was pretty interesting, huh? Whatever. Daddy just needs to get his drink on. Stuart Reynolds, better known as Brittle Star.
I know Stuart Reynolds and I know Brittle Star.
The Adam Project's an amazing film. It's really, really enjoyable, and it's packed with the action and adventure and the wisecracking comedy that we've come to expect from your work. It's also surprising, though, myself and my wife Shannon were watching it, and really emotional parts, as mentioned in the film as well, which we weren't expecting, which reduced both myself and Shannon to puddles. And I just want to ask you the question, do you enjoy making old people cry? Welcome to Pearson International Airport in Toronto, Canada. If you're visiting Canada, let me be the first to say sorry. Not because it's a Canadian stereotype, but because your time here at Pearson International Airport will be packed with disappointment, frustration, and many, many times where you will ask yourself, why? Why would they do it like that? Stripped of all smugness and a sense of superiority to America, we've had a pretty good time making fun of in the past few years. Will they succeed? Or will they show up at the wrong Shoppers or hockey arena? Find out on The Amazing Vaccine Race Canada. Hello, God's tech support. No, sorry, he's busy. How can I help? Pandemic. Sure. Awful. Let's just check. I see here we did send you some scientists and doctors. And it looks like they've come up with some simple ways to help end the pandemic. Vaccines, masks, simple stuff. Ah, you don't trust them. And the reason? Some politicians, podcast hosts, and someone on Facebook said not to. I see. Okay, so let's see if I understand this correctly. There's a pandemic that's killed millions worldwide. You have the solutions to help end the pandemic, but you don't want to. Don't worry. I think I know what the issue is. You have what we in tech support call a 1D10T problem. That's right. If you could just write that down. Yeah. 1D10T. That's right. It does look like it spells idiot. Hey, I think we're gonna have to reboot Earth. Canada is big. Canada is coast to coast to coast. Canada is milk in bags, but not everywhere. Canada is butter tarts, Nanaimo bars, and poutine, but rarely in the same meal. You make that mistake once. Canada is beer. Canada is cargo shorts. Canada is hijabs. Canada is lumberjack plaid. Canada is turbans. Canada is saris. Canada is kilts. Canada is back decks, long hikes, and canoe rides, and time by the lake. Canada is pickup trucks and country music. Canada is electric vehicles and techno, I guess. Canada is really, really big. Canada is reconciliation, slower than maybe it should be. Canada is not America. That's good and bad. Mostly good. No offense, eh? Canada is hockey and soccer and baseball and football, golf, lacrosse, curling, and more. Canada is big business. Canada is farming. Canada is Hollywood North, though we actually call Hollywood Canada South. Canada is learning. Canada is getting better. Canada is straight, gay, trans, two-spirit, and everything else. Canada is a bunch of people who decided to live here as opposed to somewhere else, most likely brought together by a mutual joy in complaining about the weather. Canada is not always right. Canada is about learning from our mistakes. Canada is the person who served you coffee. Canada is the doctor or nurse who helped someone you love. Canada is the guy who drove the taxi. Canada is your neighbor. Canada is you. Canada is Canada, eh? Now you can applaud. It's always good to play a video before I speak somewhere because people are like, how do I know that guy? They see the videos like, oh, it's that idiot. I get it. Offended. I was going to do some crowd work, but I fear the most answers will be, I'm a doctor. I'm a doctor. What do you do for work? I'm a doctor. So it doesn't work here. There we go. These are uncertain times for Canada. We're facing internal and external pressures that test our sovereignty, our economy, and all that makes us uniquely Canadian. And if there's anything more made in Canada than a double-double or apologizing when someone bumps into you, it's universal health care. Come to think of it, double-doubles and universal health care are kind of the perfect yin-yang of Canada. They need each other, really. It used to be Du Maurier and universal health care, but times change. Times change. The thing is, healthcare is the one thing that unites us all. Whether you're a physician, a policymaker, or a patient, or sometimes all three, you've got stories. Every experience with healthcare comes with stories. Some are sad, some are very worrying, and some are very, very funny, actually. Now, personally, I hate doctors. I hate nurses. I hate the doctor's office, and I hate hospitals. Don't get me wrong, I like my doctor. Shout out Christine Lee, Dr. Christine Lee. She's not dead. I shouldn't do that, actually. She's shorter than that, actually. She'd be more like, I shouldn't kiss her either. I should be fun. But I like my doctor, and I'm grateful I have one. I greatly admire nurses. How they do what they do day in and day out is unbelievable. And I'm thankful to have a hospital or doctor's office to go to when I need to. But here's the thing. My interactions with these people and places is usually precipitated by unpleasantness. And also I feel like a fraud. Like, am I really sick enough to be here? Maybe I'm just wasting their time. Maybe I should Google my symptoms one more time. Spoiler alert, Google knows that you're dying. One time I had such terrible, bad gastrointestinal issues, I went to the ER. Things were dire. I felt awful. I'd been sick for days. And going to the ER, even late on a Saturday evening, never an awesome time to go to the emergency department, especially if you're sober, was the right move. They triaged me, told me to sit down by the bathroom, nurses always thinking. But after an hour, I started to feel resentful. Like, why aren't they helping me? I'm obviously dying. Google said so. Then this guy comes in holding his arm. Now, by holding his arm, I mean he was holding his arm, covered in blood. I'd apologize for that visual that I've just painted so close after breakfast, but this is a medical conference, so if you can't handle it, get out. But suddenly I felt like a fraud again. I could feel my stomach starting to gurgle threateningly, and I thought, shut up, you wuss. That guy's arm's barely hanging on, held on by sheer optimism and an unwavering belief in the Canadian healthcare system. That's the only thing holding that guy's arm on right now. Healthcare really is the great equalizer, though, isn't it? When you're sick, all the labels disappear. We're not CEOs, accountants, or beloved social media darlings anymore. No, we're just bags of meat and bones. Dignity, gone. And of course, much effort is put into making sure dignity remains intact for patients. I get that. However, you could be a CEO or a barista, but in that exam gown, you're just a sad, flawed burrito waiting for judgment. Healthcare strips away all the normal inhibitions, though, doesn't it? I once had some concerns down there, down, yeah. Let me be clear as well, everything works, still. But I had some concerns. So I mustered up my courage and I went to the doctor. The nurse came in all professional, empathetic, and understanding. I began explaining my reason for the visit without being, too graphic, because you're aware as a patient that it's in your best interest to be as descriptive as possible without, you don't want to be gross. So you're thinking about word choices. You're using hand gestures, the occasional head tilt, maybe an eyebrow raise. And I'm thinking, how do nurses keep a straight face? They must hear the weirdest things. I don't know how it got up there, but it's not coming up now. Anyway, the nurse, she listened to my concerns and typed some notes on the computer, and I was too far away, but I'm sure it was packed with incredulousness that such a fine specimen of a man would have anything wrong down there. She told me to undress from the waist down, and the doctor would be in to see me in a minute. Again, you put your normal dignity on hold when you're at the doctor. So I disrobed 50%, and I waited for the doctor. Healthcare professionals, they see this thing all the time, this kind of thing all the time. Nothing to be ashamed of, but just a bag of meat and bones. So I'm standing there, waiting for the doctor, flapping in the breeze. The doctor comes in, not Dr. Lee, by the way. Different doctor. Doctor comes in, looks me up and down, has a concerned look on his face. I'm starting to worry. He turns towards the window in the nearby apartment block and finally broke the silence, and I'll never forget this. He said, "Well, I guess we should close the blinds." That'd probably be the first start. When it comes to your health, all bets are off. Dignity out the window. My bare ass visible through that same window. Healthcare is something we all need at one point or another in our lives. It is the great equalizer. When you need healthcare, you need it. Anyone remember the pandemic? No? Nothing? Global health crisis? Nothing? Doesn't ring a bell? Yeah, a lot of people seem to have forgotten it recently, haven't they? The economy is struggling. Maybe because the world shut down for a few years there? But sure, let's blame woke. That's a good idea. The pandemic feels like a bad dream now. The worst part of the pandemic, okay, maybe not the worst part of the pandemic, but one of the less awesome parts of the pandemic for our current perspective is looking at photos of yourself from before the pandemic. A photo of myself and my wife Shannon came up on the memories thing recently on my phone, and I showed it to her. We were all fresh-faced. My hair was dark brown. We looked like kids. We're like, God, this must be like 10 or 15 years ago. When's this from? Oh God, March 2020. But of course, the pandemic was so much worse than that, especially for our healthcare workers. While most of us were binge-watching Tiger King and making a solid argument for turning wine into a breakfast juice, healthcare workers were tirelessly doing their best to keep us alive, and I'll never forget that. So, thank you for that. But alas, people are stupid. Have you ever noticed that every Canadian blames their health problems on the weather? I threw my back out. It must be that El Nino. I have the flu, probably that cold front from Alberta. I lost a leg in a wood chipper. This damp makes everything worse, doesn't it? We need to stand up for our healthcare system because people are stupid. And we don't know how good we've got it sometimes. We take it for granted. And that's why we have to fight for it.
Our system isn't perfect. It's hurting, it's strained, it needs to be strengthened. But here's the thing. Canadians don't just throw up their hands and say, well, that's how it goes. No, we stand up for what's ours. We make things better. Because the alternative, it's not an option. Healthcare isn't just a service we use, it's a symbol of who we are. It's proof that we look out for each other, that we don't leave people behind when they need help the most. And yes, we complain about it a lot. A lot. But that's because we care. We don't settle for broken systems, we fix them. We find solutions. We make them stronger. Because when it comes to healthcare, we're not just protecting what we have, we're making it better. And that's what Canada does best. In Canada, we make things better. Sometimes slowly, but always, incessantly, bordering on annoyingly. I'm unapologetically proud of Canada's universal health care. It is flawed, but it is fixable. It has unacceptable wait times. Though to be fair, we are a nation who taps trees and waits for sap to drip out to turn into maple syrup. And there are people who still think the Leafs are going to win the cup again. It's this year, by the way. They're going to win this year. Canada's universal health care is battered but won't bankrupt us. You never have to choose between, your health or money. You don't have to choose between getting a mole checked or fixing the brakes in your car. You don't have to choose between, well, the car's brakes are squealing, but this mole has started blinking. You don't have to do that kind of decision making, which is good. Universal health care is the most Canadian thing we have. More than hockey, more than poutine, more than, God forgive me for this, butter tarts. Universal health care is the ultimate sign of our national character. Fairness, kindness, an unspoken agreement that no matter what, we've got each other's backs. It's the one thing we can point to and say, this is what makes us different. This is what makes us better. This is what makes us Canadians. And yet somehow we still have people treating it like an optional feature instead of the foundation of a decent society. Could it be better? Of course. But you don't scrap the whole system just because it needs work. You don't throw out your house because the roof needs fixing. And you don't start charging rent to your kids because they've been staying there for too long. Actually, that one does make sense. That's probably a fun one to do. But what I'm saying is we need to stand up for our healthcare system, not just because it's practical, but because it's who we are. So, as you go through this conference, learning, networking, schmoozing, glad-handing, I don't know what you guys do, really, I don't know. But as you go through this conference, let's be sure to keep complaining about it. Let's also keep working to make it better. Because healthcare in Canada isn't just about healing people. It's about making life better for all of us. And that's worth fighting for. Sorry.
A huge thank you to Stuart Reynolds, also known as Brittlestar, for his humor and thoughtful commentary. So that's a perfect jumping off point for our first panel discussion, Beyond Borders, How US Health Policy Could Shake Up Canada. We've all read the headlines, the cuts to national health agencies like the Food and Drug Administration, National Institutes of Health, and Centers for Disease Control and Prevention, the withdrawal from the World Health Organization, and many others. It's really impossible to ignore the impact these decisions could have on healthcare in the US, Canada, and around the world. I personally have to make the millennial move of pledging to do a social media cleanse pretty much once a week these days. So with that, I'd like to welcome our moderator for this panel to the stage. André Picard is an award-winning health columnist at the Globe and Mail. Bienvenue André, et merci d'être avec nous aujourd'hui.
Welcome, André.
Merci beaucoup.
Thank you. Thank you for this introduction.
I'm Andre Picard. In the context of CPD accreditation, I've declared the affiliations projected on the screen in a moment. Now, in the years I've been a health journalist, the many years, we've always looked at the US with a mixture of disdain and awe. Disdain because their health system is so inequitable and expensive, and awe because they have this massive research enterprise, so much money, so much ability. Now, these days we look at the US in horror. They're savaging their global health infrastructure, tossing scientific consensus into the garbage to be replaced with quackery and partisanship. But what will the impact of this upheaval be on Canada? That's what we want to talk about this morning, and we have two great panels. Joining us first are two guests from the US. We have Apurva Mandavili. She's a science and global health reporter at the New York Times. She's a Pulitzer Prize winner, part of the team that won the 2021 Pulitzer for its exceptional coverage of the COVID-19 pandemic. Welcome, Apurva.
Good morning, Andre.
And we also have joining us Dr. Tom Frieden. He's a physician trained in infectious diseases, public health, and epidemiology. He served as the director of the Centers for U.S. Disease Control and Prevention under President Barack Obama. And today he's the president and CEO of Resolve to Save Lives, a great global health initiative. Dr. Frieden, thank you for joining us this morning. I know you're on a tight timeline, so I want to start with you. What's going on with the US? What's happening in global health? All these cuts, what's the impact going to be on the world more broadly?
The impact will be massive both within the US and globally, and it may take time to see all of the damage that's being done, but the damage is really quite substantial. We're just hearing about recent moves kind of day by day, whether it's withdrawal from the World Health Organization, which will affect immunization globally, will affect influenza tracking, will affect polio virus and TB and HIV and malaria and so much more, or the defunding of Gavi, the Vaccine Alliance, which could lead to the deaths of millions of children. These are chaotic, not well thought out programs that are essentially pulling the rug out from partnerships that have been built over years and decades. Within the US, we're also seeing a series of abrupt and chaotic changes that are quite ill-advised. Looking at the US Centers for Disease Control and Prevention, the mission of the CDC is to protect Americans from threats, whether those threats are natural or man-made, whether they come from the US or anywhere in the world, whether they are infectious or otherwise. And moves just announced in the last 24 hours would undermine the ability of CDC to protect Americans. Now, what does that mean for Canada? Well, you may be facing spread of infectious diseases, measles, pertussis, drug-resistant tuberculosis from the US. You will also be facing spread of infectious diseases globally that will increase predictably as a result of these ill-considered changes. There's also both opportunity and I don't want to say responsibility, but the potential for Canada, which has been a strategic and generous partner in many of the global health initiatives, to do even more. And I know that that's difficult, and as an American, it's hard for me to ask you to do that, given what our government is doing. But the fact is, there are huge challenges around the world, and there's going to be a need to mitigate the damage that's been done, and also to think strategically, because although it's certainly the case that what's being done is counterproductive, it's also the case that every institution could be better. And thinking about how US CDC, World Health Organization, countries throughout the world raise revenue and spend that revenue, what proportion goes to health and what proportion of that has a maximum impact, that's all well worth considering and doing. So there's a quick overview.
And do you think that can countries like Canada, can Europe, can they actually fill the gap? The US is a huge funder, a huge influence around the world. You've had a tremendous impact when you were at the CDC, for example. There's going to be a gigantic void.
Well, there are real challenges. During my time at CDC, we dealt with the West Africa Ebola epidemic, and one of the wonderful things that Canada did at that point was to provide French-speaking expertise, because many of the Francophone countries in Africa were quite neglected. And so you do have some real assets that are of tremendous importance. But the fact is that the US has been providing very substantial resources, and these are likely to be very substantially reduced, and it's going to be hard to replace those. We're going to have to look at potential additional revenue sources. We're going to have to look at efficiencies and at prioritization. I will mention one thing for revenues. There's one thing that can be done that is a win-win-win, and that is to tax tobacco, alcohol, soda, sugary drinks, and junk food. Doing that does three things. It raises revenue, it reduces healthcare costs, and it saves a lot of lives. So that is one opportunity for countries to consider. I don't have high hopes of that happening in the US, but these are proven ways to save lives and generate resources and reduce healthcare costs.
Right. We have many of those sin taxes in Canada already, so we're doing okay on that.
We prefer to call them health taxes.
Okay. Purva, I want to bring you in. Every day we read in the news the horrible things going on to U.S. health agencies, the CDC, the NIH, VA, et cetera, et cetera. Can you give us an overview of what's going on and the impact so far?
So already so far, we had seen that the Trump administration got rid of thousands of employees from the health agencies. And then this week has been a bit of a doozy already. This morning, in fact, the HHS, the Department of Health and Human Services, just announced that they would be cutting 10,000 jobs from the federal health agencies, which includes the FDA, the CDC, SAMHSA, which is the agency that does mental health and addiction. And those things are going to have a very big impact. You know, we're still even learning all the details of exactly what the changes will look like, but I think there are things that will affect Canadians, for example. I mean, when we think about infectious diseases crossing borders, we always think about these big ones like pandemics and measles, but also one of the things that is happening is much less focus on HIV prevention within the US, and that will have an impact on the number of HIV infections inside the United States, and therefore also on its neighbors eventually. So that's a potential impact. We also heard yesterday that the federal government was taking away $12 billion that was given to states to do infectious disease tracking, to do addiction services, to do mental health services for its residents. And so the states are still trying to figure out what that all means for them. But if there is no way to get that money back, they will be really hamstrung in what they can do. And that's another huge impact on American citizens. One way I think that Canadians could really help, Canadian health agencies could really help, is that we are hearing that the HHS, the federal government, is going to be centralizing all communications. And as you may know, our new health secretary is not a big fan of vaccines. So I think Americans might be looking elsewhere for some information about vaccines if communications about things vaccine-related that normally would come from the CDC will now be coming from an agency, from a department that's headed by someone who is not necessarily pro-vaccine. I think Americans will want other sources of information, and that's a void that Canada could fill by providing, easy-to-access information for Americans. So there are ways in which this will interlink both countries. I think it could interlink both countries, and certainly on the ground here in the U.S., there are just way too many changes to even keep track of day to day.
Well, and I was going to ask you that, how do you keep track? And is there actually a plan here? We wonder, it's sort of shock and awe, but is there a plan to have a different health system, or is it just cut?
Some things look like they might be part of a plan. So, for example, when they cut things like HIV prevention, it's not obvious exactly what's happening, but then you learn that it's being moved to maybe another part of the government. That looks like a plan, but it may not be a very good one because the place that it's being moved to may not know how to handle those kinds of functions. Some things that they are planning to cut, like maybe gun control, that might make sense with the sort of greater Trump administration policies. Cutting childhood immunizations, we know that makes sense just given their stance on vaccines. But for example, the cuts to the states that I was talking about yesterday, they were framed as cuts that were made for COVID, the grants that were made for COVID. And so it looks very logical and reasonable to say this is money we gave for COVID. COVID is no longer a crisis, therefore you don't need this money anymore. But the truth of the matter is that the states had been using that money for all kinds of infectious disease tracking, and it's not actually clear that the people who instituted the cuts realized that. So that may be a case in which there was a plan that they thought made sense, but perhaps it was not fully thought through about how that money was being used and what impact that would actually have.
And Dr. Frieden, we know that vaccination is a cornerstone of public health. It's made a world of difference over the last decades. Where do you see us going in the next 5, 10 years if we see institutions like Gavi being savaged yesterday? What happens if we don't immunize the world anymore?
Vaccinations are really, as you know, one of the great accomplishments of humanity, and the implications of undermining trust in vaccines are massive. We'll see what happens in 2.5 weeks when the ACIP, the Advisory Committee on Immunization Practices, meets, and whether they're able to have the kind of transparent, objective discussion that they've had for many, many years. But what we're seeing is really very concerning, because the risks to the world and the risks to the US are enormous. Decreased vaccine research, decreased vaccine uptake, decreased support for global vaccines. And there's really an irony here that what we're hearing today is that the administration wants to limit the CDC to infectious diseases, and at the same time they're undermining confidence in vaccines. So this is essentially a 1-2 punch that will make Americans sicker, increase our already high healthcare costs, and reduce economic productivity. A weaker CDC means a sicker USA. CDC has contributed to saving millions of lives, not just from vaccine-preventable diseases, but also from cancer, heart attacks, strokes that are the leading causes of death, from road injury and overdose. So it's very concerning to see. There will be real health implications. It's sometimes hard for people to see what public health does, because there isn't an outbreak, or your neighbor doesn't overdose, or your father or your father stops smoking, or your child never starts, or your grandmother doesn't get cancer. Cutting this work puts everyone at greater risk.
And as you said, public health is invisible. It's visible during crises. I assume it's going to become a lot more visible in the years to come, unfortunately.
Unfortunately, limiting our health defense to just some threats is kind of like telling the military just to protect us from some types of attack, or telling the Weather Service to warn about tornadoes but not hurricanes, or telling doctors to only diagnose and treat some diseases and not others. It's really short-sighted, and it will result in not only preventable illness, injury, disability, and death, but also increased healthcare costs and reduced economic productivity.
And Apurva, another area we're seeing really disturbing cuts is in the way data is handled and managed, the whitewashing of data, people disappearing like transgender, for example. Talk about the impact of that on health and even on your work.
Yeah, I mean, that was one of the first things that the administration did. So President Trump signed a couple of executive orders that essentially forbade the use of certain terms, and one of the big ones was transgender. But he didn't really stop there. There were sort of there were bans on the use of the word gender at all. In some cases, even the word women. And those kinds of things made it really difficult to protect the databases. So there are a lot of CDC databases where data is, for example, collected, and then you could imagine an HIV or a STD database that would include information about transgender men, for example, and that was all removed. And that makes the data unusable to a certain extent, because you've now removed a very important variable, and you not only have corrupted the database in some way, which we don't even know if that's actually legal, but also we have now changed the way that the database was meant to be used. It it makes it much harder for people to focus the efforts on the key populations that are most at risk of a particular disease or infection. And we're still just beginning to understand all the ways in which these things have been affected. So it's a little early to say exactly what kinds of impacts it will have, but it's undoubtedly going to have an impact on how public health is delivered to the people who need it most.
And we're almost out of time, but I want to ask each of you, can you be hopeful in any way? Is there any good that's going to come from this? Dr. Frieden, how do you maintain hope in this atmosphere?
I think you have to go back to first principles. There's kind of a post-truth perspective to some of what we're hearing from the administration, but facts are stubborn things. And when diseases come back, when there are scientific breakthroughs, when you have the chance of preventing tragedies, I think working locally, building community, being clear about our principles, we don't have conflicts of interest. Our interest is in promoting long, healthy lives. And if we just stick to the facts and the truth, we understand that there's a lot of misinformation out there. But ultimately, starting with doctors and other clinicians who are caring for patients, building trust, rebuilding community, focusing on what we can do to make the most progress on health, and understanding that despite all of the partisanship, everyone wants to live a long and healthy life. And there are proven ways to do that. Improving primary health care, something that Canada has done well. Still unfinished business, I'm sure, but improving primary health care is a core way of building society. And no one wants to look back at COVID, but the fact is there are really important lessons. One of them is that we do need a renaissance in public health, and we can get there with new methods, new tools, new people, new generation to focus on public health challenges. We need robust primary healthcare systems, and we need resilient communities able to withstand shocks, whether they're natural or man-made.
Great. Well, thank you for those hopeful words. Apurva, we journalists aren't the most hopeful people at the best of times, but where do you find hope in this?
So I want to borrow something that Tom said, which I think is, the facts are stubborn. You're already seeing these measles outbreaks, for example, in the US. So you can have a health secretary who thinks that the measles vaccine is more dangerous than measles, but I think when people are confronted with the disease itself, they will be reminded of why the measles vaccine is important, for example. But also, I've been seeing just the public health community is so resilient in many ways. These people are used to working in the most horrific of conditions, seeing the most horrific things, and coming up with hope and optimism and plans for combating those problems. And I'm seeing them do something very similar right now with this crisis. And one of the things I'm seeing is, as you know, no organization, no system is perfect. There are inefficiencies. There are ways in which things could be improved. And with the loss of massive amounts of funding, one of the things I'm seeing is people talking about, okay, maybe we don't need to do it this way. How can we do it in this other way that's maybe more efficient? And so it is leading people to think about how to do things better, more efficiently. This is the most painful, horrific way to get to those lessons. But still, I think they are determined to get there. And so that is something that I really see and admire in the community at the moment.
Great. Dr. Tom Frieden, Apurva Mandavili, thank you for sharing your insight and your wisdom with us today. We're now going to move on to talk about the Canadian aspects of this, and you're welcome to stay with us, but thank you for being there this morning.
Thanks for having us.
Now we're going to shift the discussion to examine how the U.S. cuts and shifts in health policy could have an impact on the health systems here in Canada, as well as our research enterprise. We have another panel, so let me get right to introducing them so we can spend time chatting. there's back there somewhere. Dr. Joss Reimer, you met earlier this morning. She's the president of the Canadian Medical Association and served as the chief medical officer for the Winnipeg Regional Health Authority. Dr. Reimer, welcome. That's my seat. Sylvia Jones is Ontario's Minister of Health and Deputy Premier. She has served as an MPP since 2007 in the province. Minister, thank you for being with us here today. And joining us virtually, we have Dr. Andrew Furey. He's the Premier of Newfoundland and Labrador, and he's also an orthopedic surgeon. Premier, welcome. Somewhere. There you go. Oh. There, you just showed up on our screen. Welcome. Thank you. And we have Uzoma Asagwara. She's Manitoba's Minister of Health, Seniors and Long-Term Care, and the Deputy Premier. Prior to entering politics, they worked as a psychiatric nurse and were a member of the national basketball team. Minister, welcome. Great, thank you all for joining us here this morning. I want to start, if I could, with Minister Asagwara. We heard from the previous panel about the chaos in U.S. healthcare, and we know about the ongoing threats of tariffs, of course. How could all this impact healthcare in your province in particular and in Canada more generally?
Yeah, this is something that is obviously top of mind for everybody. Certainly, it's something that came up at our first the federal, provincial, territorial health meetings a couple of months ago. But here in Manitoba, we've been actively doing the work of ensuring that our province has a sustainable health infrastructure as we move forward in these pretty unprecedented times. We know that, the tariffs the Trump tariffs are going to have a very real impact on our economy, but of course they're going to have a very real impact on healthcare and the infrastructure of healthcare across the country and certainly here in Manitoba. And, when we talk about public health, we talk about public health care a lot. We talk about a public health care that we want to be strong in Manitoba and we want to protect and enhance. It is not impacted by the United States. So when we see these massive and very rapid policy changes on the public health side in the United States, we share a border, we have friends, family, colleagues, we share research, we have a really strong and important relationship with the United States. There is going to be, and we're already seeing, a direct impact here in Canada and certainly here in Manitoba. So, we focus here in Manitoba on taking an approach that centers and really amplifies Canadian values. We believe in public health care. We know that public health care has to be strong, and that's to the benefit of Manitobans and Canadians. We believe that now more than ever, people need to be unified and need to have accurate information, evidence-based, science-based information to make the best healthcare decisions for themselves. And so we're doing the work of protecting not only our economy, but our healthcare infrastructure, strengthening our relationships, and doing our part to make sure that Manitobans remain informed, they have accurate information, and they can trust their government to be a source of that in meeting their healthcare needs.
Great. And Minister Jones from Ontario, I wondered if you could build on that. The greatest threat from the U.S. actions, is it that it's going to affect procurement, for example, making it more expensive to get goods and services? Or is it going to be the squeeze on public finances that comes from tariffs, et cetera?
Great question. I think it's both, frankly. I mean, from a health system, we are very much actively watching and preparing for what the tariffs will mean. When we announce in Ontario 49 new MRIs, we don't build MRIs in Ontario. So that has a direct impact. Many of those machines are already in place, but there's a number that are going to be heavily impacted by any tariffs. The medicine that we procure. So when we look at Ontario and the Canada approach, it really is, what can we bring back? What can we do more of? And honestly, looking at the pandemic is actually a really good lesson for us. We were able to do in Ontario bringing manufacturing of N95 masks, which, as you know, we didn't have in the province of Ontario. And so as we look at those opportunities, not something that we necessarily wanted to have to deal with, but similar to the pandemic, working through all of the impacts and ultimately where we can do more domestically.
And Premier Furey, how can a province like Newfoundland, Labrador, or any other of your counterparts, how can they protect themselves against the actions of a giant like the US? What can you do practically?
I was hoping you had the answer. Look, you know, there's several things that we can be doing, and the ministers have highlighted certain elements in protection in the supply chain and the integration of the economies that are not exclusive to any specific industry and certainly can be felt across the healthcare space. By the way, that includes natural resources and retaliatory tariffs and how that is integrated into the development of a hip replacement and then transferred back across the border. So no one can fully predict the fiscal or economic consequences within the healthcare system itself. But I'll take a slightly different view than some of the other panelists, building off what the US colleagues just discussed. There's a larger contagion potentially that will have a more lasting impact, and that's a social contagion and the acceptance of not subscribing to evidence-based medicine. And whether you like the structural changes that just occurred in the United States, and they're chaotic and fast-paced and will have definitive, long-standing consequences in public health and overall health scores within the United States and as a consequence in Canada as well. The acceptance of the fact, there was over half the population voted for that. So we have to look inside ourselves as a healthcare system, as healthcare providers, to ask the question why that happened. And of course that happened in the United States, but it's also happening to a certain degree here in Canada. There has been an erosion of trust within the system, and if we don't reflect on that, if we don't understand that, and if we can't use the language to try to cure that, then that becomes a more problematic issue than the actual tariffs themselves. And so while in Canada we have the ability to say that Donald Trump makes no sense and that any of these structural changes within public health or the healthcare system writ large make no sense, there is fundamentally a shift in the societal thinking in healthcare in the United States, and we're not immune to that here in Canada either. And so as leaders, as physicians, as service providers within the system, as journalists, we need to make sure that we are continuing to instill trust in the system itself. And that's the contagion that I'm more concerned about when it comes to the healthcare system. And so writing off the Joe Rogans of the world is not the way to do it. Trying to figure out how to speak to his audience is the way to do it. And recognizing that citizens have questions and how to answer those questions at their level is going to be critically important in the next 4 years.
And I hope we can come back to this question of erosion of trust and the impact of misinformation a little later in our conversation. But I want to stick to systemic stuff for now. Dr. Reimer, do you think what's going on in the US, is that ultimately going to pose a threat to Medicare? You know, beyond the costs, et cetera, are they coming after Medicare too?
Well, that's really up to Canadians, what we do, and we're in the middle of a federal election. So now is really the time for all of us to make sure that our federal decision makers hear what's important to us and what we want. And so as Canadians, that is incumbent upon us to make sure if someone's coming to you and asking for your vote, that you're asking back, how are you going to protect my healthcare system? How are you going to make it better? Because the federal government and the provinces have to work together. The federal government is a major funder of our health system. And we know that our health outcomes in Canada with our health system far exceed the American health outcomes, despite the fact that they spend more tax dollars per person on their system, plus the insurance dollars and the out-of-pocket. So we know that our system is a better way to go, but that doesn't mean it doesn't have many different challenges and flaws and things that we need to improve. So we need to be learning from what we're seeing there and protecting our system here and making sure that all of us are engaging in the opportunities that we have to influence decision makers to protect these systems.
And as you said, our systems aren't perfect. Do you see the potential or Do you fear the potential that we could see US-style cuts in Canada?
I think there's always potential that we could see changes, and that's up to who Canadians choose to have as their leaders. We get to live in this wonderful democracy where we have a say in who represents us and the decisions that they make, and so it always depends on what leadership is saying they're going to do with the system, and the provinces have a massive role, obviously, but right now with the federal election, they also have a role, and so that is up to us as Canadians to decide what we want to see. And obviously, as people who work in the healthcare system, we care deeply about this healthcare system. We want it to be there for Canadians. And right now, when we're the emergency room doc who is seeing someone who's been waiting for 12 hours, that is heartbreaking, and we're experiencing moral distress. But we need to lean in and strengthen the system and not look at solutions that have been shown to not improve wait times, improve cost effectiveness.
Minister Assig, well, we heard in the previous panel about the attacks on data, the way it's being purged, and categories of people are disappearing. How do we in Canada, how do we maintain the integrity of our data and make sure that our populations get good information about the entire population?
Yeah, I think to Dr. Reimer's point, we really have to lean in. You know, now is the time where we have to lean into the value of data. Here in Manitoba, we have the benefit of taking an approach in terms of data and data desegregation that allows for us to make really informed decisions and work with partners across the health sector and even beyond our own jurisdiction to take approaches that are innovative. And, you know, I think we have to be pretty unapologetic about the fact that we believe in science, we welcome information, we value data, and we need evidence to make the best decisions. So, you know, in our province, we are going to continue to do the work of gathering data, of modernizing our healthcare technology, modernizing our healthcare systems, taking a provincial approach so that all communities have the chance to have informed data, you know, impacting the way that healthcare decisions are made, working and partnering with First Nations, Indigenous leadership, with communities that are disproportionately affected by upheaval in our economy, by healthcare not meeting the needs of folks the way that it should, working directly with folks who are disproportionately affected and making sure that they have a say in terms of how data is collected, how data is informing decisions that are being made. And, you know, we really have to, right now, I think more than ever, be very clear about our values in terms of science informing our healthcare decision-making, you know, investing in strengthening public healthcare through an informed lens. And, you know, here in our province, we're doing a lot of work on that front to make sure that we are quickly moving Manitoba in a direction not only to get to the point where some of our counterparts across the country are in terms of medical technology, science, evidence-informed approach to segregated data, but moving ourselves in a direction that hopefully folks can also look to and be inspired by. So, you know, science is a great tool. We have to not be shy about talking about the value of research. And so our government has taken steps to invest in research, and we're actively taking steps to welcome folks to Manitoba who have that expertise. We want folks to know that Manitoba is a place where we're excited about the opportunities of research and innovation, and we want the best talent in our province to be a part of how we make healthcare stronger on that front.
And Minister Jones, to build on that, I imagine Ontario is also trying to draw workers to. Are you seeing some opportunity in this? Maybe get U.S. health workers, U.S. researchers. You've invested a lot in the life sciences enterprise in your province, for example.
So there's a couple of things that I would highlight. Absolutely, there are certainly some Canadians who have been working, practicing in the States that are now actively talking about how we can move back home and practice in Ontario or Canada. I'm proud of the fact that almost 2 years ago, Ontario put in place as of right legislation that allows healthcare practitioners who are practicing in another Canadian province or territory to immediately start working in Ontario as their license is transferred. I know that there's a lot of interest through speaking with other health ministers that they are looking at how they can duplicate that in their own provinces. Those are the pieces that are what we need to do to prepare. I think back to the pandemic, and we leaned strongly in Ontario and Canada on our medical experts, whether it was chief medical officers of health, whether it was individual medical officers in our health units, whether it was reaching out to leverage existing partnerships. We had fly-in Indigenous communities that had 100% vaccine take-up. Why? Because we leveraged existing relationships and partners like Air Orange Ambulance, who had relationships with communities and knew how to get the job done. And I think that as Canadians, you look at the vaccine uptake, and we should be very proud of how we stacked up worldwide. And it's because we leaned heavily on our experts. We showed the data. We weren't afraid to show the data to our residents, our citizens, and ultimately, we let the experts speak. And I think that made a difference in our numbers.
And the CMA is a big advocate of pan-Canadian licensing, pan-Canadian data sharing. Is this an opportunity for provinces to cooperate a lot more?
It is, and as I said, when we brought forward that legislation a number of years ago, I've had many conversations with other provinces saying, how did you do it? And how is it working? And I think that's just one example. We started with physicians, but we can take those allied health professionals and say, how can we streamline this? Because I have no intention, and I'm sure no province does, to go and poach. But when people want to have that ability to go to a different province, we should not be putting barriers up.
Great. And Premier Fury, healthcare is already a big consumer of the budget, of 45% I think in your province. There's going to be more costs, et cetera, related to what's going on in the US. How do you contain that? How do you still deliver healthcare to the people and not have it gobble up everyone's lunch at the cabinet table?
Well, healthcare remains top of mind in the budgetary cycle, and it's the top expenditure for every province, not just Newfoundland and Labrador. There's been incredible pressures. Given the current economic circumstances, inflationary pressures are not exclusive to supermarkets and drugstores. They exist across government agencies, including healthcare. So there's increasing inflationary pressures on the system itself. But at this moment in time, post-pandemic, and with the existence of Donald Trump, there's a moment of disruption where the public is demanding that the system be changed. It's demanding that the system be more robust. It's demanding that it be dynamic. It's demanding that it evolve to meet a modern Canada. And some of that requires investment. So that's the argument at the cabinet table. But if you cannot make change without investment, it's as simple as that. And they have to be wise investments. They have to be prudent investments. They have to be metric-driven investments. But we cannot make change in the medical record systems, the data sharing systems, the recruitment of healthcare professionals, the expansion of healthcare professionals without investments. That's just an illogical argument. So while we are seeing the pressures of inflation and recognizing the pressures of potentially tariffs, we've set aside, as many provinces have, a contingency fund to allow for some flexibility across all the different departments, but I'm assuming will be felt for the purpose of this discussion and used appropriately across the healthcare system as well. And just to pick up on the mobility of healthcare providers, in Atlantic Canada, we have one license. And the easy way to expand as a national license is everyone just use the Atlantic Canadian Registry. Just click a box, it's done. I am currently licensed in New Brunswick, Nova Scotia, and PEI. It costs an extra $200 or something. Part of the problem with mobility of physicians particularly, and I did this as an experiment myself, and this demands all of us to try to address this, is the Medical Council of Canada's registering of documents is a burdensome process for anyone who's in a busy clinical life. And so while we would accept the Ontario license, and we did the same legislation, by the way, back in 2021, to accept other provinces. There is still a burden, an administrative burden that is too heavy for someone in a busy family practice setting, in a busy surgical setting, and a busy ER to actually fill out the required documents. I'm not sure why the Medical Council cannot just accept the credentials that exist currently for the College of Ontario or the College of Manitoba and have that as a carte blanche.
Hear, hear.
And we're hearing hear, hear from the audience. Some applause for you. Certainly when you talk about lifting the administrative burden on health professionals, you have a very open-minded audience here. So thanks for mentioning that. I want to remind that same audience that we're going to have a question period in about 5 minutes. So get your questions in on the Q&A function on the app. And there will be mics roaming around, but it's easiest to do it on the app, which I'll open up in a minute. Dr. Reimer, you've spent a lot of your term so far talking about misinformation, its impact. What's the impact of misinformation and that mixture of what's going on in the US? Do Canadians know what's going on? Are they confused? Are they scared? Where are we at?
Well, Canadians are being bombarded by misinformation, particularly on social media, where the algorithms really push it. It sells better than the truth. And so particularly when you don't have access to a family doctor, you don't have that trusted relationship with a healthcare provider, you go online to get your health information. That makes sense. But when we don't know what information is trustworthy or not, of course Canadians are going to be confused and making decisions that may or may not be in their best interest health-wise. And things are only now getting worse because a lot of the sources of information that used to be a given, it used to be a given that the CDC website would be a trustworthy source of information. It was, for those of us working in public health, they had a weekly report that went out that was a given that they would be sharing up-to-date health information about what was going on in infectious disease and other things, and none of that's a given anymore. That report, for the first time in 60 years, didn't go out for several weeks. The website has been scrubbed of many of the pieces of information, like their contraception guidelines that are used across Canada as well. It's been scrubbed of different terms. And so now even the information that's there, we know there's political interference in that information, and we don't know how reliable it is. So this is an opportunity for Canada to really step up. I want to see Health Canada, the Public Health Agency of Canada, as nonpartisan, trustworthy sources of information that Canadians know can be there for them when they need that information, and that healthcare providers can go to. If they need contraception information, where is the health provider going now that the CDC doesn't host that page anymore? So this is something we're seeing across the board. Canadians are impacted, and we even surveyed Canadians, and they told us that 23% of them have already experienced harms because they followed medical advice they saw online. That's just the 23% that know that the harm came from what they followed online and are willing to admit it in a survey, which is a hard thing to admit when you've experienced a harm. So this is not nothing. I had a patient when I was at the hospital who refused a blood transfusion because she didn't want to receive vaccinated blood. So this is someone who was at risk of dying because she was bleeding and was trying to make a good health decision. But misinformation, when you don't have that good advice, can be the difference in life or death. And so we need to step in now and support Canadians. Like Premier Fury said, there is a reason that the trust is decreasing, and we need to talk to Canadians to make sure that we understand what the issues are for them and that we're responding to them. But this room is so important because that trusted relationship between health provider and patient, that is sacred, and that is how we can really impact the wellness of Canadians, is by continuing to improve the system so we can be there for Canadians.
We know there's a famous expression, in every crisis lies opportunity. So before we go to the audience questions, I want to ask each of you really quickly, in this crisis that's happening, tariffs, US dismantling its healthcare, what's the one opportunity, the one bit of hope that you're taking from that? And if I could start with Minister Asegwara.
Sure. Yeah, that's a great question. This is a time of, it's very tumultuous, it's stressful, but it is a great time where we're seeing people come together. We're seeing Canadians unified in a way we haven't seen in quite some time. And I think it presents a really unique and important opportunity for us to embrace and champion Canadian values. That is a strong public healthcare system, which we should invest, and our government is doing that, making significant investments in strengthening and protecting. It's a time for us to find ways to strengthen our own domestic capacity on the healthcare side, whether it's procurement and research and innovation. And I think, and we've been doing this in Manitoba, it's an incredibly important opportunity and time for us to talk about our values in healthcare, which is why, we're making huge investments in women's healthcare, being very clear that reproductive rights should be protected and freedom should be protected and enhanced. We're investing in making sure that gender affirming care is there for those who need it, and mature women have access to the healthcare they need. So we have to be unapologetic about our values as Canadians. We have to invest in these areas of healthcare that we know benefit us socially, economically, and certainly improve healthcare outcomes. And we have to make that information and opportunities really visible, because I think that is the way that we not only address some of these growing concerns, but we meaningfully bring people together, welcome them into this conversation, and get things done in a way that strengthen our healthcare systems locally in our own provinces, but certainly nationally across the country.
And Minister Jones, do you see opportunities in this crisis?
Unfortunately, yes. I don't think anybody asked for it, but Ontario and Canada has done really well on the R&D and the clinical trials. We have not done as well on the manufacturing, the next step. In Ontario, in Cambridge, we have a COVID vaccine that is about to be manufactured domestically. Those are the opportunities that we can see. Obviously, with the labor mobility, when you see all of the premiers coming together under the leadership of Premier Ford as head of the Council of Federation, doing that full court press as a unit can be very impactful. And we need to do more of that. The interprovincial barriers, whether they are for mobility or for trade, impact us. And, Premier Fury will say it as well, I'm sure, but we need strong economies to make sure that we can continue to invest in our social services. Our education, our healthcare is impacted when we have a strong economy and when we have a struggling economy. And I think that the focus that all of the leaders, all of the premiers have put on reacting, responding to whatever unprecedented announcement comes from the White House, working together is ultimately going to make a huge difference for ensuring that we're prepared for whatever the next pronouncement is.
And Premier Fury, you've heard the others talking opportunity. How about you?
So as Canadians, I see this as an opportunity to really own the moment and help as a generational moment define our values and who we are as Canadians, unapologetically, perhaps for the first time in a generation. So the national unity and identity and the core values of what make us Canadian is important now, has always been important, but is important to celebrate loudly and more broadly than ever before. That brings with it the conversation of national unity and how strong the country is when we are united. So as Canadians, more broadly, I think that this is the moment to celebrate, this is the moment to own who we are, this is the moment to make sure that no matter what force of threat comes to us, that we have the courage and the resilience and the conviction to resist any threat to those sharp Canadian values. There's no question about that. And I think you're seeing the country come together to own that moment collectively like I've never experienced in my life. From a systems perspective, I think that this moment of disruption affords us the opportunity to break down the silos. Realistically, as we all know, the healthcare system in Canada, although we talk about it as Canadian, is really 13 different healthcare systems. We had a moment in COVID where I thought that data sharing would be more easily accomplished. I was naive at that portion of my tenure. And there are some obvious barriers. But data sharing in the healthcare system can be incredibly powerful, whether that's in infectious disease or in the system management and procurement itself. And I'd like to think that when we're talking about internal trade barriers and we're talking about this moment of disruption, that could be afforded across the entire country from coast to coast to coast in order to help break down those silos, whether it's on mobility, on data sharing, on procurement. This is the moment where Canada can come together as one united healthcare system.
Great. I think I'm hearing you say you have your elbows up as well.
Indeed.
Great. Dr. Reimer, I think I'll jump right into the audience questions with you. Remember to vote online. You can upvote. I'm skipping one because our American colleagues had to leave, but I want to ask you this one. It seems a very popular question here. What is the obstacle to pan-Canadian licensure?
Yeah, I think there's a lot. Obviously, the people in the room, physicians, have told us they want it. We surveyed physicians, 90% of them said that they want to see that. So it's not a matter of whether or not we see the benefit to it. It's really a matter of prioritizing it and making sure that our colleges are resourced to put that at the forefront. So we need to be making sure that they have the resources to be able to make that move, because right now, they're very focused on getting internationally trained physicians into our system, and that's what we've asked them to do. And so they're trying to create better ways of doing practice-ready assessments. I know in Halifax, they now have a practice-ready assessment clinic where people actually come through and the physicians are there who are trained in how to assess internationally trained physicians. So there's a lot of great solutions there. But while they're so focused on that, it's hard to really open up and think, how are we going to do this other type of system? So what we really need is all the provinces to come together. And so we need the ministers, the premier, all of the premiers to work with the colleges and let them know this is what our expectation is, and we're going to support you to do this, because that's what we need, is to have all of us doing this at the same time. It's very hard for one college to go at it alone.
Good. And if we have a question in the room, I know there are people with mics, so we'll get a mic to you. And in the meantime, I'll ask one more online question. As the U.S. cuts health research funding, including drug discovery, essentially how can Canada fill the void? How can we find more money in our budgets to support research? Maybe Mr. Jones, I'll start with you.
Well, I think continuing to strengthen the public health units is one of them. In Ontario, we very recently last year did a call out to see if there were public health units that wanted to combine, because we found, frankly, during the pandemic that there was not as consistent approach as perhaps we would have hoped for. And some of that was based on the ability for individual health units to be able to deal with everything that was coming at them at rocket speed. So we've done the strengthening piece. I think there is, as always, opportunities for the federal government and the provincial governments to make sure that what we are focusing on, whether it's wastewater testing as an example, we're ready to respond to what is out there and most appropriate. You know, I think of what we're dealing with now with measles, 100% preventable with vaccines, and yet many provinces are now dealing with measles. So having the capacity locally is going to make a difference. Having the ability to share that information quickly across jurisdictions always becomes a way to proactively react and get the information out there quickly, and frankly, lean in to our experts.
And we know the federal government's a big funder of research, the CIHR, NSERC, et cetera, and hopefully we'll hear on the campaign trail some promises to bolster there federally. Now I'm going to go to the room. I can't see very well, but wave at me. Yeah, you got the mic right in the middle here. Yes, member of our military. Thank you.
Hi, good morning. Dr. Scott Malcolm, Canadian Surgeon General. Question for our elected officials. So organizations like the Canadian Medical Association and many others have presented lots of great ideas. The challenge, though, with making any improvements in the system is rarely a lack of ideas, it's the implementation of those ideas. So my question for you, from your perspectives, who do you see as the doers in this system? Because that's where I feel that we're really faced with the challenge, is identifying who the doers are, and I feel that there may be a misperception on who those doers are. So I'd appreciate your comments on who you feel those who should be implementing many of the great ideas that have already been presented. Thank you very much.
So I see some nodding, so I'll go to Minister Asaguara and then Premier Fury. Who are the doers and who should be?
Such a great question, such an important question. You know, ultimately, our government, and I'm, you know, in Manitoba, very fortunate to have a Premier Wab Kinew, who has given me and our entire government the mandate of prioritizing healthcare and getting out there and listening directly to the experts, listening directly to the frontline healthcare workers who provide care at the bedside in Manitoba each and every day. And so we undertook a listening tour right out of the gate. I've been to dozens of sites across the province, in community, in hospitals, personal care homes. I've been to a number of them formally with the Premier, and we go into these spaces and we go there to listen. Our job is to listen to folks who understand healthcare and who have the bright and common sense ideas that we can action. And we've been able to take a lot of action directly based on what folks who understand healthcare in a professional, expert, and everyday way have told us. I'm a former healthcare worker myself. I'm a psychiatric nurse and addiction specialist by training. So being in this role and having an appreciation for what happens on the front lines and the importance of collaboration and working together has been helpful. And certainly, our approach in terms of who are the doers are the people doing it every day in our healthcare system. Those are the folks who have been asking for their voices to be heard and for investments to be made based on what they identify needs to be done. And so we listen to our experts, folks like Dr. Marcia Anderson, Dr. Reimer, Dr. Rusin, many, many other folks in allied health, on the nursing front, on the research front. The doers are there. We just need to give them the opportunity and the space to have their voices heard, treat them as fair and respected partners, and work collaboratively to make the important decisions in our healthcare system. And that reaches beyond Manitoba. So we're listening to experts across the country. We're looking at other jurisdictions, what's working well there. And then we're tasking doers in our own province, in our own communities, to get things done. And we're seeing good outcomes as a result of that.
And Premier Fury, we hear that critique often. We have good ideas, but we're not good at implementing. Is that fair?
I think that's partially fair. First of all, thank you for your service, sir. And thank you for your service to the country, and thank you for your current role. It's one of the reasons why I chose to get into the political realm in the first place. And I've given this the same commentary because it's a very common question that's asked, given the double hats that I wear, the different hats that I wear. And I gave a talk to the Canadian Orthopedic Association just recently and said, our advocacy does not work. All the complaining in the hallways of the hospitals, I mean, we've all experienced it, we all do it. You scream about canceled lists, scream about the wrong decisions made by administration and the management, the emergency department or the outpatient clinic. We all do it. But that's not a formulated approach. You can't take that to an administrator to actually action. So the first thing I would suggest is making sure that the advice is formulated in a comprehensive, actionable way. And I'm not saying that this is not happening. I'm just, when you talk to physicians and different physician groups, sometimes it's just complaints without solution-driven initiatives. So that has to be driven with solutions that are thoughtful and that are easy to understand to decision makers who are often not medical. Because that is incredibly important at the cabinet table and more broadly across the bureaucracy for that matter. The second thing I would say is having physicians in leadership roles is incredibly important. Having medical professionals in leadership roles is incredibly important, whether that's in your hospital administration, your provincial government, or the federal government. That is incredibly important. Or using this advocacy agent like the CMA to enhance and advance your agenda. And the final thing I would say is the decision makers, deputy minister, minister, and premier. And while the federal government has a role to play, their role is a funder. I'm assuming the action items you're talking about are often granular and more specific within the system itself. That is a provincial role. And I'm not saying I would never dismiss or diminish any role of advocacy towards the federal government. If you can get more money out of them, I'll take every penny of it. But the operations of the system, you want to get to the deputy minister, the minister, and the premier. Those are the three key people, and any other ministers, frankly, that would be aligned with your agenda. And it's incredibly important in delivering that message that it be solution-focused and understandable to non-medical professionals. Because that decision many of those decisions will have to be taken as a result of the budgetary process at a cabinet table. And the cabinet should not be all physicians or nurses. It should be a cross-section of society.
And we're lucky today to have a panel of doers. Mr. Jones?
If I can very briefly, the short answer is both. The longer answer is When I became the Minister of Health in Ontario, I issued a ministerial directive to the CPSO and the CNO to quickly assess, review, and ultimately, when appropriate, deal with the backlog of individuals who are waiting for licensures in the province of Ontario. They did that. It was great. Ministerial directive. The next round was actually CPSO coming to us and saying, we have an idea that will expedite internationally trained and educated physicians. I'm all ears. When we did work on scope of practice, those were ideas that were driven outside and brought into the ministry to assess and review. So I think it is a very strong combination of both. You obviously have to have the political will to be able to drive those changes. But if I can stand and say, these are suggestions made by the CMA, then that has a lot of credibility at the cabinet table as we're moving forward those issues.
Great. We're almost out of time, but I see a last question. I see a patient at the back of the room wants to ask a question, so that voice is very important to get in. Please.
Good morning. Thanks very much. My name is Jean, and I am privileged to work with the Patient Voice team from the CMA. My question is about the upcoming 2026 census. How heavily involved will the CMA be in getting additional data and additional information from Canadians across the country with regard to COVID, everything we've been through, all of the exciting events that are happening in the world today?
Dr. Reimer, that all-important question of data again.
Well, I mean, I think it's a great question, and I'll try to be very brief because I know we need to wrap up. We have been trying to collect information about a number of topics. So last year, we went across the country to talk about public and private care and talk to 10,000 Canadians. As we did that to get their perspectives on what they were experiencing in the health system. We survey our members, we survey physicians regularly. We right now have a physician wellness survey that is up, and we want people to be filling that out and telling us about that. Specifically about the census, I actually don't know the answer to that question, but come and find me and we will get you the answer, because that is, as a public health physician, census data is something we use all the time to inform the work and the advice that we're giving to decision makers. And so what our role at the CMA would be is to inform the questions that get asked and how the data gets used. And so I definitely will take that away and talk to the team and try to get you a better answer, because the data is critical to help us make good decisions in healthcare.
And you made the point earlier, what's going on in the US, it makes it all more important that we get our data act together.
Absolutely. Yeah, there's a lot of threats going on, but like you said, there's a lot of opportunity. And I feel optimistic that we can take advantage of this moment in time to make some of those changes that we've been pushing for a long time.
Great. Minister Uzoma Zagwara, Minister Sylvia Jones, Premier Dr. Andrew Furey, Dr. Joss Reimer, thank you very much for being there with us. We obviously could ask you 100 more questions, but on les laisse sur leur fait, as we say in French. Come back for more. There's going to be a great day and a great day tomorrow. Thank you.
Thank you, Andre, Dr. Reimer, and all our guests. If you have thoughts about the panel or questions that did not get answered so far, we invite you to write your observations and questions on the reflection cards at your tables. For our virtual participants, you'll find these virtual cards in the reflection section on the left-hand side of the conference website. We will be collecting cards throughout the day and posting the physical cards on the reflection wall in the interactive exhibit space, which we invite you to visit during the breaks. We'll now take 25-minute breaks. Refreshments are available in the foyer. And in keeping with the patriotic theme of this morning, we have a special treat for all of you. You'll find these elbows-up chocolate bars in baskets as you leave the room. I told you all I'm a foodie this morning. Very excited about those. And if the baskets are empty when you get to them, don't worry, we have more bars and we will be restocking them throughout the day. So I'll see you back here at 11 for our session on Healthcare as an Economic Advantage with Dan Bresnitz and Georgina Black. Cool. So welcome back, everyone. I know there's still people making their way slowly, but we'll get started. I hope you had a good break. I certainly did. Chocolate, maple, and patriotism are three of my favorite flavors, so that was certainly a good time. As we've discussed this morning, Canada is facing a healthcare crisis, but we are also facing an economic crisis as well. Long before the imposition of tariffs and the ongoing threats to make us the 51st state, Canada had a productivity problem. According to the Bank of Canada, not only has Canada not seen any productivity growth in recent years, over the past 4 decades, we've slipped significantly compared to other countries. A healthy economy depends on high productivity and a high-performing health system, and the current environment presents a critical opportunity to do things differently through innovation. Our moderator for this session knows a thing or two about strategy and innovation in healthcare. Georgina Black is Chief Growth and Client Officer at Deloitte, where she serves a team of professionals committed to preparing communities, both in Canada and globally, for a prosperous and sustainable future. A trusted advisor, business leader, entrepreneur, and board member, Georgina is committed to strengthening Canada's healthcare economy through work at the intersection of public and private sectors. She believes that a prosperous Canada requires an ambitious, modern, and accountable healthcare system. Welcome, Georgina.
Great. Thank you, Carl. Thank you, Carl. And in the context of CPD accreditation, I have declared the affiliations projected on this screen. Our next speaker, Dan Brechnitz, brings a unique voice to questions about innovation, economic growth, prosperity, and inequality. As Carl mentioned, we know that high-performing health systems are critical to our well-being and to the well-being of the Canadian economy. I quickly made a note when I heard Dr. Frieden explain that with cutbacks as Americans get sicker, productivity in the United States will drop. Today's topic, this session's topic, is healthcare as an economic advantage. Taking inspiration from the previous panel, will this in fact be our moment to have aspiration and ambition, to change the narrative about healthcare in this country from being a growing budget item, a potential burden to other parts of government budgets? Will we change the narrative to think about healthcare as a really important pillar of our economy? Will we, as the Premier from Newfoundland said, invest so that we can do more research, we can make more contributions to science, to research, to life sciences? As the Deputy Premier said from Ontario, will we use this as a moment to bring manufacturing supplies that we need for our healthcare economy back to the country? This indeed is a unique opportunity to respond to the disruption. Now, I am super excited to have Dan join us. Dan has remarkable experience from other industries. Today, he's going to challenge us to think about what kind of innovation and collaboration, in fact, is required to get us from here to there. Dan is a professor at the University of Toronto, where he also holds the Monk Chair of Innovation Studies and is co-director of the Innovation Policy Lab. He is also a fellow of the Canadian Institute for Advanced Research, where he co-directs the program on innovation, equity, and the future of prosperity. And in his most recent book, Innovation in Real Places, Strategies for Prosperity in an Unforgiving World, he offers pragmatic advice while debunking dangerous myths on innovation, growth, and prosperity. Please join me in welcoming Dan.
When this slide appears, I'll do the ritual. In the concept of CPD accreditation, I have declared the affiliation projected maybe on the screen. Here they are. So first, thank you so much for having me. I think this is a really important subject, and I thought that before we had all the current crisis coming like a perfect storm upon us. So let me try, however, to challenge all of us when we think about innovation, when we think about growth, when we think about our healthcare system. So first of all, let's rethink about what is innovation and why should we even care it's important. So the first mistake that we do is equating innovation with invention. And you see it again and again. There's a wonderful op-ed doing the rounds in policy options, and it does exactly that mistake. Innovation is not invention. Innovation is not only just high-tech gadget, new drugs, new medicine, new toys. It is the action of taking, if invention is the act of coming with an idea, innovation is the act of coming with a proposal action to take that idea and make it into reality. And it's come in the whole process of a production of products and services, from completely new ideas to the world, to making them better, to combining them with others, to figuring the ways in which we do stuff, sell stuff, maintain stuff. As a matter of fact, we're the Canadian Medical Association, and one of the greatest innovations that we gave to the world is evidence-based medicine, not a new drug. And I want you to remember that when we think about innovation in medical care in Canada. It's also important because it's continuous, not because it's breakthrough. The last panel, for example, we had projections of people on those two screens, and it still felt like a real panel. 15 years ago, that would have not been possible. And as a matter of fact, the idea, the first attempt to innovate in teleconferencing is 150 years old. And yet, only in the last few years, especially after COVID, the hundreds of millions of hours and days of engineering power that fixed everything around those systems suddenly make that into a utility that we use every day. And that was when that invention really became an innovation that changed the life of everybody and the way we work. It's also important to remember that if you think about innovation in the economy, there's only two actors, agents that actually do that. Individuals, which we like to call entrepreneurs, and firms, companies, corporation. That is slightly different, of course, in the public health care system. So because innovation-based growth is the only way to achieve a long-term sustained well-being and productivity, and therefore prosperity, worldwide, trillions of dollars have been wasted basically on blindingly copying Silicon Valley model of VC-backed startups. Every city, more or less, in Canada want to be Silicon Valley North. Almost none of them succeed. And even worse, if you look at Silicon Valley itself, this is not the place you actually want to impose on your own community. Massive and rapid and growing inequality and social disruption. So the question is, are there other models? And can innovation-based growth create local prosperity and not just a lot of wealth? And my answer is that yes, but in order to do that, we have to understand how the production of goods and services is now globally fragmented. And what really happened since the 80s, semiconductor, for example, is a wonderful example that everybody knows after COVID. You can look at Tel Aviv, you can look at Silicon Valley, you can look at Seoul, Korea, Taiwan, China, Japan. All of them have extremely successful semiconductor industries. You look at the name of the big companies operated in all of them, and those are the same names, you might think it's the same industry. And yet when we look at actually what they do in those different places, it's as different as can be. In Israel and Silicon Valley, they come up with ideas to put on silicon. As we now all know, there is basically one, maybe 1.5 company that actually know how to take those ideas and make them into integrated circuits, and that's Taiwanese. Everything from a smartphone to a tablet to a computer with a screen you buy, the second highest margin go to a Korean company, even if the name on it is not Korean, because they control specific niches. And none of that would be possible without the massive amount of innovation, constant innovation of working with constantly changing materials and tens of thousands changing components in order to produce something in a price we can buy that happens mostly in China. What is even more interestingly is that as you look at those stages and you realize that you need to have very different institutional system and innovation around them, you will also realize that the distributional outcomes of each one of them is very, very different. And therefore, we have a real choice of where we want to innovate when we want to change a system, and especially if we want to make it into something that creates wealth and prosperity and well-being, and we don't have only one model. So let me make it slightly less abstract by very quickly going through 4 cases. None of them have to do with medicine, but I want you to think about how some of that relates to what happened in your hospitals, in your organizations. So first, there's a stage that everybody knows, and that's a novelty. And I would look at Tel Aviv as the case of the good, the bad, and the plainly sad, and I'm not talking about the last 2 years, which is just tragic beyond belief, but what happened since '67. So in '68, which is the first time the state even did a census of what do they really have, they found out that there's 886 R&D workers with academic education in the whole industrial sector. All of us have been, as undergrads, in a hall where there were more students than that number in any Canadian university. 78 to 86 raging inflation, this is not a spelling mistake. It's more than 100,000. And yet, by 2000, the IT exports, forget the number, from being non-existent, became 71% of all industrial export, and 70% of all GDP growth came just from startups. And since 2000, the largest number of high-tech firms on NASDAQ after the US and China, and as a Canadian, it saddened me to say that, because when I started to do this research, it was after the US and Canada. Canada is gone. And the highest R&D intensity in the world at around 5%. So a massive innovation miracle. And yet, there's a flip side of it. '68, the country was a poor but very equal and relatively healthy social democracy. The second most egalitarian economy in the greater OECD. In 2021, much worse now in 2024, inequality is the most high after one country in the whole OECD. To put it in non-technical terms, 1 of every household or families in Israel currently do not earn enough money to have food on the table at the end of the month. So for 20% or more of a population, the result of this growth miracle is that they don't have enough food. Not exactly what you wish on your own society. And basically, it's because it is a startup nation indeed. There is nothing else that works. So the nerd elite, the pet chefs, some lawyers, some accountants, sorry, and their investors are having the times of their life. But then there is 85% of a population, which is basically running on a treadmill to nowhere. Second stage, which is design, product development, and production engineering, and to remind us that innovation is not just high tech, I went to one of the oldest industry in the world, period, in human history, and that's shoe manufacturing. But we're not talking about regular shoe manufacturing here. We're talking about the highest of the highest luxury female shoes. So no matter what brand it is, if it costs 500, 600 to multiple thousand euros, each of those shoes visited this extremely small place in Italy, in the Veneto, just above Venice, where what they do to shoes is basically what the Taiwanese do to semiconductors. They take those ideas and design and actually made them to shoes. Because I heard that our host is into reality TV. Unlike reality TV, when you design a shoe, 24 hours later, your designer and your shoe producer come up with a shoe. That's wonderful for reality TV, but when somebody actually spend 5,000 euro on a shoe, they might want it to look exactly like the shoe that they saw. They might actually want it to work. There's that thing called sweat and pressure in the human body, and you need to make all of this done. And that's what Brenta did. Even more interestingly, for Canada, Brenta was not always like that. Until the late 80s, the only shoes they manufactured was the shoes you will find unnamed shoes in German retailers. But they realized that the world is changing, that first East Europe and then China are coming. They connected with the high fashion houses in Milano and Paris and basically figure out what they need and then build on their tradition of making shoes to become the place in the world where those designer and shoe manufacturers go to produce their shoes. So very different innovation skills, very different financial institutions, very different education system, very different ways in which we tie themselves to the global economy, massive and much more widespread prosperity, from people who do wooden shoes to people who do additive 3D manufacturing. Stage 3, second generation production component innovation. We all already know about TSMC and how, without inventing any new cool chips, they basically sit like here as a strategic, irreplaceable player in the global semiconductor industry, that even President Trump have to be nice to them and not just frighten them. But the Taiwanese have done it not only in semiconductors, they also have done it in bikes. I don't know how many of you remember, but at least for me as a student, just taking my bike to the second floor room that I shared was a full physical exercise. Now my bikes are lighter than my backpack. And everybody that wants can do mountain biking, where before it was for semi-professional. And the reason is that the Taiwanese did exactly the same thing that they did with semiconductors. They saw a new technology, carbon fiber, which was still mostly for military use in the US, brought it to Taiwan, taught companies how to use it, figure out then how to use it to completely disrupt an old industry by controlling the frames, and exploded and are still there on the world stage. I challenge you to go to a store, buy high-end bicycles, and find a frame which is not made in Taiwan and not made by Giant. And again, massive, different innovational capacities, different institution, different financial institution. There's no VCs here. There was no VCs in Italy. Much widespread prosperity. You have the people you see on the picture, but you also have the most advanced material scientists figuring out how to create new materials. Last but not least, the rise of China. And yes, I know I'm repeating myself, so I won't tell you everything about the different institutions. But if you think about China and you go to a place that really did not exist in the 80s called Shenzhen, which is now one of the most biggest cities in China and definitely the biggest, highest per capita GDP. So a massive prosperity miracle within the great Chinese miracle. You will find out that all the companies that we in the West either respect or fear, from BYD to drones, to Huawei, to ZTE, to mobile, smart mobile, come from Shenzhen, where until very recently there were no universities. And even now, the best universities are definitely not in Shenzhen and Dongguan. What happened there is by really understanding how to produce stuff and then building innovation upon that, Shenzhen has now become one of the hotspots for global innovation in the world across multiple industries, coming from the strength of actually knowing how to produce stuff. Again, no VCs, very different financial institution, very different connection to the global, very, very, very different set of skills that you employ and involved in the innovation system, and much widespread prosperity, and at least as strong and as important and as a critical position in the global economy. So that leads us to several open questions for the seekers of what we do here, which is A, better health, and hopefully some profits or at least positive revenue stream to the Canadian economy. So first, should we rethink what is innovation in our health innovation policies? And not just focus on the next new thing, preferably bought from an American company. And if the aim is to improve health outcomes, and we heard in the panels before, to all Canadians on a sustained and continued basis, how does the multifaceted characteristic of innovation should influence policies in Canada, where at least one premier says that the feds are basically the check givers? I'm not sure I agree with that. And the provinces, because we have such a complex and different array of systems around Canada. And also, how should we think about choice? Meaning what kind of choices we have and what choices we want to have and to where to go. And here, I just want to remind us with a big reality check about where we are. So Canada, the good, we are the most highly educated country in the world. Our university and public institution, including of course our hospital, research output is superior bar none. Bema, we just heard from our host, a GDP per capita growth is sort of keeping up with a G7, apart from the US. Overall productivity growth is just below, but actually trending down. And then we go to the bad. People use business expenditure on R&D, but we can use any proxy you want. And the engagement of our economy, including the health system with new knowledge, has been decreasing each and every year, and it's now on developing levels. So Poland has a higher bird than Canada as of 2 or 3 years ago. Private business engagement, I don't want to talk about hospitals, but it's also the public sector, and we can see that just across the canal, with technology is low and trending lower compared to our peers, apart, and I think that's important, for anyone who actually does exports. Because in exports, you have to deal not just with Canada, but you have to compete with the best. TFP, which is a productivity that is attached or correlated with high innovation and the use of knowledge is actually horrific and might be negative since 2008. And our real median wages are flat since 76. I don't know how many of us were born in 76. I think that in this room, most, but I hardly remember 76 because I just went to first grade. And that leads us with my last 10 seconds to what I want you to leave you with. And that is the importance of vision. The importance of understanding to where we want to go. So I'm not talking about a grand vision or aspiration. I'm not in that part of Ottawa. But I'm talking about a pragmatic one, not just we love to have loads of startup VCs. No, what is a pragmatic vision? Defining what our goals in the health system are, and therefore, what would be a success in 10 or 15 years from now. So if we're successful, how would my hospital, the regional, the provisional health system that I'm involved with, the Canadian one, looks like in 10 or 15 years? Now that we know what we want to achieve, we can reverse engineer and think about how innovation could be a tool in getting there. Instead of claiming we want to be innovative, then figuring out what the hell we mean by that and impose that as a goal to our system. And with that, I'll stop. I'm here to talk and answer questions, but I also really, really, really care about that. So that's my personal email. If, 2 weeks from now you suddenly have a question, just send it.
Terrific. Dan, please join me here. We're going to get into a conversation for a few minutes. But I'd like to invite the audience here in the room and online to send in your questions. And we'll have about a 15-minute Q&A, Dan. I love the inspiration from the other jurisdictions. So you talked about 4 countries. And I think it's fair to say that most of those innovations were in I want to say kind of a free economy, some kind of market model. And just trying to think about how to extract those practices into the Canadian healthcare system, which is a bit of a mixed model, but mostly public pay, public providers with some private pay and some private providers on the outside. And I think it's fair to describe all of that as an uneasy relationship. And so with that as a frame, what inspiration or encouragements can you give us from what you've seen in other jurisdictions? Does it matter that we have this unique model?
So it does matter that we have this model. It is not that unique, meaning we think it's unique. It's definitely unique in the way it evolved. What is unique is that each province is quite different. But there are models in which it's one pay, mostly public, with a mix of private. And some of them are more effective. And they're more effective in 2 ways. Maybe we can achieve both, maybe not, but they're more effective in producing innovation and producing what you call market goals, so a very strong health industry. And the other are more effective by one thing that I think we should all care about, and that is much better healthcare to the individuals in those countries. We somehow constantly compare ourselves to the US. I don't understand why. The lessons we should learn are from Israel, from Finland, from Denmark, Switzerland, if we actually want to also have one of the world's most successful health industry, which does not look only on new drugs and new medical equipment.
You've talked about some of the conditions that need to exist for innovation. You've talked about, I think, ambition. You also talked about policy. So what would you say that Canada really needs to address to create the conditions for more innovation?
So first, but there's the general question, which you have been really, really bad at. We have and are losing innovators to the US on a regular basis. And the reason is that it's extremely difficult to create and build a company in Canada, in almost every business. Not only that, it is much easier to do it in the US, and the market is much bigger, and the investors are much bigger. And that was true, always. What is interesting that until around 1996, 2001, we were actually trending up. And only after that, surprise, surprise, this is more or less the time of NAFTA, we start trending down. Which might mean that the fact that our supposedly partners and friends to the south are now behaving in, I don't want to call crazy, but basically random ways, which make it much more difficult and less appealing, but also have negative impact for us, means that if we finally figure out all those things that we have known for years, making Canadian public institution by Canadian, letting Canadian, including Canadian hospital, make themselves into a playground for Canadian companies, from toilet papers to the end new drugs and new software. We already had at least one discussion about the fact that a doctor that moved between province to province, a product that moved between province and provinces. I have friends that tried to open a company in Canada, and after they all moved to the US because it was harder to sell into all of Canada than to the whole of the United States. So those are things that we need to do on the federal and provincial level. Yeah. But our hospitals also need to start to understand that innovation is not just the commercialization of a research. So here's an example. How many of you in the crowd, I can't see you, but I'll try, use Epic? I see quite a lot of hands. Can you think about how much money Epic will now get per year from your organization? And now multiply it throughout all the organization in the Canadian health system. And then think about who owns Epic and for how long that was an open question and a problem that could have asked for solutions. And now think about what Epic has in terms of the data, not just the medical data, but the very specific and granular data on how you run your hospitals. Who has access to it? Who has control? Who can learn how to run the hospital better? Is it an American company? Is it you? Is it accessible to Canadian entrepreneurs? Even if it's accessible to Canadian entrepreneurs, now that you have Epic, do they have any chance whatsoever to actually sell you anything? And this is just one example.
So Dan, if it's true that if we believe that healthcare is an economic advantage for a country, and if that's our ambition here in Canada, what advice would you give to the incoming leaders?
I will give the advice that I have been trying to give for a few years, and that is to look at healthcare as the complete healthcare.
As a complete?
As the complete healthcare. So if you look at, we talked about COVID throughout the day. If you look at the vaccines for COVID, and you would start looking at the companies that actually not only made large and sustained profits out of it, but also created a huge amount of jobs for people who are not only with a PhD, you will end up with a lot of Swiss companies, you will end up with specialized glass producers who got money from the American government to do that in Alabama. And one wonders why Canada, who actually has so much knowledge in tailor medication, which is now an art, and in a whole array of technologies to produce drugs that are not yet controlled by multinationals, instead of just thinking about the drugs themselves, does not try to become the Taiwan or the Switzerland of the medical world. Why don't we have a national strategy? Why don't we even have a discussion about that? I know that my province, Ontario, has tried to do that, but it was one attempt with one group of civil service. I'm not sure any other provinces even heard about that. And even that had to be done with a Korean company because nobody else in Canada was willing to be involved.
We've got some questions coming in, Dan, from the audience here. Of the many, one of the many challenges we face in healthcare innovation is our addiction to pilot projects. A little laughter from the audience there. What will it take, in your opinion, to shift our culture to one where we'd be more willing to try and fail at pace to drive system improvement?
So I think our addiction is to pilot projects, but we forgot what pilot projects are all about.
Yeah.
So pilot project is to experiment. And if experiment goes well, you should scale it up. If experiment fails, you stop it, learn, and then try again. We have not scaled up. We do not really have plans of how or method of how to scale up. And we are addicted to constantly doing experiment without doing the most important thing from an experiment, and that is actually learning. I do not, working for the government, I do not think that the federal government will help us at all in this. So I think if anyone in this room or hearing us have a power to at least start the scale up in their own organization when they do a pilot, or to shut pilots that don't work down, you should start doing it, because nobody else is going to come help you or tell you to do that. So unless we all change our behavior, we'll do a lot of pilots. Interesting results will be moved to a different country, and they will have a wonderful new company out there.
I was with a healthcare executive yesterday describing what I think is a great innovation, leveraging Gen AI. There's an avatar, it's reduced hospital readmissions, improved experience, saved money, all sorts of things. And the conversation was, why don't we scale this? And that jurisdiction is very focused on, well, it's here if you want it, but come and get it. And the reaction from the others is, well, I'm going to do my own. So yes, that resonated too. Okay, back to the questions. You touched on this a little bit, but this is, I think, really important for us here in Canada, and that's that reconciling private innovation in a publicly funded system. And so there is an uneasy relationship between the private sector and public sector. And I think we probably all know people or companies who, like your friend, have started something in Canada and just found it too hard because of our Byzantine procurement guidelines. And they go to the US. So what should we do to get a different outcome here with reconciling or marrying up private innovation in a publicly funded system?
So there's two options. There's the ideal. And the ideal is that the federal and provincial government actually change the way they do procurement and put into procurement at least the ideals over aspiration, that it should help Canadian companies. If you're a Canadian company, it's much easier for you to try new things and to solve, and you don't have to go through all the jumps. It is not, it should not be counted as very short-term cost effective, because then each and every time the Canadian company will lose. But long-term for our medical system and for Canada, it will actually cost a lot more. That's ideal. I will not bet my house on it. So instead, I would start doing it at the levels with the people that are, yes, CMA should demand it from the provinces and the federal, but CMA members should just try to do what they can, pushing the laws and actually being brave in doing that internally. Knowing the Canadian government now from within, if you're successful, a minister will appear, claim that it was their idea all along, kiss you and move on. But they will never allow you to do that beforehand.
Yeah. Oh, there's a question over here. Terrific. Thank you.
Michelle Penny, Treaty 4. I just wanted to know, what about our medical system between borders? There's nothing that matches any province across Canada. So how does this innovation work if every province has a different set of rules?
I fully agree. No, I'm serious. This is not cynical. We have a structural problem. I would strongly urge, if it was in my power, that especially in the current circumstances, our elected officials at the provincial level, which talked so nicely only an hour ago, actually do something about it and create some standards of making it easier to move ideas, processes, new ways of doing things, and people who learned a lot of years in order to actually help people across the borders in Canada. It's ridiculous. I understand, I was trained as a political scientist. I understand the political deal that was done 150 years ago, but the world has changed. And if we want to keep on being successful, we have to just break this down. It's ridiculous.
I've felt quite inspired by the Canadian panelists Andre had earlier, and maybe this will be the moment to do that. Thank you for the question. There's another one at the back of the room.
Mike, there we go. Hello, my name is Leah Stevenson. I'm a caregiver representative working as a strategic lead for All-Can Canada on earlier cancer diagnoses. What roles do you see, if any, for patients and caregivers in promoting greater innovation in Canadian healthcare as the primary users of the healthcare system?
So, first of all, you look throughout all healthcare systems around the world, and their role is extremely important. We all see heartfelt movies about very few attempts, which became headline news, but it's happened daily. It is part of what, in technical term, in academia, it's called user-based, or now more politically correct, it's called household-based innovation. And all the research have shown that in medical, especially now, with the ability to use the internet to share information across groups of users, as you call them, which otherwise wouldn't have met or feel very isolated, it is crucial. Some countries not only understand that this is crucial, but at least try to have policies on how to make it even better. I was involved in an attempt to do that in Finland, which also looked at how Denmark is doing it. And that involves both educating the users of how to do that, but also in the hospitals, they put in Denmark, for example, anthropologists whose training was to translate the needs and the ideas of patients who otherwise had very difficult time communicating with the doctors and the nurses or the producers of what they need, want, and think are. I have not seen, and it might be only me because I have not done this research in a hospital in Canada, I have not seen any attempt to even think about that in Canada. And I think it is something that we should do. A, educate users of how they can be more effective, coming up with innovation and sharing them, but also how do we create a translational facilities in our hospitals and research institutions and biomedical companies that actually understand what the users want, their ideas, and how to put it in the product.
And just to pick up on that point, we often talk about the power of the patient, the power of the caregiver, the power of the consumer. And so many people, not everyone, but so many people are becoming much more health literate. I mean, just think about during the COVID, we were all able to name the vaccines and how they were manufactured. So can you see almost could the consumer, the patient, the caregiver, and also the health professional, the doctors, the nurses, PSWs, et cetera, could they actually create a tipping point for innovation? Because many of the questions I didn't get to talk about really the government, the payer, being a bit of the barrier to innovation. It's unusual for government in Canada to innovate in the way that we're talking about. So is there a glimmer of hope if we all kind of rise up?
I would go further. The only glimmer of hope is if we all rise up. But it's not just the patients. It should be us. It should be nurses. It should be doctors. It should be people who run the hospitals. And there might be no tomorrow, to be very honest. The world, for both good and bad. So A, we already heard about how bad it can be. But right now, the whole world and our other partners, not just the US, is looking for solutions. And if we figure out A, what we want, and B, how can we give them something that they might want, suddenly we have new markets both internally and externally, that even if we had that ideas 2 years ago, we had zero chance of making them happen.
Yeah. What a great way to bring this session to a close. Thank you for sharing your research, your inspiration with us. It's a terrific discussion.
Thank you so much.
So I want to share a big thank you to Georgina Black and Dan Bresnitz one more time.
Hi and welcome. Bonjour et bienvenue à tous. My name is Kate and I'm joining you live from the Rogers Conference Centre here in Ottawa for Canadian Medical Association's 2025 Health Summit. I will be your virtual host for the next 2 days, and joining me online are my CMA colleagues Nick and Savani, who will be moderating the chat. So if you haven't yet already, please familiarize yourself with the conference website and app. I'm going to take you through a few of the functions that we'll be working with together over the next couple of days. So on the left-hand side of the conference website, you will see there are several tabs. Those tabs, many are self-explanatory, but there are a few I want to bring your attention to. So the chat function is really where you can share your ideas and comments, but we would ask you to please post your questions in the Q&A section. That's where they'll be able to be upvoted. So just keep in mind that any questions posted in the chat function won't be answered. The other tab that I want to bring your attention to is called the Reflections tab, and this is our community space. So while the participants in the room are having their table discussions, we're going to be able to talk to each other in the Reflections section, and this is where we would like to draw your attention to now. So we just heard an amazing conversation about innovation, the Canadian context, and how healthcare can really support and lift on our economy. It's now over to you to take a few moments to go to the Reflections tab and add in any insights, comments, ideas that you have, and we'll come back and review them after together. One quick comment, when you go into the Reflections tab, you'll be able to write your response. These are anonymous, so please go ahead and submit as many as you like, and then you can hit next question, and you'll be able to see the results of the other people who are in that community space with you. So take a few moments and add your reflections there. What's the timer right now? Then in 2 minutes, let me know. Good. Welcome back. Thank you so much for participating in the discussion. I'm going to read a couple of responses that we've received over the last couple of minutes. Health Canada is a major barrier to innovation as they are slow to approve things and highly inconsistent in their decisions. the inertia needed to overcome and foster an innovative environment in healthcare. One of the most interesting things that they were talking about here is innovation, not just commercialization of research. Let's be innovative with a new pan-Canadian licensure model, new virtual health opportunities. It was interesting to hear about the use of an anthropologist translating patient voices. That innovation in healthcare can lift and support the Canadian economy. And one last one here, it would be ideal to have a new Canadian developed and operated EMR that we use Canada-wide for sharing of healthcare information when people travel and receive care in different provinces. So many great responses and ideas here. Thank you for those who've been able to jump on and share. Please continue to do that throughout the course of the day. This will remain open and you can absolutely continue the conversations in the chat function.
So thanks everyone for sharing your thoughts at your tables. This is all the time we had for this piece. And welcome back to the people joining us online. So we're going to go straight into our next session, which is the first of our speed talk before breaking for lunch at 12:30. If you're comfortable sharing the comments on your cards, we'd invite you to add them to the reflection wall in the interactive exhibit space during the break. So we all have personal stories about why health matters. I know I could personally talk to you for hours about my grandmother's battle with dementia, about my dad's admission for a hypertensive emergency in his early 40s that basically changed the course of his health, or about my own experience in the trauma bay after a car accident when I was 18. But what if we could actually do something to improve the future of healthcare? If you held the purse strings when it comes to funding health reform, where would you spend the money? For what would you advocate? Each of the next 4 speakers have roughly 5 minutes to share their personal reflections on a part of the healthcare system where they'd like to see change. So we have Dr. Elisa Levi, who is a practicing family physician on the traditional territory of the Saugeen and Ojibwe Nation, who's committed to advancing the health and well-being of her clients by integrating place-based principles to enhance patient care. Next, we have Ambe Chinemu, who is a member of the CMA Patient Voice. He's an advocate for the healthcare needs of people in the Northwest Territories and understands the gaps in services in the North due to his own lived experience. We also have Dr. If you want to clap, we'll wait until the end. Thank you. We also have Dr. Ashley Miller, who's joining us virtually from Mexico, who's an academic general internist, virtual care advocate, and passionate champion for digitally enabled healthcare transformation, especially when it comes to accessing specialty care. Finally, we have William Gagnon, who's a building engineer who's found his passion helping healthcare leaders decarbonize their vehicles, practices, and facilities in a sustainable way. As you hear their reflections, please think about where you would invest in healthcare if you had the opportunity. We'll come back to you at the end of the session. So now I'll ask Elisa to start us off.
Just waiting. So good morning, everyone. My name is Dr. Elisa Levi, and I'm a new family physician concluding my first year of practice. I began my medical journey in 2018, actually. I chose to change careers at mid-career level and retrain as a family physician with the goal of practicing in an underserviced area. In a community, I knew the community I was going to practice in, a community that holds deep significance for me. The Bruce Peninsula, I don't know if anybody's aware of the area, it has very beautiful turquoise waters, rolling cliffs, wildflowers, perfect for hiking, and it's surrounded by Georgian Bay to the east and Lake Huron to the west. Beyond its beauty, though, lies a painful truth. This is the land where my maternal grandmother and great-grandparents were forced to reside as a result of Canada's reserve system and Canada's Indian Act. My thoughts, though, is that I would return to an area and healthcare would welcome practicing in your own community, in a First Nations community. It's what the TRC has called for. A First Nations trained physician wanting to serve in an underserviced area. Call to action number 23, just to remind you, we call upon all levels of government to increase the number of Indigenous physicians working in healthcare and to also ensure the retention of Indigenous health providers in their communities. Instead, it hasn't been smooth sailing, though I would say, you know, I am practicing. As I said, I'm concluding my first year of practice. There are no dedicated funding structures to support family medicine practices, specifically in First Nations communities. That's what I'm speaking about. Certainly 2 neighboring towns have models that I could have joined. And there is also fee-for-service, but my population is too small for that. Furthermore, there's no infrastructure, and that's what I want to speak about in capital for primary care practices in communities. But these barriers asked me to, you know, think more about connection. Like, what does it mean to connect with patients and the places that we provide healing and care? What do those places look like? And what does it mean to reimagine the places where we heal? So walk into most exam rooms, clinical exam rooms, and we see fluorescent lighting, we see white walls, stark walls. Actually, my daughter recently, we went to our own family physician and she said, "Mom, you know what really annoys me about this room is all the tape that's fallen off of these posters and these ripped posters," which was kind of funny. Stiff chairs, that's what we see. And, but what we don't see is, you know, what's available. So I told you about that place where my grandparents were forced to be. It is an absolutely beautiful place. And that's what I think about, and think about that healing potential of that place. So I have been thinking about that and trying to think about my own training and many of the experiences that I've felt in the training. There was no, and this is about no space, right? It sounds like when we've been talking about measles, we've been talking about you know, tariffs and all of that. It does really always bring me back to connection and that human connection in healthcare. So we expect connection in places that feel cold. We ask our patients to trust us in environments that are alienated. And why does that matter even more for Indigenous patients? For Indigenous patients, healthcare spaces were never designed for us. They have been places of exclusion, harm, and disconnection. These are the same institutional places, the same cold rooms where the people I'm serving were denied access to care, told that our ways of knowing were not valid. And today the consequences persist: deep-seated mistrust, avoidance of care. And this kind of sits with me because as I you know, go into a room in a full clinical day and I'm in a room and there's nothing there, it's, you know, it gets heavy. So it's not just about the past. You know, I'm someone who's very future-oriented. There is evidence that space matters. Studies have documented that rooms with natural light improve healing after surgical interventions. Physician burnout has been documented to improve in spaces that promote this. And biophilic design lowers cortisol, reduces anxiety, improves cardiovascular health. Despite this, though, most physicians, especially those starting out, join or build practices that don't take into consideration space and the healing spaces. Also, you know, we tend to look sometimes at Indigenous healthcare as, you know, what's missing or, you know, what we need to fix rather than leveraging what we know about healing spaces. So as a new physician, I want to practice in a space that evokes a sense of cohesion of mind, body, and spirit. So if I held the purse strings at this time in my life, I wouldn't build another cold, institutionalized clinic. I would build place-based healthcare, a space where nature is medicine, exam rooms with views of trees, windows, I would say, not blank, stark walls. Community-based healing happens beside fire lodges, gardens, gathering places, and culture safety is built into the care, which I think many people would agree in this room. So this isn't an alternative care. It's not something that's out of expectations, and it benefits more than just Indigenous peoples. The impact can be on patients, especially care providers, physicians, and also just a general shift in medicine. So Nungwa means today in Anishinaabewan, and that's a, I thought that was a special kind of thing to think about starting today. And today I would invest in and build spaces that reconsider and take healing first. So thank you.
Hello everyone, my name is Ambe Chenemu. I'm originally from Cameroon. I moved to Canada in 2012, and I now live in Yellowknife in the Northwest Territories. So my presentation today would be about access to healthcare, the challenges to access healthcare in a remote community. I'm going to talk about some solutions and also the right kind of access. It's incredibly difficult when you live in a remote community to be able to find access to a doctor. I'm just waiting on the next couple of slides, which will show you an area photo of the next one. Yeah, so that is an area photo of Inuvik. Inuvik is in the Beaufort Delta in the Northwest Territories, has a population of about 3,000 people, and the regional hospital in Inuvik serves about 8 communities, and of those 8 communities, only 4 are accessible by road, the other 4 are accessible only by air. So last year, birthing services got suspended at the Inuvik Regional Hospital because of staffing shortages. So anyone trying to access those services got moved to Yellowknife, which is the territorial hospital. And then birthing services again got suspended in Yellowknife because of staffing shortages. So everyone, including those from Inuvik, got moved down to Edmonton. And this is just one example to show you how challenging it is to access even the most basic healthcare in a remote community. This next slide shows you a little bit of the burden of travel for some of us who live in remote communities, how far we have to go just to access any kind of healthcare. Sometimes you're waiting months, if not years, just to get access. And during those wait times, your condition keeps deteriorating, or in some unfortunate cases, you end up losing your own life. So it's quite critical. For example, I got diagnosed with toxoplasmosis a few years ago, and I lost vision on my right eye. And so I've had to make several trips down. I live in Yellowknife, down to Edmonton a couple of times a year just to get just the basic care to make sure that I do not lose sight on my only good remaining eye. And this is for someone that lives in Yellowknife. Imagine if you lived in Inuvik, if you lived in Pollock, Sax Harbor, where you only have access by air. It is an incredibly dire situation. So I probably haven't had a doctor for about 5 years now, and I live in Yellowknife. I've had to access the emergency last year about 4 times just to see a doctor, and this is taking away resources from people who actually need to be in the emergency room. This is a picture of people waiting to evacuate the wildfires from 2023 in Yellowknife, and I found it as a metaphor just to give you a picture of how long it takes just to wait to get access to see or just to get access to primary care. So what are some solutions? There's a growing immigrant population in Canada, but we're not seeing that representation into med school. So the recruitment processes, how people get into med school, that representation needs to reflect the population that we're dealing with. I know Health Canada has been collecting immigrant data for about 3 decades now. We're not seeing that representation within the healthcare system. My wife is a practicing medical doctor, not here, but in Cameroon, and I've had to call her many times just to get simple diagnosis for something which I went to the hospital, I got diagnosed, got a prescription, did not work. I had to call my wife, who is back in Cameroon, to prescribe something for me. So again, we need to see some of that representation within the system. So team care, that's great. That's where the healthcare system is moving towards. That's awesome. But what is more important, though, is to make sure that who is part of that team? Is that team serving, does it represent the population that you're serving? Foreign trained doctors, my wife moving to Canada, it will take her probably 5 years or more if she's lucky enough to get into healthcare system. She's well practiced over Africa, has worked for very reputable organizations, but there's a good chance she will never make it through the system. It's a huge loss for my family, for my wife who really wants to practice, but it's incredibly a big loss for the Canadian healthcare system. So we need to fast track these processes and stop creating bottlenecks that are unnecessary. So telehealth is important, especially for us that are in remote communities. It really bridges that infrastructure gap. But for someone like me, I find that I need to trust who is on the other side of that conversation to make sure that they really understand where I'm coming from, they know me as a person or just my cultural background, to be able to trust that I'm getting the right kind of care. So it's not just telehealth as a new thing that we need to get into, but we need to find ways to incorporate that diversity so that we're talking to people on the other side that also look like us. So what is the right kind of access? In my opinion, it needs to be culturally appropriate. It needs to be absent of shame. It needs to be absent of fear. When I access a doctor, when I walk into a dispensary, into a clinic, I need to feel comfortable within the system. I need to feel that I trust who I'm talking to. I need to feel that the person that is having that interaction with me understands some of the nuances of my culture. Just like when I pick up the phone and I call my wife, she gets it. She's seen patients like me, thousands of them. So I don't need to explain myself a million times just to get to a solution. I don't need to question the diagnosis. I don't need to question the treatment. I don't need a third, fourth, fifth opinion. I just trust that when she tells me something, it's the right kind of care. So for me, it has to be 100% trust. And that trust can only be built with the kind of representation that we have in Canada. Thank you very much.
Thank you. Hello, my name is Ashley Miller. I'm a general internal medicine specialist in Halifax. In the context of CPD accreditation, I've declared the affiliations projected on the screen. The other speakers today have highlighted the critical importance of supporting primary care. Most Canadians will also need to access specialty care at some point in their lives. As a specialist physician who routinely manages referrals, I witnessed firsthand how challenging and administratively burdensome it is for both primary care providers and patients to navigate specialty care. When I first began my career as an attending, our ambulatory clinic had wait times of over a year. This is actually not that surprising given the current complexity of specialty care access. Referring providers need to know who and where to refer patients for problems that they may have had limited prior experience managing. Although some jurisdictions keep lists of specialists with contact information, most referrals are still based on the provider's own knowledge of and relationships with local specialists. Once they figure out, correctly or incorrectly, who to refer to and how to reach them, providers must navigate onerous referral processes, often requiring multiple different forms. Once a referral is received, amazingly today, still most often via a faxed piece of paper, there's generally a lack of communication regarding that referral. Lost faxes and incorrect routing are common, and patients and providers are often left in the dark regarding the status and wait times associated with that referral. Each step of this process is wrought with the potential for error, burden, and inefficiency, ultimately culminating in provider burnout. In my own clinic, almost 10% of the referrals we received were inappropriately sent to us. Sometimes this was just because the patient lived outside of our catchment area, but it was also commonly related to issues completely out of our scope. Problems such as hernias intended for general surgery were accidentally sent to general internal medicine. Really an understandable error when the task of sending a referral might constitute just one of dozens of clicks in an EMR that a busy provider has to make in the course of a day. Of those referrals appropriately routed to us, almost 40% could have been safely managed via alternative care pathways, not requiring patients to wait, travel, and fight for parking in our busy downtown location. Addressing these kinds of issues made a huge difference. The wait times in our clinic dropped to less than 2 months. But that success was only on the scale of a single clinic, and even that was unsustainable without dedicated supports and adequate resourcing. Like our efforts, many existing initiatives exist in Canada seeking to address the complex maze that is specialty care access. These include things like e-referral, where all of the processes associated with specialty referral are digitized, e-consult, where providers can access specialty advice via an asynchronous digital platform so that the patient doesn't have to wait for an appointment, and central intake, where a group of specialists in the same field receive referrals via a single pooled queue. But none of these solutions address the underlying problem of the burden on the primary care provider to know who and where to best direct their question in the first place. If I held the purse strings for healthcare, I would invest in fundamentally reshaping specialty care by introducing a single door entry for all specialty referrals. Referring providers would need to do nothing more than articulate the clinical question or need, and the centralized system would do the rest. This single point of access would be responsible not only for optimally directing referrals, but it could also be held accountable for critical quality metrics such as wait times. This would require that all specialty care exist under centralized regional organizations with a single door entry by geography. To manage the immense volumes of specialty referrals, we need to re-envision conventional specialty and provider-based silos and challenge specialists to function as an actual system. This is a massive undertaking, but it's worthwhile. Not only would it reduce the administrative burden associated with specialty referral, but it would also significantly benefit patients by improving access to timely and appropriate specialty care. At present, wait times are unacceptable. While e-referral, e-consult, and central intake have all already been shown to improve wait times and patient satisfaction, realigning specialty care to a single point of entry would have a far greater positive impact on access and timeliness than any of these interventions alone. So, how do we get there? This fundamental reorganization will require an enormous will for change. It will require people power to manage centralized intake and referral administration, shifting the burden from primary care providers to an organized and adequately supported specialty system. Now more than ever, this vision of a single point of entry is possible, given rapidly evolving technologic innovation. AI triage can leverage big data and machine learning to optimally route referrals. And you know what? This is an area where we can afford to take some risk, given our current failures when it comes to specialty care access. Ultimately, the immense potential benefits to both providers and patients justify a little bit of disruption. Thanks so much.
So it was a Monday in August 2023. I was standing in my laundry room clutching an empty Canadian Tire plastic bin, and I was repeating to myself, evacuation kit, evacuation kit, evacuation kit. I didn't know what to put in it, and I didn't know for how long we'd be gone, and I honestly never thought we would evacuate. Je m'appelle William Gagnon, je suis ingénieur en bâtiment.
I'm William Gagnon. I work on decarbonizing the health system. You've seen my affiliations on the screen.
What I would do to keep us safe and keep our healthcare systems running in the face of climate change if I held the purse strings of the healthcare system. So I wasn't the only one to be caught off guard. The Stanton Hospital in Yellowknife had to evacuate a 100-bed hospital on a 48-hour turnaround on military planes. Climate change is expensive. Adaptation is crucial, but we need to mitigate healthcare emissions. Healthcare is 5% of global emissions, and so that's double shipping and aviation combined, and it's also 10% of our global economy, so it's a huge player. And doctors have the most trusted voices out there, and so you guys hold power, an immense power in the fight against climate change. This is the Kutek Puat Hospital, one of the greenest hospitals in the world in Singapore, where I was working last year. And so Singapore now has a massive, coordinated, climate-ready national system. The UK also has a massive, coordinated national plan for climate change. And in fact, 80 countries committed to doing that. Canada is one of them. We're not coordinated just yet. Last year, the deans of Canada's medical schools passed unanimously a roadmap for the implementation of the Declaration on Planetary Health. This is something that was led by my friend and superstar here, Dr. Courtney Howard, to move us closer to a sustainable healthcare system. So to do that, we need better structures. So we need sustainable healthcare secretariats in the country. And to do that, Dr. Howard and I are starting an organization called Planetary Health Organizations for Wellbeing, Equity, and Regeneration, POWER for short. We're working with the Association of Faculties of Medicine of Canada, and we're grateful to be funded by the Trottier Family Foundation. So there's anecdotes from the UK showing that anesthetists chose a lower paying job in a hospital that had a climate action plan instead of a higher paying job in a hospital that did not. And there's a ton of climate and healthcare solutions out there. This is a low-hanging peach tree put together by Dr. Miles Sargent at the Canadian Coalition for Green Healthcare and his colleagues. So in order to implement those solutions, what we need is overarching structures to give us a policy, budget, and plan. We have a federal sustainable healthcare secretariat, but now what we need is provincial and territorial sustainable healthcare secretariats. Ce qu'on a besoin, c'est des secrétariats pour des soins.
We need those secretariats at the federal, provincial, and territorial level.
Remember that Monday in August 2023, and I was in my laundry room holding my Canadian Tire plastic bin. My friend Ty, he's an emerge doc, and he barges into my house and he says, "Will, get in the car." And we do like what every single Canadian in distress would do. We drove to Canadian Tire. And we bought hoses and water pumps and battery packs, and we evacuated. And seeing all the volunteers and firefighters come together, although it was traumatic, it was still it gave me a lot of hope, and that was really inspiring to see all these people working together. And that kind of felt like my first win in the race against climate change. And so winning is addictive. A win brings a win, and the wins bring more resources and more power. And this is what political scientists call bandwagoning. But if I held the purse strings of the healthcare system, si j'étais en charge des cordons de la bourse de notre système de santé, I would organize.
If I held the purse string.
Our second win would be a little bit less dramatic than the evacuation, and I would organize a desflurane phase out. So desflurane is a super polluting anesthetic gas. And I know from our MC that he's not using it anymore. England and Scotland are not using it. And in fact, the Canadian Anesthesiology Society recommends against its use. There's a ton of inspiring doctors in Canada working on this, Dr. Anita Rao and Dr. Stephen Williams. A couple months ago, Newfoundland Labrador came out and said, "We are the first province to phase out desflurane." And then 3 days later, Northwest Territories came out and said, "We are the first territory to phase out desflurane." So I think there's a ton of positive energy around those climate solutions that can be implemented. And I know I'm standing between you and lunch here, but instead of the hot potato of emissions, the responsibility of emissions being tossed around between the climate and Environment Ministries, what we need to do is to create sustainable healthcare secretariats. Ce qu'on a besoin de faire, c'est de créer des secrétariats pour des soins de santé durables. Because I can tell you that it really sucks to not know if your house is going to burn down or if your hospital is going to have to be evacuated. And of all the great talks that we've heard so far at this conference, I think nothing matters if we don't have a national plan for a coordinated healthcare system that can keep running in the face of climate change. We need to find a way to link up the good work that physicians are doing on the ground at the bedside to the national and our international commitments. So when I prepared my evacuation kit, I felt ready, and so preparation feels good, but it also does good. And so I'm asking for your help in two things, creating sustainable healthcare secretariats. So the role of the secretariats would be threefold. One, adapt our healthcare systems to climate change. Two, baseline emissions, because emissions hotspot is often where there's wasted resources. And three, produce a decarbonization roadmap. And I think we can do that by starting with desflurane phase out, which will generate good energy and momentum towards sustainable healthcare secretariats. Merci beaucoup.
Merci à tous nos panélistes. Thank you to each of our speakers for sharing their personal perspectives on how to improve healthcare and the benefit for physicians and patients. And I will confirm, I have not used desflurane in close to 10 years. So now we want to share your perspectives with our speakers as well as with the rest of the room. So please grab your phones, go to the mobile event site, and answer the word cloud. If you held the purse strings, where would you invest in healthcare? For our virtual participants, this question should pop up on our screens. So we'll give everyone about a minute to answer. So we see a lot of primary care coming through. Makes a lot of sense given that it's the backbone of our healthcare system. Indigenous health is popping as well as a big theme, which we'll hear more about this afternoon in our Indigenous health panel. So stay tuned for that. I see prevention as well as being one of the big words coming out. Interprovincial collaboration, no doubt inspired by our panel this morning. Preventative health, primary care team, integrating into education systems, surgical waitlist eradication. So we see a little bit of AI and tech, a little bit of all of the talks that we've heard kind of mixed into one. So clearly you've been inspired and energized, hopefully, by all of our speakers, and perhaps you have your own idea that you'll want to push in the future. So now that we've seen everyone's answers, comes one of many exciting sessions in our day, which is lunch. So lunch will be served upstairs in the Trillium Ballroom. For those of you who joined us for breakfast, it's the same exact spot, which is one level up from here. We've got a leisurely 90 minutes for lunch, so we'd love it if you paid a visit to our interactive exhibit space during that time. So once again, thank you to our speakers, and have a great lunch, everyone. Welcome back, everyone. I know some people are still making their way back to their tables, but we will get started. So I hope you all had a good lunch and are ready to go for our next session. 2025 marks the 10th anniversary of the Truth and Reconciliation Commission of Canada's 94 call to action, including 7 health-related calls. It's an opportunity to reflect on the past decade and gauge the advancement of Indigenous health and self-determination. This session focuses on amplifying Indigenous leaders in healthcare who are challenging the status quo to redefine what care looks like for Indigenous people. To a large degree, they are the ones deciding what resources are needed and wanted by their community, be it access to a sweat lodge, a smudging ceremony, or traditional medicines. They are ensuring the voices and perspective of Indigenous patients are accounted for when it comes to developing health research and policy, and are working to guarantee a patient's right to cultural safety. This session will consist of 4 presentations, followed by a moderated panel discussion. The presentation from Jennifer Periquet-Dufresne will be exclusively in French, so please have your headsets ready for simultaneous interpretation. They are available at each table. Please select channel 1 for English. For online participants, if you are already listening in English, you will hear simultaneous interpretation in English, surprising no one. As this is a sensitive topic for many, a reminder that cultural counselor Lisa Dockstader is available at the Indigenous Health display for anyone seeking cultural or emotional support. We also have an Indigenous safe space in room 201 on the level below us, and a separate wellness room in 2D for all patients. I'd now like to introduce our moderator, Juanita Taylor. Juanita Taylor is a senior reporter for CBC News Network, covering the Northwest Territories. She's originally from Arviat, Nunavut. In 2023, Juanita won the Canadian Screen Award for Best National Reporter. She currently works out of Yellowknife. Juanita, you're up. Thank you.
Thank you. Unusakut, good afternoon. Thank you everyone for being here with us to listen to some really great discussions in the next hour. Juanita Uyunga Akve Mutau Gama Nunavut. Hello, my name is Juanita Taylor. I'm from Akve Nunavut. I'm very happy to be here with you this afternoon. I am with the CBC in Yellowknife. I've been there for about 16 years. For the last 3.5 years, we have been a team of 2, a mighty 2 in Yellowknife, telling stories from Nunavut, the Northwest Territories, and Yukon to a national level. And we have covered stories about Indigenous people doing amazing things and overcoming challenges. And I think the one thing that I always take away after telling stories from the North is that Inuit, Métis, First Nations are so resilient. You can put anything in front of them and they will deal with it in the best way that they can in many circumstances that a lot of people in other parts of the country can't even imagine. So I acknowledge all the participants here over the next couple of days who are also recounting their stories and making a contribution to health in Canada, because it's so important to have healthy communities and healthy people to ensure that the future of our Indigenous peoples carries on. So thank you so much for having me this afternoon. Thank you. Sorry, I'm just waiting for the CO1 slide. Thank you. In the context of CPD accreditation, I have declared the affiliations projected on the screen. So we have some amazing guests with us this afternoon, which is why you are all here to learn from them and to hear what they have to say, and hopefully to be able to become inspired to do the things that you do. They are leading the way on Indigenous self-determination in communities across this country, and they have so much to teach us, which we will soon learn more about. Dr. Michael Dumont is an Anishinaabe family physician and member of Shawniga First Nation, now making his home in Vancouver on the unceded territory of the Musqueam, Squamish, and Tsleil-Waututh peoples. He is the medical director of Luma Medical Center. Amazing, amazing. You will learn more about that. A team-based Indigenous primary care center that integrates traditional Indigenous and Western medical approaches to health and healing. you for being here. Trina Wansundeo Delormier is Mohawk from the Ganawage Mohawk Territory, south of Montreal. She is a principal investigator at Dahagi Gunsunduje Quebec Network Environment for Indigenous Health Research and is strongly committed to enhancing the capacity of researchers and institutions to do research that respects the self-determination and knowledge systems of Indigenous peoples. Welcome, Trina. Dungasugit. Atikamekw Nehirowiskwe from Manawan, Quebec, Jennifer Petitquet Dufresne is the Executive Director of Joyce's Principal Office. The organization is responsible for promoting and carrying out projects in line with the principal's objectives of equitable access without any discrimination to all social and health services. The death of Joyce Echaquan in September 2020 sparked the creation of Joyce's Principal. Jennifer, are you coming out? Come on out. Here she is. Give her another round of applause, please. Welcome, Jennifer. Thank you. Dr. Brent Young is an Anishinaabe and a member of the Sandy Bay First Nation. He is a family physician and founding clinical lead of Wujay-Winnan Health Center. In 2022, he played a key role in supporting the Mi'kmaq Native Friendship Center in establishing this service for the urban Indigenous community of Halifax. Dungasugit, thank you for coming. And joining Brent Young on the panel is Elder Debbie Asan, a community events planner at the Mi'kmaq Native Friendship Center in Halifax. Welcome, Debbie, Elder Debbie. Before that, Debbie completed a prestigious 36 years with the Canadian Armed Forces. Yes, another round of applause for sure. Yes. Dungasugit, welcome. Thank you all for being here this afternoon. We are now going to move into our presentations, and Mike, I will start with you.
Michael Dumont, Indigenikaz, Shonaga, and Donjiba, Wabajeshi, and Dodem, Khomaskriums, Koomish, Tlewatuth, Ninda, Miigwech, Kitiganzibi, and the Algonquin Anishinaabe Nations. So good afternoon, everyone. Thank you for that wonderful introduction, Juanita. And so I'm Michael Dumont, and I have the honor today to share a little bit about our clinic at Luma Medical Center. So first off, I do have to say, for CPD accreditation purposes, my disclosures were on the screen. There we go. So Luma, I'll share a little bit about our origin story. So Luma started in 2016. It was a big vision and a big dream, but we started from a very humble place. And that building you see there is the headquarters for the Luma Native Housing Society, our parent organization. And Luma has been providing Indigenous families with safe and supportive housing in the urban Vancouver area for almost 45 years now. And it was very much Luma Housing's idea, hearing feedback from community members to build this health center. There was a real call from community for safer access to primary care and for spaces that brought together both Western medical expertise, but our traditional ways of knowing as well, our medicines. And I'll speak a little bit to what that means and how we brought that together. But back in 2016, it was a more humble beginning. So Marcel Swain, our former CEO, and myself, we sat down and we found kinship and partnership in these ideas very quickly for what we wanted to see this space become. And the vision was there, the big vision. But again, at the beginning, it was a much humbler sort of start. So we had enough funding cobbled together to build our space, open the actual clinic, an MOA, and myself. And I started a fee-for-service practice, providing care to my relatives, my urban Indigenous relatives in urban Vancouver. And you can imagine working fee-for-service, working with an urban Indigenous population. It wasn't a great way for me to start my third year of practice and pay off any of my debts and that sort of thing. So we had a little bit of a challenge at the beginning, sort of moving things along. But we kept to that vision, and the principle that we sort of held for ourselves is that we won't compromise in the care. We are going to provide excellent, excellent care to the relatives that we see coming in through our doors. We won't compromise on that. So my visits were half an hour. We were booked at half an hour, and some of them went well over an hour if they needed to. But we weren't going to compromise on that piece, and we were going to demonstrate to our funders, to our would-be funders, that we're going to do this well. And we're going to become so big that we can't fail. And if we do, and if you let us fall, that's going to be on you, and the community is going to come after you for that. So we walked it with that sort of intent. I'm very fortunate to say we've been extremely well supported. And the biggest maybe message to take from this is that the relationships are really what matter in the end. Not just the care relationships, the doctor-patient relationships, but the relationships that we've found with our supportive funders, the health authorities that have supported us, and directly with our Ministry of Health, with our government partners. We've actually found, I think, a really strong partnership that's allowed us to build this out and really realize that vision and that dream of what this was meant to be. So our model, again, very much brings together Western and traditional approaches to care. And I'm happy to say that we did find that partnership directly. So the First Nations Health Authority in BC is our main operational partner. They enable what we do, and we very much have a relationship that supports each other. They lift us up and enable us to build a really like a community-driven model for primary care that meets what our patients need. But at the same time, we're able to support the bigger picture work that the FNHA is doing. It works really well. And the other partnership I want to talk about, I'll come back to a little bit at the end, is with our local primary care network. So we're very fortunate to be part of what's known as the First Nations and Aboriginal Primary Care Network. We have 8 Indigenous owned and operated clinics that operate throughout Coast Salish territory, throughout Metro Vancouver. And we support each other. We advocate on each other's behalf, and we have a collective voice that I think makes us more powerful. So this is our panel of patients that we serve. We have it's a little out of date now, I think we are up to about 2,600 patients. But it's an extremely diverse community. You can imagine, I'll talk a little bit about sort of the cultural aspects of what we do. It can be a bit challenging. Whose culture, whose traditions do we follow? Whose protocol do we follow? And we certainly keep ourselves grounded in the territory. Our Coast Salish hosts guide us in terms of the protocols we follow in ceremony, but we're looking after many of our relatives from across Turtle Island. So 96% of our patients that come through the door are Indigenous. We have some non-Indigenous family members that are part of the panel as well, but over 300 nations represented. I think it was 340 on our last count. So that's over half of the First Nations across Canada. And that's just within our small panel in this little clinic in Vancouver. So we are a very diverse community. And this is what the model became when we had the opportunity to really build those partnerships and actually build this space up to what we meant for it to be. And I'll probably speak a little bit about this after too, but I'm probably the least important person on this team. I have some letters at the end of my name and perhaps some agency and some voice and some power that comes with those. But really I'm there to make sure that the rest of this happens. And it's the elders and the knowledge keepers who really do the important work. They're the ones who our patients come to see. But we have family physicians, we have family nurse practitioners, we have a couple of specialists that work with us, a pediatrician and a psychiatrist. We have midwives, registered nurses, social navigators, that's our term for social workers, but they work for the patients. They don't work for the government systems, so we don't call them social workers. We have counselors, a dietitian, and we just opened our pharmacy. And this is our newest part of our clinic that we're really excited about. So this is a pharmacy that's going to be bringing together, again, so Western medicines, but also traditional medicines. This is a model that we're still developing. We're really excited for what this will become, but we very soon will have a space where urban Indigenous people can come into this pharmacy, but they can actually meet with a knowledge keeper and access traditional medicines in the city, where it's often difficult. A lot of our urban folks are disconnected from their home communities and don't have an opportunity to access the medicines that they would back home. So this is a way for them to access those in the city and to have that complemented with Western medicine where they need that. Our patients can decide what approach that they want to take with their medicine on that day, and most want both. Most want the opportunity to access both systems. And that just speaks a little bit to what we talk about. Medicine can come in many different forms. That's my word for medicine in my language, mashkike. And so you can see some of the medicines in that space. On the right-hand side, that's our healing room. And that's where our elders and knowledge keepers do a lot of their work. You can see some of the plant medicines on the top and the side there. So right now we have about 35 plant medicines that are part of that growing pharmacy space. We're really excited to see how that comes out. And in the bottom you can see the sweat lodge. So we're really fortunate to have a lodge on site that our patients can be part of. And this is, again, we're a small part. We're one little clinic. I think these ideas that I'm sharing are very much ones that are happening in lots of other places across Turtle Island. But these eight clinics, we do operate very much as a circle, as a partnership. We lift each other up. Our partners' successes are our successes. Our successes that we have, we lift our partners up and help them to experience the benefits of those too. So we have 4 on reserve and then 4 off reserve. It's a partnership of the two. All right, I'll pass it on to our next presenters. Miigwech.
Thank you so much, Dr. Michael Demont. I told you guys that was going to be very inspirational. Trina?
Según se guaguego, wasundi o yujats, ogatayuni ni wagitarodo gahnawage ni de wagenu. So just introduce myself and my clan, which is Wolf Clan, and that I'm from Gahnawage. I also want to, for CEPD purposes, make the following declarations on the screen. And I also want to say that I'm co-presenting with a partner for the network I'll be talking about, the Office of Joyce's principal, Jennifer Petitquet-Dufresne, who's going to be following my presentation. Oops. There's a couple of slides missing there, but that's okay. So I'm talking about a research network called the Hadigun Sunduje, which means the faces that are coming. And the name that was chosen for the network is because we hope that health research is going to benefit those faces that we won't see, because they're the generations that are going to be coming here after we're gone. So it signifies our decisions today need to consider the impact 7 generations into the future. So the Hadigun Sunduje Quebec Network Environment for Indigenous Health Research, I'll call it NEAR from now on, is one of 9 funded, CIHR-funded research networks in Canada. So there's one in each province, one in the Atlantic provinces, one in Nunavut, one in Northwest Territories, and soon we'll have one in Yukon. So the purpose of these research networks is to enhance research capacity. Our partner with Joyce's principal is because we're aligning our efforts around building capacity that's cultural, building cultural safety in research and building cultural safety in healthcare. I also wanted to say that these NEARs are not the first iteration of the idea of having networks that support building capacity for health research. In the early 2000s, we had the Cadre program, and following that, we had a NEAR program with an A for Aboriginal. Now we've changed that to Indigenous. And those two networks were very successful, that when we demonstrated their success, the funding was cut because it was said, well, you reached what you wanted to do, so we don't have to fund this any longer. And a lot of advocacy went into continuing, and we have these NEAR programs now that are funded for 15 years. We're in our second renewal, and each of the 13 health institutes are funding these networks. So they're very, very important. I've benefited from that in the early years, and so have many Indigenous researchers. As we've heard earlier, there are very few, too few Indigenous health researchers, and we need more health professionals as well. So I just showing you here, the network aims to include all of the nations, the 10 First Nations of Quebec and the Inuit communities in Nunavik. Our values from our, that we follow in the work that we do are presented here. And I really probably will talk more about reciprocity and the importance of when we're doing research with Indigenous communities, that engagement and relationship building is really to build, reciprocity. How are we, how can research not be extractive but actually bring benefit? The vision for our network is that all Indigenous communities and organizations in Quebec have the self-determination to sustain health research for well-being in future generations. We have 3 goals that focus on a community setting, that look at supporting emerging Indigenous researchers. So we have scholarship program and other activities to support knowledge, translation, and transfer, including Indigenous knowledge and research. And a part that focuses on transforming institutions so that it's easier for researchers to have the training, to know how to do culturally safe research with Indigenous communities. So it's not just thinking about communities need capacity. We have capacity. We need to enhance that capacity, but so do research institutions, academic institutions. And we have a set of activities that network across the province, network within regions. We have different forms of sharing information that are part of our renewal. These are from our proposed activities. I just wanted to focus a bit more on the first branch, which is looking at the efforts to enhance community capacity. So for this, we're focusing on a pilot project where we're looking at research facilitators in the community and how can they work to support the kind of research that communities want to see. And also to facilitate those, all of the demands that come with research, like research ethics board applications and all of that. So we're having a project that's looking at that. We're also wanting to study the pathways to research funding. There's been a lot of effort so that more Indigenous researchers can access research funding, but we're not seeing the results that we'd like to. So trying to remove the blocks to that. And then sharing knowledge through health research summits that bring people together. And in Quebec, I just wanted to note that, we work in a bilingual environment. We do have translation for our conferences, and that is very costly. And the Quebec NEAR, compared to other NEARs across the country, doesn't have the same, we have more costs related to that. So that's one of the things we try to remind the funders that there's some inequities there sometimes because we function in that bilingual environment. And we're not even talking about, having summits with Indigenous languages yet. And so that's the Quebec NEAR, and I wanted to also recognize that the idea for the Hadigun Sunduje came from the Kanawake School's Diabetes Prevention Project. That's KSDPP for short, another acronym. And KSDPP is now 30 years old. It's a research partnership. Dr. Ojisto Horn did her master's through this project. I did my PhD through that project. And really, it's a research partnership that's based on collaborative research. Let's do research that's going to be beneficial to the community, but also, train the next generation of researchers. And when the opportunity came to propose a network that would support capacity building, I said to my colleague, Alex McCumber, I said, let's propose a network that's based on this best practice, because there's got to be other communities. We know there's other communities doing really good research. So the idea of NEAR is to really bring us together and share those best practices. And KSDPP's Code of Research Ethics, which we wrote 30 years ago, because we realized when you work with academic researchers, you have to spend time to understand each other's intentions and responsibilities, because when you don't, there's misunderstanding. And we have those tools. We have decision-making, traditional processes that tell us how we do that, how do we build understanding to come up with good ways of working. So our Code of Research Ethics also guides the NEAR. So I just want to leave you with this quote from the peacemaker, who's an important figure in our history. He said, "Think not of yourselves, chief, nor of your own generation. Think of continuing generations of our families. Think of our grandchildren and of those yet unborn, whose faces are coming from beneath the ground." That's what the Hadigun Suntuje means. So we look forward to another 30 years at KSDPP, and hopefully for sure for the NEAR, as we're just entering our second renewal of 5 years, and there'll be one more renewal. And we're crossing our fingers that the political environment is going to continue to be supportive, and trying to mobilize now to ensure that the importance of these networks continues. Yamakoa. Merci. Thank you.
Thank you, Trina. Yes, please.
Okay.
Go ahead, Jennifer.
Quick skina. Mshidugun. Jennifer Petsko Indigenous Kazon, Padamanga Docts, me wets Anishna Berino Koda Nertake Kaskiro, Shnani Book, Megata Izinishna, and Nuknauti, Yarmutskadek. Padamangin Guiten at Skamek Nervisquan, Manuanik Negra, Botutan, Krazan de Armatsanguiten, Nejo Ziretskan, Nuziretsgan de Mirsakwanik Regazan de Pitsquek Dikira. Guden Gungen Kamiodan, Nuitan Krega, Indizik Nagosak, and Gudation Aniban Megata, Benaniban Zermudmatok. And the Grekish Skertaman, Manuanik Denama, Ermizi Dikneruzuk and Optake Neokshrun, Mazinde, Akuzukungo, Hewidjazikem J, Dognizik and the Ester Magnizik. Bonjour, je m'appelle Jennifer.
Hi, I'm Jennifer Pettigrew. I was explaining my presentation today. You have my affiliations on the screen. I'm here for the Joyce Principal's Office as Director General of Joyce Principal's Office. This is Manuan. That's my community. I lived there for several years. That's where I had my first contacts with the health system, and I saw that it was not all that benevolent towards the First Nations and people in general. So to go back on what Joyce lived through, I don't know if you heard about it. Joyce unfortunately had to go to the hospital one day. She had a reversible health condition. She was asking for care. She needed that care. And unfortunately, the only thing that she got is discrimination, bias, prejudice, and she died from a treatable medical condition. So biases and stereotypes had the worst impact possible on her need for care. Indifference and ignorance cost her life. After that horrible event, which created a deep wave everywhere in Canada, everywhere in the world, in Quebec. Despite this horrible event, the first reflex of my nation, of my community, was to be part of the solution. So we started with our methods, our ways of doing, and we undertook a community consultation, and with the other parties, with public communication, to come up with Joyce's principle. It focuses on Section 3 of the United Nations principle, aims to guarantee all Indigenous peoples equitable access to social and health services free of any discrimination and the right to best possible physical, mental, emotional, and spiritual health. And the principle requires absolutely the recognition and the respect of traditional knowledge and living knowledge of Indigenous peoples. It concretizes our right to self-determination. It's something that we gave to the First Nations and to society. It's a tool with which we can start decolonizing and transforming care with the relation between Indigenous peoples and health services. I work at Joyce Principal's office. Our mission is to adopt and apply the Joyce Principle at the organizational, provincial, federal levels by transforming practices in healthcare and social services to achieve health equity for all. We have the mandate. We're anchored in a self-determination principle for self-determination of the Atikamekw Nation. We want to provide an end to systemic racism in healthcare and social services. In our vision, we could have remained political. We could have tried to just focus on governments, but we decided to act concretely with people with support tools for various community organizations of knowledge application, decolonization, with new programs that correspond to Indigenous people's needs. We have 4 great fields: accountability that we all have individually and as a society, also support for self-determination, decolonization of existing structures, and resurgence of traditional Indigenous knowledge. Our action pillars: the adoption of the Joyce Principle, the development of partnerships, because that is how unity will be stronger and cause structural changes in Canada and elsewhere. Also, the creation of tools and projects to improve access to care for Indigenous people. We've presented a guide on how to apply Joyce's principle in Indigenous or non-Indigenous organizations. Unfortunately, we come from colonial structures. We have colonial references that force us to provide services in a certain way. So how can we have a social contract, moral contract to change things and getting the tools to change things altogether? So the guide addresses those 5 structures. For us, applying Joyce's principle is not just to write it down. It's how to modify, to transform, and it's how to reflect on how to put this change in the whole structure while analyzing our leadership, our system, how we can co-govern our projects. Human resources, we will deal with that a bit later on, but also how to see services and programs and how data is gathered, rendered, and complying with the data given by communities. Here I am with Trina, which allowed us to create a roundtable on cultural safety. There were people from Indigenous communities because in Quebec we also have the issue, cultural safety. We wanted to all be there as First Nations to say what cultural safety is for us and what it should be for research, or also in applying Joyce's principle. So the report is culturally safe report. It is here with the QR code. If you're interested, there's a chapter 1 on Joyce's principle. And here, if you want to know more on Joyce's principle. Thank you. Miigwech.
Thank you.
All right.
My name is Dr. Brent Young. I'm the family physician and Anishinaabe from Sandy Bay First Nation. And I apologize, Elder Deb, I feel unusual speaking ahead of you, but I got permission when we were right backstage a few minutes ago. And feel free to chime in if you need to at any point. I wanted to start today by actually the Mi'kmaq concept of M'sit Nogma, and I'm not Mi'kmaq. I'm very clear in that in my practice and in the work that I do with community. But of course, I was born and raised in Mi'kmaqi, and so I've been learning a lot from the Mi'kmaq community and the people that I work with. And I thought this concept was actually an important thing to talk about today, because it is actually about all of my relations and how we honor those relations. And Wajaywanan Health Center, which is the health center based out of the Mi'kmaq Native Friendship Center in Halifax, where I work and helped establish, it really is about honoring community. It's about honoring the history that I have and the things that my family have been through, which I'll talk about in a few minutes. And I recognize that I forgot in the beginning to talk about the disclosures. I was actually going to make a funny quip about all my relations in the colonial context being, oh, and it's not even in here. But a few of the disclosures would include the honorarium that I received to be here today. And then, of course, the work that I do at Dalhousie, which is paid, and the work that I do at the Wajaywanan Health Center, which is also paid. And I also do some work with NIHB at the Drugs and Therapeutic Advisory Committee, and I'm a volunteer board member for the Indigenous Physicians Association of Canada. Here we are, perfect. All right, so we will now move on. So my story, as kind of a starting point, is a bit of a winding journey, and so my grandmother was a residential school survivor. She went to Sandy Bay Indian Residential School, and my mother was a 60 scoop survivor. She was adopted out of Manitoba back in the 1960s, and she had a long journey with a non-Indigenous family across Canada, a military family actually, and so this, of course, is a big driver in my life in terms of finding that connection with community again and giving back to community that has given so much to me in the years that have since passed all of this. And so where this has begun for me, a lot of it has been in Jabuktuk, so Halifax, Nova Scotia, and this is where Wajaywanan Health Center is based out of. It's actually the largest Indigenous population in Mi'kmaqi, and so looking at the Mi'kmaq population, there's about 7,000 Mi'kmaq folks in Mi'kmaqi, and overall there's about 16,000 Indigenous folks. And it's hard to believe that prior to Wajaywanan Health Center, there was no dedicated Indigenous health center in Mi'kmaqi, and really that only came to be in 2022. After I initially moved to Halifax, went to Dalhousie Medical School, I moved again and went to Calgary to do my family medicine residency. And while I was there, I was like really trying to focus on what am I going to do to be able to get back home and start practicing and serving the community that actually really means so much to me. And so, of course, as in Calgary, I was trying to figure out, like, how does one be a physician? How do you actually get a job? How do you write a proposal to open a clinic if you're not going to be working in the context of a fee-for-service environment, which, as Dr. Dumas mentioned, can be very challenging when you're working with an urban Indigenous population. And so a lot of this was really about like getting on Google and figuring out the language of health administrators. And we don't actually teach that very well in medical school, like how does one write a proposal? And that's not something that I was taught. And even our residents, I think, will talk about their struggles with kind of learning how to run a clinic or how to set up a clinic. And I think we need to be able to do a better job of that. And in the context of Indigenous health, I think we can do that with our Indigenous students and residents to be able to provide them with the tools and resources that they need to rebuild the health system for Indigenous communities. And then, of course, after I was done in Calgary, I decided I was moving back to Halifax finally again. And Halifax was really nice. I'm so happy that I moved back. It is a lovely city, and it's changing so much over the years. And the urban Indigenous community is growing quite fast. And when we think about the programs and services at the Mi'kmaq Native Friendship Center, I think there's over 50 or so now. And we serve about 7,000 people at the Friendship Center alone. And so it's a great place to be, but when I moved back, I was faced with this inertia of the health system and the monstrosity of bureaucracy that comes along with it. And I remember like simply working with the recruiters trying to figure out where am I going to work was a big challenge, and mentioning like I'm an Indigenous physician, would love to serve Indigenous communities, and a lot of the responses were kind of direct me off to communities that had nothing to do with serving the Indigenous community. But over time, there was an increasing awareness, and so you start kind of putting the feelers out and building a network. And there's folks working actually in Sebeganegedy, where I also practice, and they were looking for a locum. And it was an opening because that person was actually also developing a proposal for new physician funding, which you have to do in Nova Scotia if you're trying to open a new clinic like that. And that's where it all began with Jaywin as well. So we put in the application for that funding, and things looked a lot brighter. It wasn't as dark and dreary as this photo suggests. And of course, there was this beaming light, that is Pam Glow-DeRoche. She's the executive director at the Mi'kmaq Native Friendship Center. And I don't even know if Pam sleeps. I'm not confident she sleeps, but the amazing work that she does, it's just incredible. And Pam will tell you herself the story of me reaching out. I had sent an email initially, and I was telling her I'm an Indigenous physician, would love to explore opening a clinic at the Friendship Center, and she completely ignored me. Months went by. She's like, "This is it." She'll say now that she thought it was a scam. It was a complete like spam email and everything, and I was like, emailed again. Dear Pam, it's not a scam. And I was, from then on, she actually ended up realizing, like, wow, this is actually something that we can do. And now here we are today. And so the Friendship Center in the bottom left is the photo of the Friendship Center where it used to be located on Gottingen Street. And the top left is where we're currently located on Brunswick Street in Halifax. And soon enough, we'll be moving to this beautiful new building that's being built right next to the Citadel Hill in Halifax. And so the future is very bright for our clinic. I think right now it's a very humble space, and it's funny, when we first opened, I remember the media came by, and there was a comment somewhere in the media like, very, very humble space, because it was literally us like putting tape on the floor, measuring out like, this looks like it could be a clinic room size. But I think where we're moving into now, and we can plan into this bigger space of the new Mi'kmaq Native Friendship Center, I think it's going to be incredible, even more so than it already is. And so pulling it all together, really for kind of reflecting back on it and how that all came together for us and for community. I mean, there was work going on for many, many years, as I mentioned, at the Mi'kmaq Native Friendship Center to build capacity, to build resources, to build all of those other programs that we now have access to. And so this was really kind of about finding that common purpose and those principles. And that was actually, for me, as a medical student, getting involved in things like IPAC, and later on the National Consortium for Indigenous Medical Education. And of course, all of the work that was being done with organizations like the AFMC to advance Indigenous health and reconciliation. And being aware of kind of the work and the narratives and the reports and all that stuff was very important, because I could then kind of bring some of that in and tie that together with the work that was happening on the ground in community. And a lot of it was literally just sitting in front of a laptop and typing and typing and typing and typing. And for me, I actually really like writing, so that was an easy way to kind of get the ball rolling. And then finding partners in government and in the health authorities is one key piece of the puzzle when we're trying to do this. And today, we now have our health center. And we have about 1,000 patients at the health center now. We're still growing. We're accepting more patients. With our current staffing complement, we're looking at probably 1,800 to 2,000. And it's something that we keep our eye on over time to make sure that we're keeping our wait times in check, and we're not reducing access in that way, because we know that people oftentimes will need more urgent access. And really, this has been the work of a very broad team and developing partnerships. And so looking in the top right, very recently, again, developing a new partnership with the Department of Psychiatry to establish psychiatric services and consultation services out of the clinic. And these are the types of things that I think will be very important, is actually formalizing these relationships through memorandum of understanding and agreement, because in the past, what has happened when we've established some of these services, if it's not formalized in those types of agreements, it tends to drift away, or if there's a lack, if there's somebody who's just interested in doing the work and then moves on to another job, it can fly away with that person. And so with that, I think I'll wrap up, and then I'm happy to hear from the other panelists.
Well, thank you. Good job. Good job. Thank you, everyone, for your presentations. I don't know about most of you, but I think the information that's been provided really gives us some inspiration and some ideas in moving forward. So in saying that, please another round of applause for our panelists and all the great work that they are doing. Let's move on now to the discussion part of this hour to talk more about self-determination in Indigenous healthcare. And I'm sure we all would love to hear from our elders. So why don't we begin with you, Elder Deb. First of all, I'll ask that you please declare your conflict of interest.
In the context of CPD accreditation, I have declared the affiliations projected on the screen.
Thank you. Thank you, Elder Deb. Now, the Mi'kmaq Native Friendship Center played a key role in the creation of the Wuj'ewinin Health Center. How have you seen it transform the care for Indigenous patients in Halifax?
Before I begin, Oni Buju, Nana Temakus, Indigenous, Nome Ganaway, and Ishnabekwe, Batwana. Thank you very much for that question. I actually was on board from the very beginning of the Wuj'ewinin Health Center, and I've seen it from the masking tape on the floor to what it is today. And I have to tell you that the difference between before and today is amazing. And the reason for this is because a lot of us know of the 7 grandfather teachings, and from the get-go, Dr. Brent kept those teachings in mind when the community members were coming in. And the teachings of love, respect, honesty, humility, bravery, wisdom, and truth are all there. But the most important one that I've seen over the past 3 years, 4 years, are we? I can't remember, 4 years now? Yeah, about that anyway, a few years, has been respect. And so by that, I mean that anyone who comes to the center, no matter what walk of life they're from, if they're from the street, or if they live in their community or wherever, they're treated with respect and dignity from the get-go. And that is a huge, huge barrier that's lifted. Thank you. It's so true. Because it doesn't matter what ailment that they have. As soon as they come in, first of all, they're met with smudge right as soon as you come in the door. And then they're seen by Indigenous receptionists, and it just gets better from there. And even at the center, when we have individuals coming in who have a little bit of mental health concerns, I work at the center, so the doctors will come and ask me to help calm down. And I don't know of any other medical organization that does that, to allow an elder to come in to help to calm the patient down a little bit. And then once that happens, and I leave the room and the doctor continues to work with the patient. So it has a huge impact on our community. Even moms who are pregnant, never got prenatal care before, are coming in for prenatal care and are coming back for postnatal care, because the RN nurses that are there are Indigenous and understand, and they're not afraid. It's culturally safe for them to come in with their babies, or culturally safe for them to come in to talk to doctors who understand our backgrounds, who understand our culture, and who understand where we come from and the intergenerational trauma that has happened. For myself personally, I came from a military background, which I did get very good medical care while I was in the military, but once I got out, I switched 3 doctors, but once Dr. Brent came on board, I was quick to switch over, and I've been with him ever since. And the trust that I have in him as an Ojibwe Anishinaabe doctor, it makes my heart feel really good. And that's the big thing about it, is the trust and respect that we get, that patients get when they come into the Wajaywanin Health Center. So I know that we're growing again, and all of the doctors have taken part in blanket exercises to understand the cultural background and where we're coming from and the trauma that has happened, and have questions, and just are like normal people, bring their lunches to our lunchroom and have lunch with us. And that's what makes us a family and a community. And it doesn't matter if you're Mi'kmaq, Anishinaabe, Cree, Inuit, doesn't matter. You're treated with the same kind of respect and love and dignity that every human being deserves. Miigwech, thank you.
Thank you. And Elder Deb, I would just like to, I just have one quick follow-up question to what you said, and you know, you pretty well answered it, but to show respect to everybody who walks into the door, can you just tell us just briefly, why is that so important?
I've noticed this because when I walk down where we used to be on Gottesden Street, there's a lot of homeless people, and a lot of homeless people, they don't have access to showers, that as an example, and so there's not a very good smell on your nose sometimes, but my superpower is hugs. So if I see somebody and I give them a hug or say hi to them and acknowledge that they are human, and that they are there and no one's going to walk by them and just dismiss them. That is so important for people to know that they're cared about. Doesn't matter, 30 seconds of your nose or 15 seconds of your nose, that goes away, but that hug or that nod or that acknowledgement stays with that person for a very long time. And when they come into the Wajaywanin Health Center, it doesn't matter. It doesn't matter, they're treated with kindness, and the doctors are looking after them, and the nurses are looking after them because they need the help. No matter if it's just to lend your ears or to give you a hug or just to know that you're cared about and you're loved, that is so huge. And I think this whole world, this whole Turtle Island could take a lesson on that of treating each other with kindness and respect and dignity, and it will go a long way.
We will.
Thank
you. And in everyday life, thank you for that, Elder Deb. It was really special, thank you. Now, in the work you've each done to advance self-determination, how have you managed to bring the Indigenous worldviews into the mainstream, or to marry the two worlds? And what has been the greatest challenge in doing so? Michael, can we hear from you on that one?
Yeah. Well, I want people to know that we talk about worldviews, we talk about our knowledge systems. Our knowledge systems are complete; they are whole, and it's not about trying to squeeze that in and fit that into this other knowledge system, this sort of Western scientific knowledge system, which is also whole, maybe a little narrow focused at times, but it's its own system, a younger system than ours. But what we're talking about in our context, at least what we've tried to do, is to bring those together, acknowledging that there will be times where these two systems clash. There will be times where we don't necessarily agree on the right way forward with a particular issue that comes up. But that those two knowledge systems both need to be respected, and they both need to be appreciated as complete and whole systems. And that the patients who are approaching this sort of space deserve to be able to access both of those knowledge systems in the care that they receive. And so the way that we've done that, again, I think both Brent and Elder Deb did a wonderful job describing this beautiful center. I can't wait to visit at some point. And this is incredible that you're doing this as the one center in Jipuktuk. That's I think of our own experience in being able to do this as a group of 8, but to do that alone that's amazing. That's heavy lifting. One of the things that we needed to do is our elders, our knowledge keepers who were working with us, they didn't have a way to be paid in our system in BC. So one of our first steps is we actually went as a group, as our network, to the Ministry of Health had a meeting in Ottawa, or in, sorry, we're here in Ottawa, in Victoria. And we had to advocate for essentially a funding mechanism for elders to be recognized as essential, having an essential role within the healthcare system. And that was a process, a first meeting of many that happened. And again, we've had really strong partners who've been in lockstep with us along the way on that journey, with the First Nations Health Authority especially, supporting that as well. And we were successful. And so any clinic that's setting up their funding model, their clinical model in BC, elders are there's a funded position within the catalog of healthcare practitioner positions in British Columbia. Elders and knowledge keepers are considered one that you can apply for with setting these clinics up. But that was something that we had to do. Maybe I'll just speak briefly about our physician contracts. I'm no longer working fee-for-service, thankfully, in that space. But we had to advocate for physician contracts that equitably supported the work that we were doing. And it's not going to work the same way as the incentives that are there for care in the existing contracts that were there really emphasized medical complexity. But medical complexity through that Western lens, not through the lens that really appreciated some of the complexity that Elder Deb was talking about here. Our relatives who have been on the street or who are experiencing difficulties with their mental health, or substance use, or trauma, and just the way that trauma gets expressed makes a medical visit a little bit more difficult. Takes more time to build trust. Takes more time to do that care well. So we changed our whole contract model, and this is something that's still in process, but to put the incentive on relational care, to put the incentive on how well are you building and maintaining those relationships and looking after the families, not just the patient, but looking after the families and their community in the care that you provide. And so you get your incentive if you're doing that. And if the clinic recognizes the patients and the community recognizes that you're doing that. So that relational care incentive is a piece that we're looking for as well. And we think that'll flip the dynamic and the power a little bit in terms of how we're providing that care in the community.
Okay. Thank you. Now, Trina, you work at a very colonial institution, McGill University. What do universities and medical schools need to do to ensure there are more Indigenous perspectives in medical research?
Oh, it's an easy answer. Well, I think that with Truth and Reconciliation, we've seen many universities state what their commitments are at an institutional level to do that. And McGill University has done that as well. And within that, they have 52 calls for McGill University, for example, to do that. And those touch on medical education. For example, there's a program that looks at how are we changing the health professions at McGill University. So there's a group of people who represent different health professionals to talk about how we're addressing, how do we ensure that health professionals are trained in cultural safety and other aspects of their training that need to address, so we can be improving relationships with clients. Parts of those commitments talk about research ethics boards in the university. Are there people who are trained to understand the kinds of relationships that are required to do community-based research? So those are, the universities have to, I feel, have to make commitments for Truth and Reconciliation, have been doing this. The challenges are in the limited resources and just the scope of things that have to change. There's a lot of calls in there, but the resources are very limited. And, we spend a lot of time, again, there's not that many Indigenous faculty members, even though there's efforts to recruit and retain. Without changing the institutional space, you're still sometimes facing those challenges. And Indigenous faculty burnout because we're just called on to actually, help implement these calls because we have those perspectives. But we're also expected to do everything else that faculty are called to do. So I think there has to be institutional transformation. That's what the NIR is working on when we say we need universities to ensure that researchers can conduct research that is respecting the self-determination of Indigenous communities. How do we do that? You know, how do you ensure that your research trainees can get beyond just the training they have to do to get a certificate from CIHR, for example? So very good expressions of commitments have been made, but in terms of advancing them, the progress is probably a lot slower than we'd like. But there have been, you know, incredible successes in terms of supporting students, making spaces in the university, having really good commitments. But yeah, so we need infrastructure, and we need more people to do that work.
And Trina, just quickly, how optimistic are you that those challenges are going to get met?
Oh, I'm always optimistic. I'm always optimistic.
That's a great way to Jennifer, let's move on to you now. Now, Joyce's principle, and I apologize, I don't speak French, but Joyce's principle aims to guarantee all Indigenous people the right of equitable access without discrimination to health and social services, as well as the right to enjoy cultural safety. How can medical professionals and healthcare institutions contribute to the success of that principle?
Ben, je vois quand même le support à différents niveaux.
I have different level of support, you know. I can provide you more information about that. But when I was talking about leadership, when you're in such position, we have to put in place a governance system that is shared, a shared government responsibility. And this will help self-determination. So when, let's say, you're not involved in the decision-making process, but more into micromanagement, you have to review to see how you can participate. You have to be fair towards Indigenous population. We can use the expression population, at-risk population. When you are in a position of authority, you can change the status quo. Then, when we're talking about self-determination and data, say how can we capture traditional knowledge within our processes? We can expect a doctor to know everything for every single First Nation, but the person needs to have the choice how they want to access these services. Unfortunately, this may create a barrier to patients. So I think we can put forward some measures. It depends on the level, once more. And it depends on what we can do. We have also to take into account the effect of colonization. So how can I help today to have effects within 20, 30, even 40 years? We have systemic issues in my service. What can I do? We only have the First Nation and Inuit within Quebec. So how can we position ourselves in order to promote changes within Quebec? We just adopted a resolution. We want to have a healthcare system for Indigenous people, directed by Indigenous people. This self-determination is done in partnership. We have to work together, like we just said before.
Merci. Okay, and I get to be the boss of these guys and say we have to wrap up soon, but of course we want to hear from Dr. Brent first. We heard from Dr. Elisa Levi today about how difficult it is for her as a new physician to establish an Indigenous-focused clinic in her community. So Brent, what advice would you give to those who want to exercise their right to Indigenous self-determination?
Yeah. I think it's important to think about self-determination as a collective right. Like, I mean, we have a right to bodily autonomy and all of those types of things, but really self-determination for Indigenous people is about this collective right that we have to, as communities, as nations, to be able to shape our services in health. And of course, it expands beyond even just that. But when we're looking at health, how do communities harness that right? And how do we organize to build systems that serve our needs? And I think a lot of what we do is not revolutionary in a lot of ways. I think when you describe respect being a principle that we apply in our clinic, really this should be happening everywhere else in the healthcare system as well. And it certainly does to a certain degree, but we do have these terrible things that happen within the healthcare system that alienate Indigenous patients and harm Indigenous patients. And so for me, I think the advice that I would give is that would be to find community, find people in community who are doing work and who can help advance some of that cause and move some of the pieces of the puzzle along with you. And that's what I think has led to the success that we've seen at Wajaywanan Health Center.
Mm-hmm. Thank you so much. We are just about up to time for this session, but I would love to ask Elder Deb to leave us with a final thought just on looking forward to feel inspired in how to advance reconciliation in healthcare, if you can leave us with a final thought on that.
You know, there's an elder from Eskasoni in Mi'kmaq. His name is Elder Albert Marshall, and he coined the phrase two-eyed seeing. So it's looking through one lens with your Indigenous roots and looking through the other lens with your the colonial roots. So if we can walk those paths and understand which path that we need to be on and to understand where that has to happen with the patients that you're working with and the community that you're working with, and work towards the truth and reconciliation calls to action for health, I think that that would be a good start. And in my heart, I feel that we are on a good path. I feel that people are really taking the truth and reconciliation calls to action serious, and we call them reconciliation. So by even having this panel here today and the work that everyone is doing, to me, feels very good in my heart and gives me hope that we can continue on and that everyone will begin to understand that respect that I talked about and the work that has to be done with everyone and love everyone. So that's what I would leave it with. Miigwech, thank you.
Thank you. Thank you so much. Very wise words to end this session on for this hour. Thank you to all our panelists this afternoon who shared their great work moving forward in self-determination in Indigenous healthcare and for giving us ideas. And like I said, I use the word inspiration a lot this hour, but just to feel inspired to move forward and to keep doing the great work that you all are doing. I'm very honored that I was able to be here with you this afternoon and to listen to the discussion as well. Thank you so much for your contribution, and thank you all for being here as well. Thank you. Thank you. That was fun. Yeah, it was great. Thank you. All right.
So now it's my turn to thank you, Juanita, and to thank all of our guests for being here. I really appreciate it. If you're looking to learn more about CMA's work on Indigenous health, including our recent apology and our reconciliation action plan, you can find more information in our interactive exhibit space at the back of the room. So we have heard a lot today, the impact of US health policy on Canada, the importance of innovation in strengthening our healthcare system, and the need to advance Indigenous self-determination. We'd like to take the next 20 minutes to reflect on those conversations. For virtual participants, Kate will help with instructions on what's next.
Hi, and welcome back. For those who are just joining us, my name's Kate Woolhouse, and we're here at the Rogers Centre in Ottawa for the Canadian Medical Association's 2025 Health Summit. I am your virtual host for the next couple of days, along with my CMA colleagues Nick and Savani, who are on the computer or your laptop or your telephone to help moderate the chat. So for those who are not yet comfortable with the website conference, I invite you now to join me there for a couple of instructions for how we're going to use that for this next segment of the conference. So if you open the website, you'll see on the left-hand side there are a series of tabs. Most are self-explanatory, but I'd like to bring your attention to just a couple. So there's a chat function. Please feel free to add your insights and comments there. It's a place for you to share how you're experiencing things and your reactions to the conversations. And then there's also a reflection space. So this is our community space online for sharing conversation while the people in the room are having their breakout discussions at the tables. So if you open the Reflections tab, you'll see that there is a text box. You can enter your questions, comments, insights there. We're asking you to please think about and reflect on any of the sessions that you were present for today, and there are, of course, you can review what we did go over in the program, but we're asking you to share what are the big questions that you're coming out of this with? What are those questions that are on your mind? And please feel free to speak to the session that just happened on Indigenous self-determination or any of the other discussions that we had today. So you can enter your text into that box. It's anonymous. You can enter as many reflections as you'd like, and then you can hit submit. Once you hit submit, there will be a button that says next questions, where you'll be able to see the results of everyone else who has contributed to the reflection space. So we're going to give you a couple moments now, about 3 to 4 minutes, to take a moment and pause and reflect on the day, and please enter your questions there. We will come back and read out some of what you have contributed, and we'll take it from there. Welcome back. Thank you so much for your contributions and for taking the time to share a little bit about how you have been experiencing the sessions at today's Health Summit. I'm going to read a few of the responses and let's take a look at what you've said. I wish that more Indigenous knowledge had been available when I was in practice. I think all of medicine should be practiced following Indigenous principles. We've come a long way in treating our Indigenous sisters and brothers with respect and cultural safety, but cultural humility is a lifetime process. A few others we have, it continues to be disheartening that some colleagues feel only their views or the way things have been done in the past is the only way that we should do them in the future. How can we help people embrace change? And this is a great question. What does the future of healthcare look like in Canada? And this, along with so many of the other questions that are coming up today, is why we're here to bring together some of the great minds and the great ideas and the stories that we've been hearing and will continue to hear tomorrow as well. For the rest of today, we're going to take a health break until 4 p.m. Eastern Time, at which point we'll invite you back for the final session of the day with the co-host of The Nature of Things, Anthony Morgan, on radical collaboration. So we'll see you at 4 p.m. Eastern Time.
Just wanting to give everybody the 5-minute warning. So we'll reconvene in 5 minutes. Okay, everyone, so that's the time we had for the sharing session. Some of you were kind enough to share some of your cards with us to share with the broader group, so I'll read a couple before we go on our break. So the first theme that came out at a few tables was from our session this morning on innovation and how hard it is to do innovation, especially in healthcare. I think the quote about the pilot project culture came up quite a bit, and people are thinking about how to scale that up and maybe move a little bit faster on certain things. That's something that even back in my business school days we were discussing a lot, how to create change in a high reliability organization when you can't afford to have a massive failure the same as you could in, for example, technology. So something to think through in the next couple of days. From our Indigenous session, something that came up a lot was how to establish funding models so elders get compensated properly for their work. Especially because I think Elder Deb's conversation about the power of human contact has touched quite a few of you. The power of the hug and the 15-second, that can make a huge difference for a lot of patients. And to tie that into our last thought, someone talked about scaling allyship in our healthcare system and how to integrate other ways of knowing into our existing healthcare system or into other initiatives. So thank you to everyone who shared. We'll now break for 30 minutes. For those of you on site, you can join us for a light snack in the foyer. And at 4 o'clock, please be back because you will not want to miss our keynote from Anthony Morgan, science communicator and co-host of The Nature of Things. He will give a talk about radical collaboration. You'll also get to meet our new CEO, Alex Munter, who will be the moderator of that session. So I will see you in 30 minutes. Good morning, everyone. Thank you so much for being here once again today. I hope you had a good night's rest and are ready to go for the second day of this CMA Health Summit. I hope you had a chance to reflect on yesterday's session, our varied lineups of speakers and topics. I also wanted to share some of the thoughts that were posted on the reflection wall yesterday, as well as the results of our ping pong poll. If you feel that the results of the ping pong poll don't quite yet reflect your views on the issues that we discussed, you still have some time to vote. So please make sure your voice is heard. So at this point, the highest voted short-term solution for our healthcare system is team-based care, followed closely with fighting false information. In terms of our long-term solutions, the highest voted solution was Indigenous-led care, followed by team-based care. So sounds like team-based care is something that this group feels very strongly about. If you haven't voted today, you can do so at the Interactive Hub, which is at the back of the room. For virtual participants, I want to apologize. I was informed that the poll was not working yesterday. It is live for you today, so please make sure if you get a chance that you take time to vote. We can see later today if there was any shift in the results after our conversations. From our reflection cards, I wanted to share with you some of the thoughts that were shared by some of the participants yesterday. Some people has talked about the need to be innovative with a new pan-Canadian licensure model, as well as new virtual health opportunities. One participant asked how we could create a culture or society that strengthens our capacity to hold multiple truths and to see our diversities of identity while strengthening our collective identity as inhabitants of this land. Also, there's lots of comments about collaboration, false information, and innovation, which tracks with the speakers that we've heard from yesterday. We heard questions such as how, as an individual and a collective, we start restoring trust in science, or the fact that innovation is not just intention, but purposeful action, which we'll get into a little bit more today as we embark into our workshop. We also heard some hope in the room, which I think is very encouraging for the future. We talked about working together across all sectors, patients, doctors, health professionals. I had a conversation with a psychologist this morning. I know we have nurses in the room, and so it's important that we all work together to advance our common goals for our healthcare system. And the last question that I will leave you with is, what if we were all working on the same thing? How does that affect our collective power to affect change? And hopefully we'll get to see a glimpse of that by the end of today. To kick off the morning, we'll be digging into the growing role of artificial intelligence in healthcare. This is a significant topic that provokes both excitement and concern, thoughts on issues of safety, equity, security, and accuracy. While AI has the potential to transform pretty much every aspect of healthcare and every other industry for that matter, enthusiasm for its widespread adoption can vary widely. To give us his perspective, we're all thrilled to welcome Dr. Daniel Yang, Vice President of Artificial Intelligence and Emerging Technology at Kaiser Permanente. In this role, Dr. Yang ensures quality oversight for all AI applications across the organization, including those used in the clinical world, research, education, and administrative function. First, we'll hear Dr. Yang's keynote presentation titled AI in Healthcare, Innovating at the Speed of Trust. Following the keynote, we'll have a sit-down interview with Dr. Yang, which will include time for an audience question and answer period. So please join me in welcoming Dr. Yang to the stage. Stage is yours.
Hi, good morning. All right, this is the English one. Okay, I should be looking at that. Hi, everyone. You have my disclosures up here. So it's an honor for me to speak with you all here at the Canadian Medical Association. Thank you for having me. As was mentioned by Carl, I'm Daniel Yang. I'm an internist. I'm also the Vice President of AI and Emerging Technology at Kaiser Permanente. And for those that are not familiar with KP, we are an integrated healthcare insurance company and a delivery system in the United States. We serve 12.5 million members in 8 states, with the majority being in California. And we employ 25,000 doctors, more than 70,000 nurses, and 230,000 employees across the organization. At Kaiser Permanente, as Carl mentioned, I'm fortunate to lead our program in responsible AI, which is focused on ensuring that our use of AI technologies are safe, effective, equitable, compliant, and ultimately aligned with our core organization's mission. Today, we're going to talk about something more complex than a convolutional neural network or a large language model. We're going to talk about human trust and how to build it and why without it, even the most advanced AI systems will fall short of its goals. And so I've dedicated my career to shaping the intersection of patient safety, healthcare quality, and artificial intelligence. And that experience has given me a front row seat to witness both the incredible opportunity, but also the perils of applying new technology into healthcare. And I want to illustrate both the opportunity and the perils with an example from my last job. So prior to joining Kaiser Permanente, I spent nearly 7 years working in healthcare philanthropy. I led a large philanthropic program focused on improving clinical diagnosis and reducing diagnostic errors. I worked at the Gordon and Betty Moore Foundation, which derived its wealth from Gordon Moore, who is the co-founder of Intel and named Moore's Law around computer chips. And so when I joined that foundation more than 8 years ago, Intel had been at the time the dominant chip maker in the entire world. And just down the road from Intel was a medium-sized chip-making company that very, very few people had heard of because they were building these specialized chips for gaming purposes. They were called graphical processor units. It just so happened that those GPUs were incredibly effective at running AI tasks, and in the last decade have powered the AI revolution, first with deep learning, and now with generative AI. That company is called NVIDIA. And so if you want to understand the opportunity for AI, all you have to do is look at the stock prices of these two companies. 8 years ago, Intel was 4 times the market cap of NVIDIA. Today, NVIDIA is 25 times the market cap of Intel, a 100-fold difference in 8 years. So if you want an illustration of the opportunity for AI, right, that's a mathematical illustration of what the market believes is the opportunity for AI. Now let's look at the other side, the hype, the perils around new technologies in healthcare. And so the Moore Foundation's office was located in Palo Alto, California, in the heart of Silicon Valley, just outside Stanford University. We were located across the street from another company you may have heard of. This one was called Theranos. Now, if you remember Theranos, they had a compelling concept. You could run scores of diagnostic tests on just 1 drop of blood. They had this charismatic and visionary leader. They had tons of venture capital, publicity, right? Everything you could want in a promising startup. But they were just missing one small thing, which is a product that actually worked. And yet it took people years to find that out. And in that time, many of the employees didn't know. The investors didn't know. The regulators didn't know. But most importantly, the patients who trusted and relied on the technology, they were kept in the dark, some of whom were directly harmed by Theranos. So sometimes in our excitement for new technologies, we overlook the critical importance of building and maintaining human trust. So I want to take a step back and ask the question, why do we even need AI in healthcare? What problems are we solving for? I want to apologize, this is an American-centric slide, but I imagine these are very similar issues you're facing here in Canada. What I see as what ails healthcare in the United States is a simple mismatch between supply and demand. I see demand for healthcare services continue to go up, driven in large part by demographic shifts. We have an aging population. And while it's great that people are living longer, they're also accumulating chronic diseases as they age, which makes providing high-quality care for them all the more complex. The second demographic shift is the rise of millennials. And as a millennial myself, I can tell you that the way we like to consume healthcare is the same way we like to consume TV shows on our computer, which is on demand. We don't want to wait 2 weeks to see our doctor. We want to be seen today. And we're happy to take a video visit, a telephone call, or better yet, we'll just email our doctors. Now, this is placing incredible stress on our care delivery system. And so as demand goes up, if you recall from high school economics, you increase supply. But unfortunately, healthcare, we can't do that very easily because we have a fixed supply. We're reliant on all of you, highly trained clinicians. And I'm sure all the doctors know, multiple years of medical school, many years of training. When the American Medical Association estimates that we have a shortage of 3 million healthcare workers in the US, I think you'd all agree we're not going to train our way out of that problem. We're not going to hire our way out of that problem either. And so what are the consequences when you have this supply and demand mismatch? What we're seeing are rising costs of care to unsustainable levels. You have physicians feeling increasingly burnt out because we're asking them to see more patients and more complex patients with the same number of hours each day. And access to care for our patients is also decreasing. And so when I ask, why do we need AI in healthcare today? It's to solve those very issues. And that's exactly what we're doing at Kaiser Permanente. How do we deploy AI to drive operational efficiency in our organization? How do we deploy AI to support our clinical workforce and reduce administrative burden? How do we deploy AI to increase access to care for our members? But those are really just addressing symptoms of this bigger issue, the supply and demand mismatch. How do we solve for that? Now, I think that AI will be critical to enabling two fundamental shifts that are needed in healthcare. First, how do we leverage AI to unlock the largest healthcare workforce in Canada and the United States, which are patients themselves? Right? If you think about other industries, how many of you have interacted with a human bank teller in the last month? I'm seeing a few hands up, not many. How many of you have interacted with a human travel agent to book or modify a flight in your last travel? A few more, but still the minority. Right? Healthcare is a very unique industry where we try to drive efficiency by adding more people to our organization. The rest of the world is moving towards a self-service model of care, which I think many of us prefer. I'd rather book my own travel than have to wait, on a telephone line for someone to help manage that for me. I think the patients feel the same way. They prefer self-management. And so how might AI enable better self-management of care with appropriate guardrails for our patients and members? The second fundamental shift is changing the unit economics of healthcare. Right now, we have a one-to-one model of care. One clinician takes care of one patient, one at a time. And so how might we leverage AI to move to a one-to-many model of care, where one clinician can take care of many patients simultaneously, while still maintaining quality of care and even increasing personalization of care? I think it's possible. Now, while I believe that AI has tremendous opportunity to transform every aspect of healthcare, I've also come to learn that the pace of progress is no longer tied to technological innovation. I live in the Bay Area, and I see huge advancements in AI coming out monthly, sometimes even weekly. Instead, what I'm seeing is that the pace of progress in health AI moves at the speed of human trust. Do our patients trust our use of AI? Do our clinicians trust our use of AI? Do our policymakers trust our use of AI? And nothing slows down innovation more than people that are harmed by these technologies, or vendors that overpromise and underdeliver, or tools that inadvertently worsen health disparities within our communities. And so we need to acknowledge the risks also that come with these AI tools. And so if you were to take a CT scan of my brain to capture the different anxieties that I have to grapple with every single day in working on AI, it would look something like this. In terms of the risks, we have risks of patient safety. We have risk of bias and discrimination. We have a lot of uncertainty among our clinical workforce. People worry about the impact of AI on their jobs and their livelihoods. And all of this is creating a rising tide of new regulations, at least in the United States, around health AI. But there's also another risk, which is the risk of doing nothing, right? It's the opportunity cost of not deploying AI. And as I just described, we're facing these incredibly challenging macro trends about physician burnout, access delays, costs of care. And so not deploying AI in many ways is accepting that status quo, which I think many of us would believe to be unacceptable. And so here we have this tension. On one hand, I have people telling me, Daniel, we need to be more aggressive with our use of AI. On the other hand, people are telling me, Daniel, we need to be cautious and really thoughtful about our use of AI. We can't move too quickly. And so how do we proceed when we're getting pulled in two different directions? Now, I believe we need a new language, a new infrastructure of trust that helps us navigate through that tension, a framework that's robust and reusable for a diverse set of use cases, a framework that's structured but also flexible, that accommodates for differences between health systems. Now, those attributes remind me of what we call the tech stack for AI. Now, for some of you, the concept of the tech stack may be new. To illustrate this, I'll give you a story. So a few months ago, I was speaking on a panel presentation in Southern California on health AI, hosted by the Southern California Permanente Medical Group. And what surprised me was not just who was on the panel, but actually how we were seated. And so on the far left of the panel, you had a senior leader from NVIDIA. To his right, you had the global chief medical officer from Microsoft. To his right, you had the CEO of a startup called Abridge, which creates an ambient scribe technology. And finally, to the far right, I was seated, representing Kaiser Permanente. So if you want to understand the tech stack, it was actually illustrated in the panel. You had the hardware layer, the computer chips on the far left. You had the cloud platforms, the foundation models, the inference layer. To its right, you had the applications of that technology in a particular area represented by a bridge. And then finally, you had the deployer of the technology, which was us, Kaiser Permanente. Now, on my left of the panel, you had some of the most valuable companies in the entire world, right, representing trillions of dollars of market capitalization. These are the companies that are building the pickaxes, the genes of the new AI gold rush. What I realized was that while the profits are happening on the left side, social value and risk was disproportionately felt on my side of the panel, on our side of the panel, the deployers of these technologies. And so it dawned on me that for deployers of technology, there's another stack that's more crucial than the tech stack, but overlooked by most. I call this the human stack for AI. At its foundation are people. Above that are priorities, then processes, and lastly, policies. And if we really want to transform healthcare with AI, we need to build trust along the way. And I think we can do that by building the human stack. So first, let's talk about the foundational layer of the human stack, which are people. Right now, there's a public trust gap when it comes to the use of AI in healthcare. Pew did a survey of American adults a few years ago and found that 60% of Americans would feel uncomfortable if their doctor relied on AI for diagnosis and treatment. That's the majority of people. But I would argue that that same 60% of people that feel uncomfortable about the use of AI in healthcare are very comfortable using AI in their everyday lives. It powers their Netflix recommender systems. It may even drive their car. I would also argue that that same 60% of people, by and large, are very trusting of the healthcare system. And I know we have a biased audience here, but if this was a general audience, to illustrate that, I would ask how many of you at some point in your life have undergone general anesthesia? A good number. And for general audience, I would say if you've raised your hands, you're extremely trusting of the healthcare system. Because as all of you are aware, what general anesthesia entails is not only do we knock you out, but then we paralyze your body, including your diaphragm, which is why we have to intubate you and use a machine to breathe for you. And remember, that's just the appetizer for the main course, which is surgery. If that's not the most profound illustration of trust, I can't imagine something more trusting than that. Our patients trust us with their lives. And so we have this paradox here. Why is it that people trust AI in their everyday lives? They trust the healthcare system, and yet they don't trust the use of AI in healthcare. Is it because AI in healthcare is somehow riskier than anesthesia or surgery? I don't think it is. I think there's a simpler reason, and it's because we haven't given the public a reason to trust us. And so one of our core principles of responsible AI at Kaiser Permanente is trustworthiness. And when you break that word down, it simply means being worthy of trust. It means that we have to earn trust. We need to be deserving of it. We can't simply expect it. And so how do you earn trust in healthcare? So let's go back to the example of anesthesia. Right? Why would anyone go through anesthesia? It's because they know that the benefits of those procedures, anesthesia and the surgery, far outweigh the risks. And there are two core components that drive this trust. First, we've been able to verify and quantify the benefits of those procedures. Right? We have decades of experience. We have clinical trials that demonstrate that these procedures work. Health AI, on the other hand, has done a very poor job so far of validating their real-world benefits. Right? So often I go to these big health technology conferences, and you have tons of AI vendors. Their benefits are mostly hypothetical. Right? They live on PowerPoint slides. Real-world evidence is very scarce. And so the more that we can demonstrate the real-world impact of these tools through rigorous clinical trials, I believe that the public will trust these tools. The second driver of trust in anesthesia is we minimize risk. Right? We have this whole safety infrastructure in anesthesia. We've seen huge breakthroughs in safety in that field in the last 50 years. We had technological innovation. The introduction of the pulse oximeter device enables anesthesiologists to monitor a patient's blood oxygen levels in real time throughout surgery. We had the introduction of human factors engineering applied to anesthesiology. Medical device companies re-engineered how the tubes fit with the gas canisters. You simply could not put the wrong tube to the wrong gas canister. We essentially made that human-proof, whereas before that could kill someone. We also saw innovations in medical education. The introduction of simulation allowed our clinicians to be more prepared for emergency situations. So we built this huge infrastructure around safety for anesthesia that made it one of the least safe medical specialties to now one of the safest medical specialties. But again, when you go back to health AI, we have not built this infrastructure for safety. Now, the second layer of the human stack are priorities. In addition to patient trust, AI in healthcare needs organizational trust. Now, when I joined Kaiser Permanente, I was struck by the level of creativity that AI stimulated within our organization. We had hundreds of project ideas. But what I realized was that if you really want to build organizational trust in AI, and if you want to extract maximum value from it, paradoxically, my recommendation is you need to be doing less of AI, not more of it. Now, I'll share an example from Kaiser Permanente. I'm proud to say that we've actually deployed the largest implementation of a generative AI tool in a clinical environment in the United States, if not in the entire world. We've deployed an ambient scribe technology to over 25,000 doctors. And the key lesson that I learned from that experience is the importance of relentless prioritization. The only reason we succeeded in deploying this technology responsibly and at scale was because we invested the time, the energy, the resources that this project deserved. We treated our deployment of this AI technology like you would treat a go-live for electronic health record system. Every single week, KP's senior-most leaders met Friday morning from 7 a.m. to 8 a.m. for months to work through some of the operational issues that arose through this deployment. We had hundreds of IT staff that were rounding in our clinics and our hospitals, providing on-the-elbow support for our physicians, making sure they could log on, collecting their feedback. We also conducted a failure modes effect analysis, which helps us identify potential process failures and mitigate them before they cause patient harm. If you're actually interested in learning more about this process, we just published 2 days ago, actually, a case study in the New England Journal of Medicine AI on our quality assurance testing process for this technology as we deployed it at scale. But even with KP's size and our resources, our organization does not have the ability to deploy this level of resources on 10 AI use cases simultaneously, let alone 100. I believe that if we're going to be successful with AI to start, we need more lighthouse use cases like the ambient scribe, as opposed to 1,000 flowers blooming, deploying AI, sprinkling it everywhere. And these lighthouse use cases build organizational trust along the way. Now, I have a 1-year-old daughter at home, and what I've learned from her is you have to learn to crawl before you can walk, and you have to learn to walk before you can run. And the same is true for building organizational trust with AI. It takes time, and you need to do it slowly. Now, the third layer of the human stack is focused on processes. Now, I love this quote from a colleague and mentor of mine at Stanford University, Dr. Nigam Shah, who said that workflows eat models for breakfast. Now, I think this is true not just for AI. This is really true for any health IT implementation. So often, we overemphasize the capability of the models, the algorithm, and we underemphasize the critical importance of redesigning workflows to accommodate these models. Again, let me share another example from Kaiser Permanente. So this was a program called the Advanced Alert Monitoring Program that it was an algorithm developed by our own researchers at Kaiser Permanente. The purpose of this algorithm was to identify patients who are hospitalized and are likely to clinically decompensate in the next 12 hours. So for example, if I was hospitalized after a hip surgery, it would be every single hour assessing my risk of unexpectedly landing in the ICU because of a blood clot or a surgical site infection. And the idea being, if we can identify these patients before the negative outcome, we can intervene earlier, thereby preventing that poor outcome. And so eventually we deployed this program across 21 hospitals in Northern California. And then we rigorously evaluated the impact of this program. And what we found astonished us and the world. We found a mortality benefit through this program. Across Northern California, we estimate that we save 500 lives per year through this one program. And to put that into perspective, 500 lives is roughly equivalent to removing all deaths from car accidents in New York City and Los Angeles combined. That was the impact of this one program. We published our work as original research in the New England Journal of Medicine. But I should also say that the algorithm itself didn't save a single life. It just flagged an alert. In order for this program to have had the clinical impact that it had, we had to redesign or design an entirely new workflow around this. When the algorithm flagged a patient at high risk, we had to decide who would that alert go to? What would that individual do with this information? We decided the alert shouldn't go to the doctors because they're busy and we don't want to distract them with a possible false alarm. So we sent the alert to critical care trained nurses that sat at a command center remotely off-site. They would review the alert, they would review the patient's electronic health record, and if they thought it was appropriate, they would activate a rapid response team who would go to the patient's bedside. The clinicians would evaluate the patient, decide on next steps. Ultimately, it was our clinicians that saved 500 lives, but AI helped them to do it. And I think one really important point here is if you took that same exact algorithm that we deployed and deployed it in one of your hospitals, and if you put a different workflow around it, I promise you, you may have a different result than we had. And so what's fundamental here is that the workflow around these algorithms is just as important, if not more important, than the model themselves. Thinking about processes and workflows is also critical because it respects our providers. It appreciates how they work and what's important to them. And I think we all know that when technology integrates seamlessly into our lives, it feels like a co-pilot. I mean, it feels like a wind on our back. But if it's not concordant with our workflow, it feels like molasses, right? It makes our lives more difficult. The last layer is around policies. So here we are in Ottawa, Canada, right, federal capital of Canada. Policy is a blunt instrument. Like, for example, in the United States, we're still living under the HIPAA privacy law from 1996. It's almost 30 years old. The public internet had just been introduced around then. When it comes to health AI, I have colleagues in our government relations and health IT policy team that have been working in that field for 30 years. They've said they've never seen more activity on a health topic than they're seeing around health AI. A few years ago, there was just a trickle of policy and regulations around health AI in the United States. Today, there's a steady stream, and pretty soon there's going to be a raging river of regulations. We're tracking 700 proposed legislation across state legislatures in the US focused on AI. And I say this half jokingly, but actually quite seriously. Pretty soon, we're going to need AI to manage compliance to AI-related regulations in healthcare. That's how complicated things are getting. But policies and regulations oftentimes are really just an expression of public mistrust. Today's stream of regulations often come directly from real-life examples of how AI may have been used in ways that could harm patients or magnify mistrust. And so that's why, moving full circle, people and policies are so closely intertwined. Because when the public doesn't trust us, it manifests in regulations that are fragmented, that are rigid, that can often slow or stifle innovation. And so if we want to avoid that, if we really want to realize health AI's full benefits, then we have to be trustworthy. We have to be accountable. Oftentimes, it's easy for us to imagine ourselves as just passive recipients of policies and regulations from other people. But I'd say we're not passive here. It's really our own actions, our mistakes, that are key determinants to how and to what extent health AI is regulated. And so if we're going to ask for a light hand in regulation, we really need to walk the walk of responsible AI. And if we can do that, I believe we can help transform what would otherwise be a fragmented, rigid regulatory landscape into one that can accelerate progress and innovation while still reinforcing trust. And so in closing, I hope that I've convinced you about the importance of the human stack for AI. And if we're going to build it, we need to invest the resources, the time, the expertise, and the attention that it deserves. We're going to need new technologies to support this, new research methods, and an engaged healthcare ecosystem that's all contributing to this effort. So I hope that each of you will contribute. I hope that the CMA will continue to contribute to this work. Because if we don't invest in this, if we don't build trust, I worry that we'll encounter another AI winter, where expectations and hype are followed by a trough of disillusionment. But our patients, our health systems, and our providers so desperately need these tools, and I think it's up to us to deliver them. So thank you.
Thank you so much, Dr. Yang.
Yes.
So I'll now have a couple questions for you, and then we'll turn it over to the audience. So I know you talked a lot about different aspects of the human stack and about patients' reservations about artificial intelligence in the clinical setting. Can you talk a little bit about what you think is going to be the actual impact of AI on the relationship between doctors and their patients?
Yeah. So actually, let me use the example of ambient scribes. So as I mentioned, we've deployed it across our entire organization. And it's a good illustration of what I think could be the impact of AI on the human-doctor relationship. And so just as a refresher, I'm sure many of you are familiar with how the ambient scribe works, but first you consent the patient to record the visit. The recording is turned into a written transcript, which is then run through an AI algorithm to generate a first draft of a clinical note. The doctor reviews the note, makes any modifications, and then signs it into the medical record. And so what's so remarkable about this tool is it liberates our doctors from their keyboards. Right? It allows them to refocus their attention from the computer screen to the patient's faces. And I know for so many of our patients, you know, a common experience is they take a half day off work, they go to the doctor's office, they wait in the waiting room, and then they spend the majority of their visits staring at their doctor's back as they're typing into the computer. And so while we initially deployed the technology to support our physicians to reduce administrative burden, what really surprised us was how much the patients loved the tool. So not only did the patients feel that their doctors were more attentive during the visit, they also felt that it created a greater sense of transparency into the visit. It was kind of this interesting side effect where if you want, for example, for the AI to capture your physical exam, you have to dictate the findings out loud. And so normally what happens, you know, you listen to the patient's heart and lungs, don't really say anything, the patient's kind of wondering, I hope everything's okay. And now the doctors are dictating their findings. You know, heart sounds normal, lungs sound clear, you know, belly is soft. Patients really like that transparency. Same with the assessment and plan, right? The physicians have to dictate out loud their assessment and plan in order for it to be captured. So again, the patients feel like they're getting more transparency into what the doctor is thinking. And so, you know, when you take a step back, I think what's really profound is for so long we've deployed technology into healthcare. I mean, since the beginning of healthcare, we've had technology. But so often when we deploy technology, while it serves really important purposes, it's often come at the expense of the patient-doctor relationship, right? I mean, imagine the electronic health record, all of the amazing things it helps us do, but also the impact that it's had on the doctor-patient relationship. And so for me, what's so profound is that for the first time, we've deployed a technology in healthcare that actually removes complexity from the visit. It actually makes care more human again, right? So if you go to a doctor's office in Kaiser Permanente, it feels like a doctor's conversation 20 years ago. There's no computer in the room. Or if there is one, it's not being looked at or used. And so what excites me is really AI that allows us to move more back to that human interaction that I think, brought us into medicine. So I'm very bullish about the opportunity for AI to enhance the human relationship between doctors and patients.
Yeah, that makes a lot of sense. I mean, I, for one, am in favor of anything that allows me to stop apologizing for having to type while talking to patients.
Yes.
One thing, I was at a CMA session about AI a couple of months ago, and one thing that kept coming up over and over again was the fear of being liable if the AI makes a mistake, or if you ignore the AI and you make a mistake. Can you comment a little bit on who should take responsibility if there's an error made by AI?
Yeah, that's such a great question. You know, one of the things that I've been seeing that troubles me is that responsibility and liability is increasingly pushed. You know, when I talked about the tech stack, it's increasingly pushed on the right side, on the deployers of technology, so healthcare systems and increasingly providers themselves. And first, I don't think that's fair. I actually think that the developers of these technologies need to take more responsibility. But for example, in the United States, we have this regulation in the Office of Civil Rights. There's a final rule, and it puts healthcare systems as responsible if they deploy an algorithm that may be biased, and they don't use sufficient mitigation strategies. Now, I mean, I do believe healthcare systems hold some responsibility, right? We need to ensure that the technologies we deploy are safe and they work and they're free from bias. But sometimes the bias is so deeply embedded that it's even hard for health systems to pick it up. And not every health system has an army of data scientists that can deconstruct these technologies. So I don't think, to me, it's completely fair that it should all be on the healthcare systems to manage this. I really do think that the vendors, the creators of these technologies who are profiting from this need to take primary responsibility. It's not any different than how it works in medical devices or drugs, right? You've got to go through pre-market review. You've got to demonstrate safety and effectiveness, right? Clinical trials. Who pays for that? It's not the deployers of technology. It's the developers of these technologies pay for that. And by going through, at least in the US, the FDA process, one of the primary benefits of that is you get liability protection if you use that medical device or drug according to the indication. But again, we don't have that liability protection for health AI. All of that, again, falls on the deployer. And the other troubling thing I see is, right now there's this concept of human in the loop. Okay, things are fine because the doctors are going to review the outputs, and they'll make sure they'll catch any mistakes. That's absolutely critical, but it's also kind of insufficient. Even as physicians, we make mistakes, we get tired, we may not be as attentive as we'd like to be. And it also sends a mixed message to our physicians where we want to deploy these tools to help you with your job, right? To take cognitive burden off. But by the way, you have to review this note and check every single word, and you're like a hallucination detector. And that's another form of cognitive load as well. And so I say the vendors need to make these tools easier for us as humans to provide effective oversight and efficient oversight. Instead of read every word in this note, it's can you bring to my attention the sentences that might have more uncertainty and color code that so that I can focus my attention on those sections as opposed to having to read everything very carefully. So I think we're in the messy middle right now, but one of the things that we advocate for is really shared responsibility. Yes, the provider has responsibility. Yes, the system has responsibility, but it definitely needs to be shared with the vendors. And we believe that there does need to be a regulatory environment around this, again, for public trust, right? For safety, for effectiveness, to see these clinical trials.
And how do we push developers to make that happen? Do you think it's a policy solution? Do you think it's a market solution?
I mean, at least at Kaiser Permanente, we push them through the power of the purse strings, right? So, in all of you, as you're procuring technology, it's asking the tough questions, like how did you train this algorithm? How did you validate it? What evidence, real-world evidence do you have that this technology works, that it works in the population that I serve or a population similar to the one I serve? What are the guardrails that you've deployed around it? Again, even at Kaiser Permanente, we have a very sophisticated procurement system, but we're upskilling our way on how do we have these negotiations with the vendors to ask the right questions, to push them to do the work so that we can be informed users of these technologies. So again, I think that our primary ability to influence is through what we use and what we don't use. But I do think there's a role for regulators. I'm sure pharmaceutical companies would prefer not to spend $1 billion on clinical trials, but they do it because they have to do it, right? So I also we live in a capitalist world where people do things because they have to do it, and so I think we need to also push these vendors to move from this being a nice to have to a must have.
Right, so voting with your dollars in a way. We have a lot of questions coming in from the audience, so I do want to get to that, but just one more for me before we do that. What's the future looking like in your view?
Yeah. Sometimes I speak to medical schools, and I often get this question from med students, residents, even people thinking about medicine, like, am I going into the right field with AI? I mean, will there be a job for me 5 years from now or 10 years from now? And I'm very bullish about the practice of medicine with AI. There was a lot of fear that AI was going to replace doctors, but that narrative has shifted where doctors who practice with AI will replace doctors who don't. But more importantly, I actually think that the practice of medicine will be, in many ways, better with AI. A lot of the administrative tasks that we struggle through, prior authorizations, writing notes, things that didn't bring us into medicine, I think we're going to be able to offload a lot of that to AI. I think that from a clinical decision support perspective, I can imagine AI providing like Google Maps, turn-by-turn instructions, real-time decision support pushed to you that is useful, that's personalized for your patients. I see a safety infrastructure being built with AI, just like you have with your cars, right? Blind spot detectors, lane keep assist. You're backing up and you're about to hit someone, the car just stops. Those types of automated processes that check for human blind spots, I see that going into AI. And so in a lot of ways, I feel like the people that are most suffering in healthcare today are physicians today. I feel like we're like the sandwich generation, where you look back 30 years ago and you imagine, okay, well, doctors 30 years ago had it easy. You know, I didn't practice then, but people told me they used to treat MIs with bed rest. You know, how easy was that? Like, you used to have only 10 or 15 patients you had to treat in the hospital. You didn't have a census of 35 patients. The complexity of medicine has exploded. The number of therapeutics have exploded. And so we're all trying to keep up with the demand, with the advances in science without these tools. I really think that doctors 15 years from now will look back and feel bad for us. Like, how did you practice medicine without these tools? How did you manage all these administrative tasks without these tools? So I think that the practice of medicine 15 years from now will look more like the practice of medicine and less like the business of medicine.
Yeah, well, I, for one, am looking forward to the time where I get to tell my medical students that I was walking to the hospital uphill both ways.
Yes. Yes, you had to fill out forms manually.
Exactly.
Yeah.
I'll lay it on very thick for them. So for the audience in the room, feel free to raise your hand if you have a question, and I do see that we have one there. For the audience online, you can submit your questions through our conference website, and I'll be able to read them out. So I see one question in the back here.
Yes, thank you. So you know, here in Canada, we have a public healthcare system, publicly funded. So of course, budget increase are an issue. So with AI, in your experience, do you only see an increase in productivity, in efficiency, or is there any place for cost saving with AI?
Yes. I mean, that's, if you go to these health IT conferences, there's a lot of debate around productivity, right? What's the ROI of these new technologies? When it came to ambient scribe, for example, there was these amazing claims by vendors that they would save physicians an hour, 2 hours a day, and that they would otherwise spend writing their notes. Studies that have since come out have not validated those levels of productivity savings. I mean, there is time being saved, but it's on the order of minutes, not hours. Nevertheless, though, physician perception of time savings is much greater, which is quite interesting. And physician satisfaction is much higher, right? So there are real benefits, but it may not be necessarily measured in, oh, well, you can see another 2 patients. You know, you've saved so much time, now you can open up your panel for more visits. So I'm actually a little bit conservative when it comes to productivity gains. And the truth is, if you look across the innovation landscape, there's this concept called the productivity paradox, which is every time you introduce a new platform technology, like electricity or the internet or personal computing, and now with generative AI, everyone expects to see an immediate bump in productivity. But what researchers have found is that there's often a 10 to 15-year lag from an introduction of a new technology to seeing productivity gains statistically. And the reason behind that is because you have to completely redesign workflows, again, like I said, in processes around that new technology. So when you go from steam-powered factories to electric-powered factories, if you just change the source of energy, you're not actually changing the work people do or how it gets done. And so, you know, every time I go talk to our customers that pay us to care for and insure their members, they're always asking about, Daniel, your rates keep going up. How are we going to manage this? When is AI going to take our rates down? And I do say patience, you know, I don't think this is going to significantly cut costs in the next few years. There are opportunities for efficiency, so I also don't want to throw the baby out with the bathwater. There are definitely more back office use cases where we're starting to see productivity gains. I'll just give you one example. In California, we have an insurance regulation where we have to send letters. If we send a letter to one of our members, it has to be in the language of their preference. So if you're Spanish speaking, we send you a letter, it should be written in Spanish. Or if you're Chinese speaking, it should be written in Chinese. And so in order to abide by this regulatory requirement in the timeline that they set, which is 2 weeks, we have to go through a third-party interpreter service to translate all of our letters. And it costs something like $45 to $90 to translate every letter we send out. And so we're exploring the use of generative AI to do a first pass at translating these letters, which are then reviewed by a qualified human translator. But in that process, cut that cost in half, right? So just that one use case alone can save us several $1 million. Now, Kaiser Permanente, our revenue is $115 billion per year. So that use case is not, it's not going to make an impact on our top-line budget. But if you can imagine an aggregation of those types of efficiencies, eventually, you may start to see it in our top-line budget. So it will lead to efficiencies. But if anyone tells you this technology is going to cut your cost by 10%, I would be very skeptical.
Fair enough. So we'll take an online question, and then we'll go to my right there. But first, can we talk about bias in AI for women and people of color and how that is mitigated?
Yeah. So first, let's just talk about bias and algorithmic discrimination on all protected characteristics and how it even gets introduced into these AI technologies. So I like to think about AI like a giant mirror to our society, right? All it does is it just mimics patterns it sees in the data. So why might algorithms be biased? It's because we live in a society that's biased, right? That has structural biases, that has human biases that are sometimes embedded in that data. And so if we're not careful, all it does is just mimics and perpetuates those same biases. So I'll give you an example. Researchers at UC Berkeley looked at this algorithm that was developed and deployed by Optum, which is the 800-pound gorilla in healthcare, owned by United Healthcare, or United Health Group. And the purpose of this algorithm was to identify patients with complex medical needs that would benefit from case management, right? Population health, can understand why that would be valuable. The researchers found, though, that when you take a white patient and a black patient with the same exact health status, the algorithm would disproportionately favor the white patient for additional services over the black patient. So on face, not fair. How did this happen? It wasn't that the developers of the algorithm biased it, told it, hey, we want you to prefer white patients over black patients. It was actually a much more subtle reason. It was because the developers of the algorithm used healthcare cost as a proxy for healthcare status. And what they didn't realize was it's a biased variable. Black patients on average with the same health status as white patients spent or cost the health insurance company less money because of structural barriers to accessing care. That's how you got a biased algorithm. The other source of bias in algorithms is the training data set. So there was this JAMA article, a research letter that got published some years ago that found of the public data sets that are used to train these algorithms that are published in the peer-reviewed literature, 70% of those training data sets came from just 3 states in the US: California, Massachusetts, and New York. Now, you can understand why it would come from those states. You have great institutions, places like Stanford and the Harvard hospitals and NYU, but that doesn't reflect the rest of America. And so a colleague of mine from Mayo Clinic, John Halamka, would say, hey, Daniel, we can develop the best-in-class AFib detection algorithm at Mayo Clinic. We know it works extraordinarily well for white Protestant Norwegians in rural Minnesota. But how well does that work in Oakland, California? We don't know. It could work phenomenally well, but it has to be tested and validated in that population. And we shouldn't assume that it does work well, right? So we have to be thoughtful around how is this algorithm trained on what data? Does the demographics of that population reflect the demographics of the population that I practice and that I serve? So those are ways that bias can get brought in. There's another form of bias that actually has nothing to do with the algorithm itself. It's what you do with the outputs of that algorithm. So for example, a common use case we see is an algorithm to predict which patients are not going to show up in clinic. And by predicting those patients, the idea is you can open those clinic spots up to people that are on the wait list, right? Again, makes a lot of sense. But what people found was that the people that don't show up often struggle with these social determinants of health. They don't show up for a reason, because they don't have a car, or they don't have reliable childcare at home, or they can't take a half day off work, right, without losing their job. And so if they overcome all of that and do show up in the appointment, and now they've been double booked, you're inadvertently worsening access to care for these individuals, right? So you can take that same algorithm and you can just flip the output of it. So instead of trying to predict no-show rates to double book, if you were predicting no-show rates to identify who you should outreach to, with the goal of increasing the likelihood they do show up, right? Calling them, hey, do you need transportation assistance? Maybe we can switch your visit from an in-person visit to a virtual visit. Maybe we can move the time around if this time doesn't work for you, right? Again, it's the same algorithm, but the output of that changes from a program that exacerbates bias inadvertently to one that addresses it. So those are just, I think, to mitigate it, you have to understand the cause, right? The treatment should really fit what's underlying the issue. It is a very complicated topic. I wish there was a one-size-fits-all. I wish you could just say, if you were to do this test and it looked good, you're good to go. It's not that simple. There are, again, policy solutions that intend to try to debias these algorithms, but the other thing that people would say is, if you want a perfectly unbiased algorithm, a terrible working algorithm for everyone is unbiased, but it's not useful to anyone either, right? So we have to be careful that an algorithm may perform differentially in different populations, which doesn't mean it's bad, right? We just have to be thoughtful about how we use it, and just, again, keep coming back to the core principle, at least for us, is our goal is to reduce health disparities in our communities, right? Is this algorithm serving that goal? That's the perspective we bring to it.
Mm-hmm. Yeah, that's a very important conversation and work that never ends, truly.
Yes.
So we had a question from one of our audience members.
Yeah, thank you. Hi, I'm Lee Donahue. I'm a family physician. I actually work quite close to here in an extraordinarily poor neighborhood of Ottawa, and we do have poor neighborhoods in Ottawa. I was very taken with many of the points that you've brought up and appreciate them. One that I did want to hear your reflections a bit more extensively on would be on this idea of one to manage many. I've been in practice a long time. Some of the children and teens that I first cared for are now grandparents, and I also got to care for their grandparents when they were early in my practice. So I'm curious about it, and if you have some brief details for us about how your clinics manage that, and in the context of longitudinal comprehensive care.
Great. I will say, I always get a question on, tell me more about this one-to-many, Daniel. It sounds interesting, but what does that actually look like? So I'll give you one example from healthcare and then some examples outside. So when my wife was pregnant, we got our care at UCSF. And there was a prenatal program that we participated in called centering. I don't know if this is something that people do here in Canada, but essentially, instead of individual one-to-one care with your midwife or with your OB-GYN, it's group classes. And so what they do is they create a cohort of pregnant women around the same gestational age, and they meet together as a group once a month. And it's a conversation that's facilitated by both a midwife and an OB-GYN. And the learning, it's peer-to-peer learning. I mean, it's like, hey, I'm suffering from morning sickness. What should I be doing? And you're getting advice from other women in similar situations. And you do have the one-on-one visit. So the doctor, the midwife may pull you aside. They'll take your vitals. They'll make sure you're vaccinated. They'll, do an ultrasound if they need to, et cetera, et cetera. So you're getting those touch points, but really the magic happens in the conversation with your peers. That is a one-to-many model of care. The outcomes that UCSF has shown is that are similar, if not improved, through that model of care. And you can imagine it's a little bit more efficient, right? Because now you can have a cohort of 20 women in conversation together with 2 providers, as opposed to 20-minute visits for each of them. When you look outside of healthcare, education is a one-to-many model of care, right? We all have gone to classrooms. There's 1 teacher, there's 30 students. There's an efficiency there. It's kind of crazy to imagine if we were to have our education system where everyone had a personal tutor, and we're saying, oh, we don't have enough personal tutors. I think that's ideal. And there are definitely issues with the classroom environment when you have 40 students and 1 teacher. The biggest issue is personalization, right? Is that students learn at different paces, and the teacher kind of has to teach to the median of that class. And so you get some students that feel like they're not being challenged. You have other students that feel like things are moving too quickly. And so actually, there's a great book from Sal Khan, who created Khan Academy, that talks about the potential use of AI in education. And this has really inspired for me this concept of the one-to-many model, where he solved this. The first thing they did with Khan Academy is, how do we create asynchronous learning, right? So how do we allow students to learn at their own pace? They put a lot of videos up on YouTube. Students can then learn math at their own pace, as opposed to needing to go at the pace of the classroom. But again, the big issue that they were dealing with was students had different learning styles. And so again, even though you've solved the pacing issue, some students learn differently than others, and so you need that personalization. And so what he's very excited about is the use of AI as these personalized tutors that can understand your learning style and ask you questions and kind of nudge you along. And they talk about the flipped classroom model, where most of the learning happens at home. And then when you go to class, the teacher is helping you resolve issues that you're struggling with, right? So the teacher is not spending all their time teaching you the core concepts. The core concepts are being learned on your own. And so I think for healthcare as well, is like, we kind of had this belief that healthcare happens in the exam room. Like, it doesn't. You can only do so much in a 20-minute visit. You can do a lot over time, but healthcare happens, our outcomes happen outside of the exam room when we're living our lives. And so, I'm piloting this, it's kind of like a wellness type thing. It's actually to address diabetes and obesity, but I'm just experimenting with it. And what it does is it puts sensors on your body, and it builds this twin of you. So it's actually developed by the person that created technology for Tesla, autonomous driving. And what it does, it tries to predict your individual response to particular foods and exercise. So again, when we practice medicine, we're practicing for the median. And so this would say, Daniel, if you had those 2 pieces of toast, you would have a different reaction than Carl. Your blood glucose level spike might look different. The impact of walking 10 minutes before you have those 2 pieces of toast might mitigate it in a different way. And so what it does is it provides you nudges throughout the day that helps make healthy food choices and exercise choices. And it's mostly AI-powered. There are human health coaches, there are physicians. The outcomes that they tell us is quite remarkable in terms of deprescribing medications, especially expensive ones like GLP-1s. But again, that's an example of personalized care that's one-to-many. You have one, actually in this case, nurse practitioner that's supporting a large cohort of patients with diabetes that's providing, the whole program itself is providing very personalized, interactive, literally, people are interacting with this app 15 times a day. So the number of touch points increased is so dramatically increased. And so that's where I feel like you can get this one-to-many care that is more personalized than the care that we provide, more efficient, and it doesn't replace the longitudinal relationship with providers. I think it's really important to know that for all the great things AI can do, it can't replace what we want doctors, which is to like help us accompany us through our most difficult days of our lives, right? Through illness, to understand us as people, to understand our preferences. I think that that longitudinal relationship is the differentiator that will make doctors more important. But managing hypertension and diabetes and medications, you know, at Kaiser Permanente, we support our nurses to do a lot of that work with algorithms. And so if nurses with kind of like decision tree algorithms can support a lot of that work, I think AI can help as well.
Thank you. So we'll go to one of our online questions, and then I have a question from the front of the room here. Can you comment on the rising environmental impact of AI energy needs?
I know it's an increasing issue. You know, one of the interesting things to watch from the stock market perspective was, you know, first you had all of the chip companies, NVIDIA in particular, that went gangbusters. And then you had all these nuclear companies that their stocks started to rise because of the just insatiable energy appetite of these data centers for running these computing tasks. So it is a real thing. I mean, the fact that like Microsoft are signing these licensing deals with nuclear power plants to power their data centers, to power these algorithms, do show that these are very energy intensive. But if we've learned anything from the technology industry is, you know, and Moore's law, is that there are efficiencies to be gained. And already, I mean, I don't know how many of you have tracked, you know, the introduction of DeepSync, which was this new model that came out from developers in China that in many ways had comparable performance to you know, these foundation models that cost billions of dollars to train from OpenAI and other companies. I mean, we're seeing like exponential increases in performance and efficiencies. So it is an issue. You know, what are we at Kaiser Permanente doing to manage it right now? I think everyone's trying to figure this out. But I also believe that we will see improvements where right now they're very energy intensive. I think everyone expects those, the efficiency will get better.
Well, hopefully for our planet.
Yeah.
Question in the front of the room?
Good morning, I'm Nick Newhammer from the Canadian Association of Radiologists. My question is about the clinical involvement in procurement and then change management and on AI. And I want to say that we've run 2 surveys, national surveys with Nanos survey about asking patients about their comfort level with AI. Consistently, both surveys have responded yes to AI, but AI with clinical oversight. That's validation and ongoing surveillance. So the CER, Canadian Association of Radiologists, created the Health AI Validation Network that provides national guidelines for validation of AI on a local basis, as well as ongoing surveillance. We believe that this would help not only systems, clinicians, patients with an ethical oversight and understanding to provide the reassurance. But I'd like you to expand on Kaiser Permanente's management of the procurement of AI, because sometimes AI is sold as the silver bullet.
Yeah.
This will fix everything. But wait a second. Does it work locally?
Yep.
So can you talk about the, like right from the sort of the inception of AI, the level of clinical involvement in procurement of AI, and then the value of clinical quarterbacking, if you will, of the validation and change management and introduction of AI solutions?
Yeah.
Thank you.
First of all, I mean, the work that you just described around validation, oversight standards, to me is very much in line with what I described about building that human stack for AI, right? And really building those layers of assurance and testing and confidence. So one, I want to just make that connection there. But two, yeah, what level of clinical involvement is there when it comes to procuring AI at Kaiser Permanente? So first and foremost, I want to say all all of the clinical AI technologies we deploy come to us from clinicians because they're solving a really important issue. So I will say among the radiology community, there's a little bit of consternation to say, well, every other doctor has this scribe. Where's our scribe? I want help with transcribing my note. Like they were early users of the transcription service, but they want solutions that also help to produce a structured report from their unstructured findings, or even assistance in helping to read that they can then modify the report. So for example, that was a project that was driven by our radiologist around next generation reporting. So one, we're not in the business of telling our providers what technologies they should be using. It's the opposite, where the providers tell us what technologies they want, and then we go through a vetting process to say, okay, well, there are a lot of vendors in this space. How can we select a vendor that gives us a technology that performs well in our environment, that has the sufficient cybersecurity guardrails put around it? So, Kaiser Permanente, because of our size, we have very kind of rigorous and intense procurement process. I kind of like to think we're like Costco for healthcare. Because we can procure in bulk, we really put our vendors through the ringer. Like, they need to meet our highest standards for cybersecurity. Obviously, we're looking for a good deal from a cost perspective. And when we talk about responsible AI and voting with our dollars, I mean, it's really in that conversation. And so once we decide on a vendor, and obviously we're getting clinical input all throughout the way. We don't want a great tool that has great cybersecurity functions, but doctors don't want to use. So we want to make sure that we're getting them the best tool that we can. And then obviously when it gets to the deployment of it, that clinical change management is all clinical. So we have chief medical information officers that really quarterback a lot of that work in close partnership with our IT teams. And so that's exactly what happened when we deployed our ambient scribe technology. We had not only hundreds of IT staff, we had hundreds of physicians that were early users, providing very close feedback, champions of this technology. So we had many of the different specialists. We had early users take the technology, test it, validate it. How well does this work in ENT versus oncology? So absolutely. I mean, I feel like our success at figuring the process piece out is only because we partner so closely with our clinician users.
So thanks everyone for your questions, and thank you, Dr. Yang, very much for your insights. I really appreciate your impassioned plea for AI and also for anesthesiology, let's be real. So thank you so much for being with us.
Thank you so much.
And for coming all this way.
All right, thank you so much.
So Dr. Yang talked to us about the need for new technological tools for our patients and for our health systems. This next session is about exploring the profound ways that these new technologies, including artificial intelligence, are reshaping not only how we deliver care, but how we connect with and empower patients. So we're thrilled to have Eddie Guo, a medical student innovating AI tools like OSCE AI for medical education, Angus Pratt, a passionate lung cancer patient and advocate, bringing a vital patient perspective on biomarker testing and precision treatments, Dr. Carolyn McGregor, a pioneer in AI and sensor data applications, revolutionizing healthcare projects through projects like the Artemis and Athena AI platforms for health, and finally, last but not least, Dr. Kaylee Shukalek, a leading voice on at-home virtual care and the evolving regulatory landscape. Each speaker will have 5 minutes to share their vision of the future, revealing how AI, big data, and virtual care are pushing the boundaries of precision medicine, reimagining clinical education, as well as decision-making, and transforming patient advocacy. So, Eddie, I'll invite you to start us off once you're ready. Welcome.
Thank you. So, I want you all to picture the following scenario. Sarah, a single mother living in a remote community, wakes up feeling feverish and unwell. Instead of waiting days to find a family physician and arranging for childcare so that she can actually attend her appointment, she instead logs on to a virtual clinic where she speaks with a conversational AI agent. The system explores her symptoms, reviews her past medical history, and even provides education on her condition and the next steps that she has to do. Within moments, Sarah has a care plan and is offered to be connected with a care team that has appropriate handover for her. And so for Sarah, this isn't just her future, this is her everyday life. Now, Sarah's story illustrates how AI can provide not only convenience, but they can also provide timely care as well as access to care. Many patients nowadays are suffering from chronic conditions, overdue treatments, and delayed appointment times. And so AI aims to meet patients where they are by providing real-time guidance, by actually, providing personalized care and addressing some of the misinformation, especially in this era of misinformation. And so now I want to talk a little bit more about the specific AI tools that were illustrated through Sarah's story. Firstly, conversational AI. Within the general domain and not just medicine, we're beginning to see tools like ChatGPT, like Google's Gemini, that provide voice AI systems that allow you to communicate with them naturally. And even within the Canadian healthcare context, we have apps such as Scribeberry that allow you to directly speak with the app and at the same time have documentation. And this brings me to the next idea of the ambient AI scribe that was described in the previous talk. It will aim to save patients, doctors a lot of time in terms of the documentation. And where I'm from in Calgary and Edmonton, we're now beginning to see the evolvement and testing of some of these agents that will allow you to talk with the patient directly and have the note written up for you with you just needing to review and sign off on it. And so you might be wondering now, how can I possibly incorporate this into my practice? And won't it disrupt the essential face-to-face time that I have with my patients? And so I want to challenge the notion that AI is about dehumanizing care. I think in reality, a lot of these AI tools are really focused on working in the background, reviewing the medical history that's there, listening in on conversations, providing timely reminders. And I think that all this put together creates a package where it really allows you as the physician to actually be able to focus on what actually matters, that patient interaction that you have and the plans you make for your patients. And so now I want to switch perspectives from Sarah's story into more of an emergency department. So I want you all to imagine that you are the emergency physician on call. And you have a patient coming in from a car accident, and they have a tiny brain bleed that you're really not too sure what to do with. You have conflicting reports, you have a really time-sensitive situation, and so instead you turn to an AI system that reviews the imaging, triages for you, and provides suggestions on what's there. And while this sounds potentially very futuristic, it's actually being tested right now in St. Michael's Hospital in Toronto. So for example, this AI system, for anyone with a trauma brain CT scan, it will review that imaging, and then it will, if it's an operative decision, it will directly send a referral off to neurosurgery. And so not only does this reduce the time from door to treatment, but it also saves you as the emergency physician a call to the very scary neurosurgeon. And so putting all of this together, I think that AI has a lot of opportunity for both patients as well as physicians. It allows for interactions that potentially wouldn't be possible with the time limitations of 10 to 15-minute meeting. It allows for the opportunity for patients to actually access care that they really do need. And I think that with all this being said, AI really offers an opportunity. So the next natural question you might ask is, how do I incorporate this into my own practice? How do I get started with all this technology? I'm not a techie person, so how do I start? And I think you're already making a really great choice by being here at this talk. Talk to your colleagues, see what they're up to. Start playing with some of the tools that are out there. For example, there's Open Evidence, ChatGPT, Gemini. I can keep on listing these things out. But the really first next step is really start playing with these tools, seeing what they can do, and seeing how they can fit into your practice, with the caveat that the tools today are probably at the worst that they're ever going to be. And so with all this being said, like, for example, the speech was created partially by ChatGPT. So imagine how good this speech would be if this was 10 years into the future. And so I want to return back to Sarah's story. And while her story is fictional, I think it offers a vision of what's possible, a vision of what's possible for our patients. And I think that if we all come together and work together on this and really take the opportunity to explore and use these tools and have conversations around it, we can make this future a reality. Thank you.
There's supposed to be a disclosure slide. But there it is. There it is. I actually have more disclosures than that. The first one is that a week ago, I was sitting in a chemo chair. And then since I'm losing hair, I think I'm probably losing some brain cells. I'm used to making this kind of speech very spontaneously, so I have a little bit of a helper here. I also may appear to be a little bit preoccupied. Last night, I got an email from inviting me to begin the process of a trial of one, talking about a cancer vaccine for lung cancer. So if I seem a little preoccupied, it's on my mind. Vaccine hesitancy, not a chance. If I get the opportunity, I'll be taking it. The second or the third disclosure is, in the interests of AI transparency, I took my talk and ran it through ChatGPT and asked it to rewrite it in the style of Dave Chappelle. I take full responsibility, and I just banged the microphone, I apologize. ChatGPT, Dave Chappelle, if it's not funny, it's because it's me. I'd like you to imagine for a second that you're sitting in an exam room, one of those cold, white, sterile exam rooms. The silence is absolutely deafening. You hear a knock on the door, and in walks that white-coated oncologist, and he looks at you, and he says, "Mr. Pratt, I have some bad news for you. Your lung cancer is stage 3C. It's as close to stage 4 as I could get without actually kicking you over the line." And at that point, he went to a whiteboard, and he drew a set of lungs, and he showed me where the various tumors were, and then he wrote a number next to it, 5%. And he turned to me and said, "That's the number of lung cancer patients with your stage that make it to 5 years." You'd think he could have done that a little bit more gently, but it is what it is. But here's the crazy part. I was diagnosed in 2018, and here I stand in 2025. So either there are some real miracles in modern medicine, or there's maybe a glitch in the medical matrix, and I just happened to get caught in it. If you hang around the cancer world long enough, you're going to hear the phrases personalized medicine or precision medicine. Yeah, they have finally discovered that giving every cancer patient the same chemo treatment, it's sort of like giving everybody the same haircut. It doesn't work. It doesn't. And so what I'd like to talk to you about is that whole idea of precision medicine and the idea of biomarkers and how it is dramatically changing the face of lung cancer and cancer in general, in fact. So what is biomarker testing? Well, basically it's CSI, Cancer Edition. They dive into or the oncologists, the pathologists, the molecular pathologists dive into your DNA and figure out what kind of mutations you have. And based on those mutations, they begin to design your particular treatment, very personalized. In lung cancer, this leads to something that we have affectionately called soup, alphabet soup. And that whole idea is, you know, EGFR, RET, ROS1, there are a whole wide variety of potential mutations. And so it leads to something that can be quite challenging to follow. But the dream is that every single cancer patient, not just lung cancer patients, but all of us, have access to biomarker testing. Right now, it's a patchwork across Canada. Every province treats it differently. Some get the full meal deal immediately, others get handed a dry cracker and say, well, we hope for the best. There's another part to this as well, and that's the fun part, is getting the drugs. These drugs are ridiculously expensive. They're so expensive they should come with their own private jet. But in my case, what happened was I was given initially chemoradiation with aggressively curative. Then I was put on a brand new immunotherapy, which they don't do anymore because it doesn't work for my particular kind of mutation, but they didn't know that at the time. And so when I saw progression in 9 months, I was offered a choice of the drug that was approved and funded by Health Canada and by the province of British Columbia. Oh, but there's this other drug, a great drug, much less side effects, it crosses the blood-brain barrier, much more effective, but it's 30 grand a month and it isn't funded yet. So you face this choice of good drug or great drug. For me, I was fortunate. I got the good drug, I took the good drug, and it worked for me for almost 5 years, which was almost 3 times as long as they thought it would. It was simple, it was a simple pill a day, I still remember walking into that same cold, sterile exam room. The oncologist walked in and said, shrinking and disappeared. What a marvelous feeling. Saw progression about a year ago and started a whole range of chemo treatments, but that's a different story. What I want to say is that in Canada, it takes about 2 years longer than it does in the US to get those drugs approved. That's 2 years of watching Americans getting better drugs. And we sit here waiting for the leftovers. I get it. Public health care means making tough decisions about how you spend your resources. But for 2 years of cancer time, that's like 20 years in normal people time. Technology is really changing cancer treatment faster than our systems can keep up. We need to stop playing catch up and start building a system that actually works with precision medicine. Because the future of healthcare isn't just about better medicine. It's about making sure that the people who need it can actually get it. Otherwise, we're just writing 5% make it to 5 years on the whiteboard and hoping for the best. Thank you.
Thank you. Well, how do you follow that? In my world, I deal with high-frequency data. I deal with a very, very granular digital twin. I started off in neonatology with a personal drive to help more children survive by looking at every heartbeat, every breath, every blood oxygen saturation reading. 500 to 1,000 readings a second of electrocardiogram, and looking, are there ways we can use just that data to be able to predict and detect and actually advise the clinicians what we were finding in those particular fields that related to what we were seeing for changes for different conditions. And then I listened to the talk that we had this morning, and I want to draw it back to what does this mean for the future outside of neonatology. I monitor firefighters, tactical officers, and even astronauts now. I monitor humans in extremes. But what's that going to mean as a clinician with an individual patient? So I would normally come into a clinician's office when I was feeling unwell. And I would be presenting my descriptions, and we heard this morning that now we have these solutions where the clinician can turn towards me. And then I can be interacting with the clinician. But what if I did something different? What if, when I was presenting what I needed to present, that I was still facing the clinician, but I had this? And when I was describing me, instead of me saying I've been feeling run down and unwell for the last few days, that I brought up an avatar on my phone. The avatar is presented in a way that I feel comfortable that they're representing me. So by skin colour, hair colour, appearance, it's what I've chosen. And they speak with an Australian accent because that's what I've chosen. And the avatar comes on and says that over the last 5 days, Carolyn's heart rate has been elevated. She's had 3 tachycardic events that were all in the one evening between 2 and 4 in the morning. And it proceeds to go through information about my blood oxygen saturation levels in a different day. But then what's more? They say, this avatar on my behalf says that for 3 days, for 6 hours, Carolyn was in 50 degrees Celsius. And I pause it at that point and I provide some context because at our university we have climate chambers. And I work with tactical officers and firefighters and we test things at extreme temperatures. So I was in 50 degrees. Now as an Australian, I know that I'm more used to that, but it still presents the information. And it presents information about what was happening in my physiology during that time. And it also presents information that on the weekend I'd gone to a theme park with my children because it knew the location. It was describing information. Now that's what I chose to present. But I have another app on my phone that's tracking my fluid intake because I have interest in that. Now I've got to make the decision about whether I present that information on the fluid intake to my clinician that I'm meeting with. But I have all of this data. And all that it was doing is presenting you very rudimentary summaries, minimal level of AI. But the human avatar makes that whole experience very comfortable for me and many people. Because when you put an avatar in front of a list of summaries and they're reading it, people trust it more because they look like me. That's actually been reported many times. So now we have this conundrum in the next wave of healthcare that I'm the one with all the data about me. And how do I give it to you? And is it my AI or your AI that analyses the data and does the differential diagnosis? And this is some of the challenges we're going to face. And how do we decide of all the things that are being tracked with me, with my wearables, with what's running on my phone, and I'm using the phone now rather than a future device because you can do many of these things now. And how do I do this then? And how do we decide whose differential diagnosis and what the role then in the clinician experience? Because at the end of the day, I haven't chosen to have a differential diagnosis on my phone. I've chosen to go and speak to a doctor. And I have that choice. And even though there was a comment this morning with the millennial comment, there are millennials who still like to go and see doctors. There are Gen Zs that still like to go and see doctors. that these are some of the things we're going to have to look at in the future when we think about who has the data, whose system is going to run the AI, and where do we go from there. So thank you.
Hello, everyone. Allowing me to present virtually. I'm Keely Shuklak, and yes, these are my disclosures and relationships. So first, thank you to all the other speakers. I had pre-written my speech and then figured you're all going to say things just like Dr. Yang did actually in his keynote just before this that I think relate to what I wanted to talk about. And I have an interesting perspective of having built out a health tech company and repurposing that technology company into a health service company within Canada and now actually within the US. And I, what really motivated that is my own awareness, both as a physician, obviously, but as a patient who would potentially use those health services that we were actually building out using technology. And I think to some extent, clinicians, physicians, like such as ourselves, don't often think about our duality as both patients and professionals in the healthcare systems enough in terms of how we leverage and how we think. But ultimately, when it comes to Canada, I have a firm belief that patients want care, and our universal healthcare system has so many wonderful things about it. But there are limitations, and those limitations are becoming more and more and more evident as we see, issues with access due to simply numbers of providers, availability of them. And that's compiling on top of, the issues of geography here in this huge country we live in, with sparsely populated areas and these large urban centers and how patients access. And, to Eddie's point, this beautiful example of technology being that first point of connection for patients and providing them this direct funnel into healthcare providers is, what I myself have tried to help build, in a pre-AI state before AI has, maybe all of those abilities and all of that. We're sure enough that it can do those things. And part of that sureness or part of that, ability to use those things comes from regulatory pieces. And I want to focus in on some of that regulatory aspect. Angus made a mention about this with medication approvals and the delays that we see in Canada versus, other countries, say our, neighbor to the south. To what Carolyn is discussing is, these are things that, also if it's considered a medical device, are going to have to go through those processes. And what is that timeline? And in terms of those regulatory approvals and in a universal system like this, what is the, potential funding for those types of things? What I really worries me in this, how do we be innovative in how we leverage technology for both the benefit of the healthcare system and probably more importantly for the benefit of patients and their individual care is how do we be sure that the technology and the innovation we're using is safe, adequate, high quality, and how do we make sure that to Dr. Yang's point earlier, that there is some, I'm going to say dispersion of medical legal liability across the various stakeholders, the vendor, if there's a system, the provider, and ultimately actually on the patient as well in terms of, that autonomy and how they use it and everyone is doing their part. And I, as someone who's built something across the country and into the US across, nationally and across each state is, my ultimate frustrations and the issues that we run into with regulators. And that's regulators on the government level, on a national scale, thinking of Health Canada, thinking of the FDA. That's on a provincial scale, thinking of the various colleges from nursing, pharmacy, physician, and to be perfectly honest, the almost complete lack of communication between them, or at least outwardly seemingly lack of communication. There's issues like, in the US, the FDA recently issued statements around HIV dried blood spot testing, which is home-based testing for HIV that is internationally recognized in WHO documents, and the FDA been used in the US for well over a decade at this point. But the FDA has made an about face to, now step in and say it needs to go through primary health system trials and efficacy trials, despite all the real world evidence, and both in the US and internationally. Health Canada has a very different approach to those types of things. As we look at various technologies and how, like AI, and how it's leveraged, we don't even see those things being commented on yet here we are with multiple people in a row talking about how AI is going to change technology. And so I think about how regulators affect the way we practice and the technologies we use and how we innovate as healthcare providers, as healthcare systems, and recognize the need for us as individual providers and even as patients to just call it Angus and all the work that Angus does in this regard and advocacy is, how do we apply pressures to governments and to colleges of all varieties to collaborate and to move quickly, and as quickly as technology is moving, because they are dragging behind and they will fall even further behind as time progresses. And they need to be forward thinking and they need to work together, because we can't have piecemeal province to province, state to state, country to country. We need to be thinking about this in a way where it is synchronized, it's collaborative, and that's on the individual scale. And similarly, the CMA has that same potential. And so, I leave this with more a call to action for each and every one of us, and for the CMA, and for every other professional association out there who has the ability to advocate to regulators, to governments, to be more collaborative and fast and forward thinking in how they intend on ensuring that all these advancements truly do benefit patients, providers, and the systems that we all live in.
So I want to take some time to thank all of our presenters for this session, and I'll invite you to stay with us for another couple minutes. Before we break for 30 minutes, we have a question for you to answer for our speakers and for others in the room. For those of you who are virtual, the question will pop up on your screen. So we'd like to know in 1 or 2 words, what is critical for us to keep in mind as we incorporate new technologies into patient care? We'll give everyone 1 minute to answer, and hopefully the presentations this morning have sparked your imagination to answer it. So privacy seems to be a big one for people, which makes sense as we're integrating new technologies that come from developers that we might not know. Trust was a big theme this morning. Humanity, so keeping patients, physicians at the forefront of what we discuss, the avatar being a good example of that. We see equity being a big one as we introduce new tools that might have some bias ingrained in them, and trying to eradicate that and improve on that as we develop further. Access, so I'm thinking access for patients to these tools, access for physicians, access for every healthcare professional, and also access to training for these tools even. And then bias comes up as well, so same sort of theme as equity that comes back. And patient safety, which is always very important to keep in mind. So I think that gives us a good pulse of what's going on in the room and in our minds after all these presentations. So with that, we'll invite you to join us in the foyer for a light snack. We'll start again at 11:15. After we come back, we'll have a presentation by political strategist Latoya Jones for a Pitch the Minister session. So you'll really want to be back for that to not miss her energy and passion. Okay, perfect. So while people are walking back into the room, I would like to welcome you back to this next portion of our Health Summit. So this next session will be a two-part interactive session. First part before lunch, second part after you've had a little bit of sustenance. So CMA President Dr. Joss Reimer will be joined by Latoya Jones, a political strategist and community organizer, who will walk us through the core elements of developing an advocacy pitch. By the end of this two-part session, we'll hope you'll feel empowered with the skills and tools needed to craft an impactful and concise message and actionable solutions for decision makers. So far at this conference, we've discussed all the things that we could be fixing about our healthcare system. Now it's time to put those thoughts into action. So without further ado, I'd like to invite Dr. Joss Reimer to introduce our keynote speaker.
For me to be part of this next session, and to be able to introduce this next guest is truly a privilege, and I'm excited for you all to get to listen to her speak. When we planned this months ago, we had no idea how good our timing really was going to be for a session like this, because we are in the middle of a federal election, and you will potentially literally have candidates coming to your door to ask you what matters to you. They're going to be asking you for your votes. And so we want to prepare you so that in those moments, you know what to say, you know how to respond. And after the election, regardless of which party forms government, there will be an opportunity to ensure that health and healthcare remains at the top of the political agenda. And so today, we're going to get to talk about how you, as medical professionals, as health experts, as patients with lived experience, how can you be effective in advocacy? How can you help us at the CMA in pushing for these changes that we need to see? And believe me, I have heard her speak, so believe me when I tell you that Latoya Jones knows how to get a message across. We are so thankful to have her with us today. She is an accomplished political strategist. She's an organizer, a respected community leader. She has more than 20 years of experience. She's worked on presidential campaigns. She's worked on gubernatorial races. For those of us in Canada who don't know the word gubernatorial like me, that means governor races. And she's also done movement building efforts, particularly aimed at empowering those communities who face additional barriers and who are not well represented in leadership. She's currently the Senior Vice President of Government Affairs and Political Partners for Hustle. It's a progressive digital communications company, and so please join me in a very warm welcome to Latoya Jones.
I'm sorry, can you play the music again for me before I start? I'm gonna need y'all to dance a little bit because this is fun. Okay, come on. That's not enough. I'm not gonna start till y'all give me some energy now. Come on now. All right, we got some work to do, y'all. We got some work to do. How y'all doing this morning? Afternoon, evening? How are y'all doing today? Okay. Look, I am Black and I'm from the South, so when I say how y'all doing, I want y'all to respond back. Call and response. How are you all doing today? Thank you, thank you, thank you. You all will realize I have a lot of energy. I will offend a lot of you in this room. Unfortunately, that's not my fault. That's your fault because you kind of have some little issues if you're easily offended. But in this, we're going to talk about how to pitch. I'm going to start in like 1 second, well, like 1 minute, but I want to give you all some ground rules. It's going to be a lot of information. It's going to be fun information. But all this information, I need you to center yourself, right? Figure out how you can center yourself in this conversation. I am all the energy. You might not be all the energy. So don't try to be me. Be yourself. But if I ask you a question, I do want you to respond. I used to work for teachers. I can call out students if I need to, all right? Those are ground rules? Those are the ground rules? Thank you, thank you, thank you, thank you. All right, also, I have to do my disclaimer. I have no political affiliation. I'm saying it wrong, but this is my disclaimer in French and in English, no external relationships. Thank you. I do not work for Big Pharma, So don't have to worry about that, okay? We cool? All righty, so, all right, we're about to start. How many of you all know who Thanos is? Okay. How many of you all know about the Avengers? I mean, I'm gonna give you all a pass because you all are doctors, so that means you probably were not watching movies and things of that nature. So if you don't know, when you get some time, figure that out. But in this conversation, we're gonna talk about how to build power and how to persuade Thanos. And for this, Thanos is actually gonna be your MP. Whoever's in power, that's who you're gonna try to persuade. Got that? All right, so we've already went around Thanos. All jokes aside, in today's climate, particularly in today's climate, it can feel like persuading a politician is as tough as persuading Thanos. Sometimes getting your ideas can feel daunting, overwhelming, and downright confusing. So when you think about this, if you're trying to persuade somebody to do healthcare reform, emergency room expansion, or tackling medical backlog, it's like a Thanos snap. And for you all who don't understand who Thanos is, he was like the big villain, and he snapped half of the universe dead. I mean, he had his reasons, but think about that. The snap. Oh, okay, I gotta go to the next slide. There we go. Later on, you all can see I'm in this photo. I might know it. Whoever can find me, you might get a treat, but I'm in this photo. Those are my friends, doctors, lawyers, heroes in America. We're doing the work. But here we are. So the reason why I said Thanos, because Thanos has power. Your MPs have power. They are the ones who control what's happening in your country, what's happening in your community. And it's going to be your job to get them on your side. And you do that by impactful communications. Thinking about how you actually talk to somebody, thinking about how you actually get them on your side, it requires a message. So much like at the end of Endgame, half the Avengers, and you all are the Avengers, they were beaten, broken, other half of them was snapped into existence. But the ones who remained had to figure out a strategy. And to do that, they had to regroup, strategize, and defeat Thanos. And for you all, you have to regroup, strategize, and defeat well, you don't want to defeat your MP. You just want to persuade him, unless you're going to run for office, but that's a different topic and a different session, okay? So, as you are at Thanos, as you all are looking to defeat Thanos, what is the issues? Expand emergency rooms, or reduce medical backlog, that's the issue you're going to be talking about this afternoon. The stakes are high, but when you have the right strategy, the right message, and the right team, you can win. So let's talk about how. And I'm going to say a movie reference. Avengers assemble, but you all are not the Avengers today. You are the advocates. So advocates assemble. Remember that phrase, because later on you're going to have to say it. It might be a pop quiz. So, went the wrong way. You see all that already. There we go. Why messaging matters in high-stakes negotiations. Picture this. Thor and Iron Man. Y'all know who they are, right? Okay, we're going to figure it out later on. So Thor and Iron Man are trying to negotiate with Thanos. But the one wrong word, snap, half the universe is gone. If you have the wrong message, half of your battle is over. You don't have the message, you don't have what you need. It's not as high as snapping half the universe, but if your MP does not understand your message, that can be dire consequences for your community, for medical organizing, for medical policy in your country. So it might not be snapping half of the universe, but it's just as high stakes. So that's why messaging matters. It's the difference between a good, concise message and chaos. A clear, powerful message can unite people. A sloppy one can detain and derail the conversation. When you're negotiating with Thanos, your MP, your message has to be as precise as Hawkeye's aim. That's arrow. He has arrows in the movies. So you have one time to hit the mark to get their attention. High stakes, whether you're fighting for budgets, whether you're fighting to actually expand healthcare, it's all a win or lose games. Heroes have to have plans, and I know you all have heard this a lot, but you all are heroes, but you still have to have a plan. So let's talk about how you do that plan and the importance of impactful communications. In real world, impactful communications, I'm gonna stop with this until I figure out which one's going back and forth. In real world, impactful communications is our superpower. You might have a brilliant plan to fix healthcare, but if you can't communicate it effectively and passionately, it's like the Incredible Hulk trying to do ballet in a tea shop. That was a joke, y'all. Guess y'all didn't get it. Okay. To influence policy, you have to make a message simple, compelling, and emotional. You have to paint a vivid picture that hits them at their heartstrings. Do not give them data. Data is cool. You all live in the world of data. Data will not move your message. Data will not move the agenda. You will lose if you start with data. What you need to do is hit them so you know where they are. So they know where you are, and when they're actually looking at this, so when they think about your message, they feel it to your heart, okay? And I gotta hurry up. So, clear, concise, emotional. Repeat that. Clear, concise, and emotional. Also, once you have clear, concise, and emotional, you also have to know their why. I said earlier, people were like, Thanos, he had a rational reason why he wanted to kill half the universe. He was trying to save the planet. Your MP might actually have a rational reason why. He might be a person who's trying to save, money. He's a community person. You have to figure out what's persuading this person. If you know what their issue value and your core values are, that's knowing is half the battle, because you're going into the conversation knowing how to persuade them. Because why? You have to hit emotion. You have to get their emotions. Emotion is a powerful thing, knowing how you actually can get your MP on your side. So, knowing is half the battle, and y'all can read all of that kind of thing. What if the world had been erased? So, y'all take pictures of this, or y'all can get that later on. So as we're thinking about knowing who your MP is, everybody in here has their MP has a different strategy, a different why. Research. What you have to do is look and see some of the last bills they signed, figure out where they grew up, figure out how they're leaning. So when they come to you and say, you know what, I want to do this, and you're like, oh yeah, this is the one that cares what his reputation looks like. He doesn't want to be the person that says, I closed the ER. He doesn't do that. So that's the work on you all. You have to figure out what the work is, right? And then you have to have a persuading message. A good story is amazing. Researchers showed that people remember stories up to 22 more times than facts. So remember I said earlier, let the data go. Have a good story. You will remember a good story. Data does not matter in this. And I understand I'm talking to scientists and doctors. I'm sorry, again, but data does not work. Stories work. Figure out how to weave a story with some data if you cannot get away from data. But stories, emotional stories work. Figure out if his dog died when he was 12 years old, and talk about how a young girl actually was at the hospital and she missed the dog dying because she couldn't see a doctor. Figure it out. Touch their heartstrings, make them cry. And then you also, I'm a good storyteller, because if I want to make somebody, I get one tear in the corner. I don't let the tear drop, though. You get that one tear when you're telling your story. They be like, oh, she's emotional, she cares about it. That's how you tell a good story. Find your emotion. Even if you have to figure out something, if it's like somebody pissed you off, there goes the cuss word. Somebody pissed you off, use the emotion to tell your story, right? And once you use the emotion, you got to figure out how to counteract their argument, right? Because the other side, they are good at telling stories. But you have to figure out how your story is more efficient than their story. Figure it out. Like, you know what? His dog died, but his dog and his mama died. Find the emotion. I'm going to keep telling you all, research what it is, find the emotion, and then also weave your facts in. It has to be believable. You have to show them a better way, that your side is the better way, because you're doing this for the people. You're doing it for the community. It's not about dollars and cents. You cannot take dollars and cents home when you die. Now, some people try to put them in a casket, different conversation, but you cannot take the money home. You want to make sure you're talking to them about their legacy. Do you want to be the MP that had 100,000 people die? Do you want to be the MP that made sure that little kids can see? Do you want to be that? And so you figure out those counter arguments, and you figure out your counter argument. You tell them, yeah, I understand that saving $1 million is here. It works. But what about saving lives, 1 million lives? What about the look? Figuring it out, because the counter argument is always going to be something you're going to have to counteract. Do y'all get that? So we got to be concise, clear, and what? What? Okay, y'all, y'all gonna be Southern before I end up with this, okay? So think about this. If your MP says something that pisses you off, you have to stay calm and confident, right? So you have emotion, but never let your emotions take over you. Never let it say, because he gonna say something that's gonna piss you off. But you cannot show that. You're like, you know what, I understand that. However, let's go back to why we're here. So you have to make sure you keep your cool. I never keep my cool. That's why I stopped pitching people a long time ago, because I'm like the person like, you know what, let's rumble up. Come in, because you making me mad, it's time to squabble up. Y'all can't do that. Y'all have to stay calm and concise, emotional, but not emotional where you want to knock somebody's head off their block, okay? Remember that. So calm, cool, emotional, and what? There you go. He got it right here. I got, well, give him a prize, right? But also, in thinking about, and I got 1 minute, 42 seconds, and thinking about your story should be your shield. Your story should also be consistent across the board, right? Because the reality is that the more you tell your story, and the more it's the same story with a little bit more emotion, they will remember that. They will know before they come to you, oh, this is their issue, and this is how they're doing it. So the reality is that you have to make sure you're getting emotion, but stay consistent. Stay consistent and always have what you want to say ready. Okay, I got 1 minute. That 15 minutes went fast. Okay. All right. So, are y'all getting this? Is this working for you all? Yeah. Okay. All right. So, what do you do when you have a stubborn opponent? You have an MP. You said to him, and you got the emotions to them. You had the stories 22 times, no facts, and he's just not listening. You get somebody else to tote your water. What does that mean? You find somebody else who is closely associated with you, but not really, and you tell your story to them. Because if you start telling your story to them, they're going to start, oh, that's a good story. And then they're going to start telling your story to other people. It's kind of like the game of cup, right? Or telephone, where you tell somebody, this is a secret. Or they'll never stay a secret. So they tell somebody else, they tell somebody else, they tell somebody else. What happens, now you got your community telling the exact same story, but they're not a medical professional. So they was like, why is this community saying the same thing? Because they care, but it all came from you, and your MP don't have to know. The reality is that as you start telling your story just doesn't have to go with one person. It has to go through the community, all right? So I got 6 minutes left. What's about to happen now? You all at your table will create pitches. Oh, I have official documents that I'm supposed to read, but I don't have them. Can all the helpers stand up in the room? Who's going to help? All right, so this is going to be your team, right? You all, before lunch, first of all, everybody at your table, I'm going to need you all to give me a superhero name. Figure out your name of your team, but whatever it's going to be, I'm going to randomly ask, and the people who I know not looking at me, I'm going to come to you all first, okay? So you all are going to come up with a pitch, and I'm going to walk around and help you. You have 2 articles in your packets, and for the people on virtual, Kate got you. Holler, hey, Kate. Kate's going to take over this part for you all, so online, holler at Kate. Everybody in here, you have 2 stories at your table. You are going to create a pitch. The pitch needs to be concise, direct, and emotional. This is to your MP, your Thanos. We don't want him to snap the world in half, okay? So once you have your pitch, you're going to work on it, and we're going to ask you to come after lunch to show your pitches. Now, if y'all can get that 1 tear out of me, you might get a prize. So we want you to look at the articles, read the articles, figure out what your pitch is going to be, and we're going to do a pitch. Again, it's not as difficult. I'm going to go back really quickly. You got to make sure you know impactful. You got the stories. The stories are impactful. Understand your MP's core values. Figure out what his core values are and center your story around that and framing a pitch. Direct, concise, and emotional, but do not lose your head. That makes sense? I know I missed something. Did I miss something, or I'm good? I didn't miss anything? I'm good. Okay, so y'all got a little bit of taste of LaToya Jones. If I come to your table and y'all talking about something that's not a pitch, I'm going to tell you all to tell the whole room what you're talking about, because that's what we do. We making pitches now, okay? So if you're sharing it at your table, you have to share it with the whole room. If it's not about a pitch, don't share it. So figure out what we're going to talk about. These pitches are going to be good. We're going to do pitches after this. Again, wave your hands, people. These are the people who will be walking around. I'm also going to be walking around. I got my sneakers on today. If y'all see me before, I normally have on heels, but I got my sneakers on because we're ready to go. And they're cute sneakers. Y'all like my outfit? Yes. All right. So y'all ready to get this pitch done? Are y'all ready to get this pitch done? Do y'all feel confident y'all get a pitch done? Okay, let me say, this side don't speak no more because y'all in it. Right here. Are y'all ready to do this pitch? Okay, y'all stop talking. In the back, I didn't hear you. Are you ready to get this pitch? Okay, in the back right there, I see you, girl. You playing with your hair. You ready to do this pitch? Okay, she ain't saying nothing. Over here, y'all ready to get this pitch started? Okay, on that back row, y'all talk about something. I'm gonna come get y'all. Y'all ready to start pitching? See, y'all ain't paying attention. Are y'all ready to start pitching? That back back two tables, y'all gonna be the first one we have pitch after lunch, okay? I'm just letting y'all know in advance. Over here, we gonna pitch? Are we gonna pitch? But this is the thing, these pitches are important. All jokes aside, I know I gotta go out of time, but these pitches are really important. You all are in the middle of elections. If you do this effectively, you have what you need, all right? So it's pitch time, read the articles, let's get the party started, all right? Can I get some theme music?
Hello and welcome. Bonjour et bienvenue à tous. My name is Kate and I'm coming to you live from the Rogers Centre in Ottawa for day 2 of the Canadian Medical Association's 2025 Health Summit. I'm going to be your virtual host for today, and joining me online are Nick and Savani, who will be moderating the chat. So if you haven't done so already, please make your way to the conference website or app. And I'm going to take you through a little bit of how to navigate the tabs on the left-hand side, and then we're going to get into the pitch competition. So a couple things here are self-explanatory. You have the program, speaker bios. The chat is a place for you to comment, add some insights that you're hearing, that you're having from the day. And we also have resources and recordings. I want to take a moment to talk about the recordings. So those are from yesterday. If you weren't able to catch some of the sessions that you were looking forward to, please click on the recordings tab and you'll be able to access them. And then there's a reflections tab, a poll tab as well. So this is where you'll be able to answer some polls. Please do that. And we're going to have the results available for you at noon. So what an amazing session from LaToya Jones. I'm going to take you through how to access the participant kit so you can build your pitch. So on the left-hand side of the website, you'll see the resources tab. Click on that. And in there, you will see a participant kit. So click on that tab. Click OK. And there you will access the PDF, which is going to take you through the 2 case studies. So read both the case studies and then select one that you're going to build your pitch off of. There's a worksheet as well as a pitch guide. So use those to build out your pitch. Keep in mind what LaToya shared in terms of all of her tips and tricks. And then you have about a minute, like as you talk it through, about 1 minute for that pitch. When you're done, post the pitch in the chat, and what we're going to do is after lunch we're going to come back and be reading out some of those in the room. One of them could be yours. So take a moment to do that now. We're going to reconvene at 1:15 Eastern Time, and very much looking forward to hearing your pitches. Good luck.
Okay, everyone, it's great to see so much enthusiasm in the room. I'm really excited to hear some of the pitches this afternoon. Unfortunately, it is time to finish up your table work. Now that you've created a pitch, we'll want you to deliver it this afternoon. So please identify one person from your table who'd be willing to come on stage after lunch and pitch the minister. We may not have time for everyone, but many of you will be selected to pitch your pitch to the group. We'll now break for lunch. You will be served upstairs in the Trillium Ballroom, kind of like breakfast and lunch yesterday. We'll meet here at 1:15 and we'll ask you to return to the same table. Please note that we have a slightly shorter period for lunch than yesterday, so make sure that you're back on time so we can get the pitches started as quickly as possible. So have a good lunch, everyone.
Check. I had to do a little change of outfit. Y'all like the jeans and little heels? I had to do that because I'm getting ready for these pictures y'all about to get me, you know? So I had to be able to stretch my legs. Let me stretch my legs. Y'all ready? We did this morning. Are y'all ready? Yeah. All right. So we're gonna have some. My mic fell off, so I gotta put this in the back so you know. We gotta get this right. So there we go. See, this is why. I'm just gonna hold it. That's what we're gonna do. All right, so I'm excited. We got a good little crowd back. I'm excited about these pitches. Y'all see, I changed my clothes. So I used to be a cheerleader back in the day. Y'all can't tell. So if I do a herky, that means if I do a herky, I need one of these doctors to come check me out because these knees and these ankles ain't made to be jumping no more. So I'm gonna start asking people, who's ready to pitch? We got one hand up, two hand up. I saw a hand in the middle, that's three. Not yet, I'm just trying to see how many people. We got 3 hands, 4, 5. Where's the chosen frozen? I know they gonna do a pitch. District 13, y'all gonna pitch? District 13? Okay, may the odds have been in y'all favor. So right now, it looks like we got like 7. Y'all got that reference? You know what? Y'all were kind of stale earlier, but I feel like y'all got it. Y'all ready for these pitches. I'm excited. So what we're going to do is, because it's dark in the room, and I want everyone to see you all's face, and I want you to see the emotion in you all, we're going to have you all come and do your pitches, okay? And don't be afraid. We're all family, you know. So do your pitches. A good pitch might get a good prize. We also have a pitch from virtual. So y'all ready to get some pitches done? Y'all ready to get some pitches done? Batter up? All right, so with that said, let me see. I'm going to turn around in a circle. Hopefully I don't get myself too dizzy. And then I'm going to do a circle. And then whoever I point on, I want y'all to come up, tell me your team name, and give you your pitch. Does that work? Okay. Oh, I'm already getting dizzy. There's no way right there. Right here. You come on stage. Where's the mic? Here on stage. Give me your team name and your pitch, and we're gonna start doing it. You coming up with me? All right. So I need a mic. You need a mic, girlfriend.
I can meander over here.
There you go.
Thank you.
I like that skirt.
Thank you.
And those boots. Oh, we're gonna have to talk fashion later than it.
A lot of chocolate up here. Okay, it's working. Can everybody hear me? I'm normally not a quiet person. So, Minister Thanos.
Team name?
I am Snowguard.
Oh, I like that. Clap it up for Snowguard.
I am an Inuk teenager from Nunavut. I harness the spiritual energies of the Aurora Borealis and the Arctic. Thank you for meeting with me. I know you are one of the most powerful beings of the Marvel Universe. You use your time to build your dream of a sustainable future, achieve balance in the universe, and address pressing issues in our healthcare infrastructure, including inadequate health human resources resulting in limitations and closures of emergency services. I am here today to affirm that I share your vision and address your problem. I want to help you achieve it by building capacity in healthcare competencies within urban, rural, and remote communities and grassroots community members. You have suggested genocide to lower the health services burden. This is a solution that has been repeated by leaders throughout history and is never shown to be effective. There is a stark evidence here in the Canadian jurisdiction that the impact of genocide is legacies of harm, including the development of complex intergenerational, lateral, and historical trauma in large populations. The colonial health systems do not have the processes and infrastructure to address the holistic health consequences of genocidal traumas. This is evident in the growing complexity of the genocidal legacy on social determinants of health, including mental health and addiction crises that are straining our existing health infrastructure. In my home community, we have the highest rate of emergency department readmission in the country due to these factors alone. The health professionals serving in these systems are not immune from the spiritual and ethical harms of these dilemmas. And these crises and workload include health human resource departures, reduced hours, burnout, and lateral moves that are extremely costly to the system. A deeply respected Inuit elder, Martha Peet, has given me permission to share this story. In her home territory, the nurses who operate remote nursing stations carry the entire health burden of deeply harmed communities. One such professional experienced so much ethical and spiritual harm in her role that she took a bottle of alcohol after her shift, drank herself to death, and was found the next day outside and naked from her response to hypothermia. The crisis in our health systems is due to a lack of a balanced approach, a biomedical and physical health model to address a legacy of spiritual harm, and an absence of a balanced and holistic approach to health and well-being. Our health systems and providers are being used inefficiently, and we are wasting resources needed for acute physical care. Our critical care physical care teams are instead ineffectively redirected to address issues of holistic well-being. In a time when we face growing climate and economic threats, we must diversify knowledge systems and health teams to reflect a holistic approach. I ask you today to consider an investment in building community health competencies training and capacity to transform healthcare silos into health and well-being ecosystems. This approach will also strengthen our mutual aid networks to navigate long-term sustainability strategies and a resilience to crises. Elder Martha and other Indigenous knowledge keepers and communities of Inuit, First Nations, and Métis ancestry are willing to collaborate and share their most valuable resource, their knowledge. And to solve this crisis, diversity of knowledge and culture, like the biodiversity on this planet, strengthens the collective whole, and the Indigenous peoples of this planet are equipped with histories of interconnected community infrastructure that has sustained life in balance for thousands of years. Thank you.
So that was a really, really, really good pitch. Only thing I will say is it needs to be a bit more concise. It was clear. And Martha, girl, you almost got a tear out of me. The story was amazing. So you just need to get to the story a little bit quicker. But great pitch overall. Y'all agree? All right. So I'm not spinning around no more. I can't do that no more because I get too dizzy. So pitch number two. Who's coming up for number two? Number two, come on down. Y'all know the grand old game. Oh, okay. Well, we already went to the front, so we got in the back. You come on down. Come on down. Y'all remember that game show? Come on down. Now and then, okay, so what we gonna do? So pitch two, pitch three. I got four right there. The chosen frozen is 5. Hey, y'all, we got some pitches. Yeah, all right. It's gonna be a good time today. So come on, you gonna come on stage, girl? She is a public speaker, y'all. We talked earlier. So give us your team name and get to this pitch.
We are Captain Marvel, or Miss Marvel, powerful women-led team. And I want to start my pitch by saying, I have not been alive as long as it took some of y'all to complete your post-secondary education to get where you are today. So I'm a young person that has come out to be a healthcare advocate, and I think that speaks volumes to what is going on in our healthcare system. When we read the article about hundreds, if not thousands, of Ontarians standing outside in the freezing cold, waiting to get a family doctor. That hit me very close to home, as well as some of my teammates that helped create this pitch. In the middle of my transition from pediatric to adult care, my family doctor decided to retire because she was burnt out from our healthcare system and decided to move on to another form of career, which is totally understandable because it's hard right now for our healthcare providers with all the administrative burden. And it was up to me as an 18-year-old with the support of my family to figure out how to figure out my healthcare on my own. That meant lots of times going to ER unnecessarily, calling 811, or just being super, super sick. And I also survived septic shock in the middle of that transition. So it was a crazy, crazy time. And unfortunately, that's not an unknown story. There was hundreds, if not thousands, actually millions of Canadians, 6 million without family doctors who were stuck standing in the freezing cold waiting or staying home and waiting. And that is unacceptable. And another point that we brought up, which is the big piece in this pitch, is that, you know, you love your double-doubles. We see a Tim Hortons on every single corner in Canada. But where are the healthcare systems? My partner has worked at Tim Hortons for 8 years, leaving it soon, fortunately. And he works with countless people from other provinces and a few foreign workers. And one of them is a brain surgeon from India. And this man is forced to work in a Tim Hortons because he cannot afford to get his license and is saving money to bring his children and wife to Canada. And that is just not okay at all. And we need to change that because we need more than double-doubles, we need healthcare. And young people deserve to feel seen, heard, advocated for, and my future matters. So people need to start standing up and spending money on what matters, which is the youth in our country.
All right. One thing we know, we don't want to piss her off. So it was a really good pitch, but the messaging got a little bit muddled. You start off with humor, which I love, and you saw her emotions. So emotion doesn't have to make you cry. The emotions made me angry, right? So and ideally, that's the word I'm going for. When you do a pitch like that, make sure you say, okay, I'm a young person, this is important to me, and this is why it's important to me. But the fact that she started by saying, you know what, I have not been here long enough, you've been in office longer than I've been born, and talked about her issues, that is a good opening line for a young person. So really good pitch. All right, where's number 3? Okay, we fighting. Come on, number 3, come on. Okay, you know what I want y'all to do, because we got a lot of pitches. If y'all know y'all want to pitch, come line up to the side so y'all won't have to worry about y'all walking up. All right, deal? So y'all come on to the side, come sit at this table, and then everybody gonna come. That's what we gonna do. I am excited for these pitches, y'all. Y'all understand. The fact that I actually have not, I keep saying pitch and not the other word is a testament, because you know sometimes I be slipping. All right, let's go. Team name and get to it.
We are the Maplers.
Hi, I like that.
We're from Captain Canada, the Maplers. Minister, I am a family doctor. Last week, my own family doctor sent an email. She has stage 4 cancer, met to the brain, liver, and lung. Even doctors ourselves cannot get a family doctor. I've been practicing 33 years, and my patients are fine. I'm not going to quit or retire, but I'm here standing up for all the Canadians that don't have a family doctor. And I think it's reprehensible that people in wheelchairs have to go out in the snow with Facebook to find a family doctor. If you want to be voted in again, you want to be the government that created a provincial wait list so that patients don't have to go to the ER 2, 5, 8, 10 years without a family doctor. Once we die, quit, or retire, you need to create a wait list, so if we're going to be waiting anyways, at the end of it, we'll get a family doctor. And like I said, I'm standing up here for all the patients that don't have a family doctor. And are we going to wait for our wheelchair patients on the verge of amputation, diabetes. The people who really need doctors can't even stand in this lineup. So you have the power to legislate wait lists, organization to forward the healthcare system so that every Canadian is not waiting around for nothing.
Well, that's a good, clap it up. I like that pitch, because one thing she said was that if you want to get elected again, because trust and believe, as she is a doctor, you know, them being elected, that's their job. So she's like, I'm a doctor. Letting you know, I know what I'm doing, but if you want to be back here again, you got to listen to me. That was a good pitch. Come on up.
Ani, this is Team Summit 2025, which means we're still climbing.
Oh, I like that.
So I want everybody to stop and take a step back. As I've sat here and listened this whole weekend, and I've enjoyed everything, I hear about everybody advancing. I hear about everybody moving forward with medicine and making it equal across the board. And I think that's an awesome concept. Unfortunately, back there, I was looking at the ping pole. And if you look, the smallest line or the smallest one there was racism. If you stop, take a step back, and think about what and how this medical world can move forward if we got rid of racism, that would be something for you all to consider. And there's racism within all of the system. I get questions as a lived experience person. I had a child that was special needs. I myself am now going through the health system. And this health system has asked me how much I drank. And I was holding a glass of water with me, and I said, whatever was in this cup. And the guy took it off and smelt it to make sure it was water because they didn't trust my word. Because I'm a First Nations person and I'm an alcoholic. I'm a First Nations person and I'm uneducated. I'm a First Nations person who needs to sit down, shut up, and listen to what we have to say. And that is not acceptable in my world. I'm 60 years old and I've lived with racism my whole entire life. And it's become just a part of a normal part of society. But it's not normal. I don't tell my kids in the morning to wake up and go out and hate white people. I don't tell them to go pick on somebody or stop your system and not serve somebody within your job. I don't tell them to have biases when they walk out the door about these people, about anyone when they walk out the door. Those are formed by your personalities, not by ours. Those are formed by your education, not by mine. And I think rather than rushing towards moving forward and getting everything in front of us and maintaining the barriers that require us to be able to use whatever it is that's available, I think education needs to be given. My name is Michelle. I'm of Treaty 4, Saskatchewan. I'm a 60s scooper, and I grew up in the white world. And I had to leave a lot of that white world behind so that I could live my culture. And one of the things I do as an adult educator is I teach about diversity, equality, and inclusion. And that needs to be taught to begin with, because in all the times I've been to the hospital, I've never received a First Nations person, nurse or doctor, by my side, although I do know they exist because I've talked to them before. There isn't enough. So I don't get representation of me when I sit in the hospital. I get the stereotypes of what people think I am in the hospital. So while we were at the table, I have a cancer brain. I've been dealing with cancer for 3 years. And on February 26th, they took the last of it out. I can't say I'm cancer-free for a year, but that's okay. So while we were sitting there, I can't remember certain things sometimes, and I couldn't remember what I did, one word. And she says, think of it as DUI with an E. Diversity, equality, and inclusion. I believe in education. I totally believe in education, and that's what's needed. But the best part we need is truth. Truth from the system, truth from us, and we need to sit down and listen to each other. Because once we understand each other's truth, I think we do have a possibility of moving forward. I really, truly believe that. But you both need to own up on both sides what your truth is, and you've got to hear the inequality from both sides. Miigwech.
Thank you, thank you. So that pitch was good because it hit on emotion. And the only thing I would ask, I would assume that you would be talking to an MP that understands your nation and your community. So make sure you're hitting to what his why is. But thank you very, very much. All right, who's coming up next? Hold up, we got, yeah. Okay, I'm excited for this right here, y'all, because we got a storyteller. Come on, come on. Tell them your name, tell them your name.
Hi, everyone. I'm Ali Butt, and I've actually brought a caretaker perspective with me today. We are team caregivers, or that's our superhero, is caregivers. So I want to start off by saying, dear Minister, thank you so much for having us and for the impact you've had on the country so far. It's very important for us to bring a pressing issue to your awareness. And what we wanted to talk to you today was specifically often those who are forgotten, who are the caretakers of those who are ill. And so our proposal is putting forward a caregiver algorithm that incorporates AI so it can help the caregivers navigate the complex healthcare system that is often so confusing for people who are already trying to navigate it on their own and for ill family members. So with that being said, I do want to pass it on to the perspective of a real-life caregiver who's going to speak about their experience.
Hi, Minister. How are you?
Awesome.
Thank you for your time. I wanted to ask you a question.
Okay.
Have you ever had to take care of anybody in your life?
All the time.
Right. I had to take care of two parents during the pandemic. Unfortunately, both were very sick and in two different health tracks. So my mother was diagnosed with stage 4 glioblastoma, and my father was ramping up for a liver donation, and I was the donor. And then the pandemic hit us. And before that happened, I was already discovering the limits of care in our country and within the different institutions here in Ottawa. And it was very hard to navigate. As one person providing compounded dual caregiving to two very sick parents, I couldn't do the job I wanted to do. And I saw a lot of suffering, and I took a lot of that on my own shoulders. And if I had a navigator, if I had somebody to guide me, I lived in Nepal for a year, I lived in Kathmandu, and I got to go to base camp. And I couldn't have got there if I didn't have a guide. And that person was there to carry my bags at times and was there to point me in the right direction. And if I had that kind of navigation while I was caring for two very sick people who I love more than anything, I think I could have done a better job, and I think I would have been less angry at the system. And I really hope that whoever you care for in the future or have to care for has the same kind of resources to make that difference. And I thank you for your time.
Thank you, thank you. So that was,
So now, Minister, now that you've heard the perspective of a real-life care giver for both sides, I do want to urge you to think about so many Canadians right now that are also in similar positions, and this is one perspective of many, and we're very thankful to have that voice here today. And the last thing I'll leave you with is imagine being the minister that makes the lives of caregivers much easier. You'll be remembered forever, and people will align with you going forward. Thank you.
okay. They were paying attention. They asked the minister a direct question, how it affects me. And also say, what do you want your history to be? Very, very good. Uh-oh.
So we have 9
Uh-oh.
that want to make their pitch. I will do the 2-minute timekeeping.
Yeah. So turn this clock right here off, because it's throwing me off. We can't go 9. Okay. Uh-oh. Okay, so hold up. Everybody got 1 minute to pitch. Come on. Come. So, sorry, gotta keep it fast. Come on out. Come on.
Tough pitches to follow. All right. Okay, I'll make this quick.
Gotcha.
Good afternoon, Minister. So thank you so much for making the time to meet with me. I promise you this will be time well spent.
Okay.
My name is Catherine, and I'm here on behalf of the physicians of our community, but I'm also a constituent, I'm a patient, and I'm a family member. We have a problem in this province, and in this town as well, and I have solutions for you. People can't access the healthcare they need because they don't have a family doctor because our rosters are full. So let me tell you the story of a young woman who needed care, Mrs. Pregnant and Alone. So this young woman waited in line at a walk-in clinic because she still had morning sickness at 23 weeks. She waited in the cold with her 1-year-old because she had no one to look after him. And after waiting in line outside for hours and not being seen, she had to go to Emerge because she and the 1-year-old had frostbites. And then she waited hours in Emerge, and the lack of sleep and the stress kicked in, and she started to have preterm contractions. So she went on to deliver way too early. Her baby was flown to Toronto, where she received expensive care in the NICU for months. And meanwhile, she had to spend a ton of money on childcare for the 1-year-old. And this, Minister, is just one story. There are 2.5 million people like her in the province. Now, I don't need to convince you that your constituents care about healthcare. You understand that. You need care. Your loved ones need care. We all do. And most Canadians rank healthcare as the most important issue for them. And I know it fully aligns with your values and your mandate. You promised that everyone would have a family doctor. Well, I'm here because I have solutions for you. I'm asking you for a small amount of money, only $2 million. And that's not a lot to prioritize health, increase access to care, decrease burden on Emerge, and decrease physician burnout. And I can go on with the benefits, but I know we're on a tight schedule, so I'm going to move on. This funding will be used to put together innovative cost-saving solutions, such as leveraging AI and using a one healthcare worker to many patient model of care. Not only will more patients have access to care, but each patient will have more time spent with the care provider, and the one-to-many model will allow for peer-to-peer interactions and community building between people that otherwise wouldn't have met. And this will lead to better health outcomes for all of community. And I can guarantee that other communities will want to do the same, and you, Minister, will be remembered as the one who saved healthcare in Ontario. So I know this is quite a bit in a few minutes, but I'd be happy to sit down with you and explore solutions at a later time.
Thank you, thank you. I'm gonna leave my commentary to the end. Next pitch.
Hello, Minister. I'm a woman who lives with heart failure, and the importance of having access to an emergency room at any given time is critical. We have way too many hospitals that are closing for months at a time or for nights at a time when nobody expects it. I would like to share with you why it's so important that we all step up and make emergency rooms open 24/7. I wear a crown not because I'm bragging. Oh, sorry, I forgot. There's my crown. I wear a crown not because I'm bragging. I wear a crown not because I have royal blood. I do not wear it because I like to dress up, although I do. I wear the crown as a symbol that I am a heart warrior queen, and we have a table of them at the CMA Summit. I am wearing the crown not only for me today, I wear it for all other Canadian heart warrior queens too. I wear the crown for women who are unexpectedly, like me, hearing the term chemo-induced cardiomyopathy. Life-saving chemo left us a legacy. I wear the crown for women who had the incredible joy of birthing a child, only to be told hours or days or months later that you have heart failure. I also wear it for those who are born with wonky hearts, and my apologies. I also wear it for those who are born with wonky hearts and they need the care of specialists from day one. I wear the crown for women who have had the misdiagnosis of depression, anxiety, or worse, heartburn. And then they're only to find out that the damage has been done because it was, in fact, their heart. I also wear it for those whose hearts may beat beautifully, but their vessels and arteries have a mind of their own. I wear the crown to support women who have gone through personal trauma and that caused their heart to break. I wear the crown for women whose arteries, without any rationale, shred open and spill their blood inside their bodies. I also wear it for those who face arteries that have blocks and they stem the flow to their hearts. And of course, I wear the crown to acknowledge the hard path of women who had to say goodbye and thank you to their own born hearts and accept the gift of another. I wear the crown for women whose hearts gave all they could and their owners who are no longer here. The crowns we wear may all be different, but we are united as Heart Warrior Queens. As Heart Warrior Queens, we represent heart as we strive to love boldly. Heart as we strive to love boldly, being a warrior because we live to be brave, and queens because we must lead in our own heart journeys. So Minister, please help me to make sure that when I need to lead, I can access an emergency room.
Thank you, thank you.
Hello. Thank you for taking the time to see me today. You've done so much incredible work in this field already, and I'm here to talk about solutions. So I'm a family doc, 20 years in practice. I have over 1,000 patients, and I represent the other family docs in these small towns with hospital closures, intermittent hospital closures. So I want to tell you about Gary. Gary lives rural BC. He's got young kids. He's about your age, young kids, looks after his parents, single dad. His dad's been diagnosed with dementia. And so imagine that call from your doctor's office that you've got cancer. And imagine the thoughts you would feel when you get that call and what rushes through your head. And that's Gary. So Gary had to travel to Vancouver to get treatment. But as we heard from the last speaker, there's a legacy that cancer leaves you, and there's a lot of acute care that needs to happen, emergent care. So imagine going to your local emergency and the doors are closed. And you're like, okay, well, where do I go? So this is Gary. The doors are all closed. So now he has to stay in Vancouver and he can't come back home. And so his kids are looked after by his parents and the community. And so, you know, we talk about the cost of healthcare. The cost of healthcare is not Gary. It's Gary, his parents, his kids, and Vancouver and everywhere. That's the cost, and there's no money on that cost. So why should it matter? It should matter because you're doing such amazing work in this, and you've funded so much of it. But I think we need to look at other solutions because money is great. I will take your money. I love money. But you know, sometimes money's not the answer. It's about making decisions. It's about kind of figuring out what to do, where can we use that money better? And that's what I'm offering you. So I'm offering you a solution that's bottom up. I'm offering you a solution with the right people at the right table to look at what you've given and where can we look at it? Because we may have to close some hospitals, but we can keep some open consistently, and that's gonna count for Gary than it will having this intermittent open closing. So what I would suggest is that we should say hospitals are gonna be open. You're gonna know when the emerge is open, and that's what our goal is. And what that requires is for you to work with the people that actually understand patients, community, and flow.
Thank
so
you.
I will call your office next week to set up a plan.
Thank you, thank you, thank you. Okay, unfortunately, I only got one more pitch. Come on, one more pitch. I'm sorry, y'all, but this is the thing. I want to hear you all's pitches, so I'm gonna hang out and I'm gonna listen to y'all pitches. All right? Deal? Deal.
Hi, MP Fanos. I use so much healthcare. I am constantly seeing my doctor. Love him, great dude. I'm on a first name basis with him. But I also know how sick I was as a teen before I was able to access him. Do you live in this riding?
I do.
Do you use healthcare in this riding? Do you know what that's like? There was a woman in line with a 17-month-old in minus 17 degrees Celsius for 8 hours waiting in line like she's at a ticket booth for a family doc. What if that was your daughter? What if that was your granddaughter? Would you be okay with that? We have to help kids. That's crucial to our healthcare system and our preventative care. We have to skip this AI and this new tech stuff. We have to go back to what works. Put nurses back in schools. Let nurse practitioners practice more independently to ease that family doc burden. We need to utilize the underutilized to keep our healthcare system running.
Thank you, thank you. So, I wanted to say the fact that we have so many people still ready to do pitches means that y'all were paying attention earlier. But these pitches were actually amazing. You all got the emotions. You hit on the emotions. You hit on facts without being too facky, and you actually were concise. Some of them were not as concise as I would like them, but you all are seeing what it looks like to actually do a pitch. And think about what happens if you actually have more time to do a pitch. If you actually sit with it and talk to your people in your community. This is the makings of really, really, really good movement to make sure that healthcare and your MPs understands what's happening. So thank you all for the pitches. I think we're about to do a Q&A session now. Thank you for the pitches. For you all over here, I want to come talk to you all because I want to hear these pitches. But thank you. You got it. You will get the slides later on. Next section is about to start. Hey.
With you.
Oh, yeah, with me.
That was amazing. When we were talking, we were like, what if nobody wants to do a pitch? Like, what do we do? Do we need to plant people? And like, we were so wrong. What a great problem that we had too many people. I think that speaks to your energy and encouragement, but also to the inspiration of this room. So we want to hear now what your questions are for LaToya. We really want to give you a chance, not just to share your pitches, but what else do you want to hear from LaToya? What do you want to learn? So there's people with mics, and I'm going to figure out how to use this tablet as well, because if people in the virtual setup have questions, hopefully I can figure that out. But if anyone has a question, please raise your hand. We'll bring someone with a mic, and since I can't actually see whether or not we're there, I'm going to ask a first question and see, do we have one right away? I don't even have to use my pre-planned questions. Great. It's somewhere over there.
Hi, I'm Lynn Sonnenberg here from Ottawa as a clinician. And when do we follow up after our pitch? So
I will give it, depending on what's happening in the area, I always give it a week. And you tell them, I would say I will follow up within a week to 10 days, but you always follow up in a week. And when you follow up with them, if you're particularly following up with an email, just say, hi, remember me, we spoke, and give a little bit about what you spoke about initially in the intro to remind him, but I will always say at least a week.
All right. Any other questions? I see a hand here, but there might be other ones it's really hard to see further back. So,
then there's a hand in the back as well.
Okay. Go ahead.
Hello. I was just wondering, how do we prepare for the pitch when we're at home and they're coming to our door? You know, like, should we have something written by the door?
So when you're at home, because what happens when they're at home, they're gonna come in and they only really wanna give you when they come to your door, they say, hi, can you vote for me? So you should say, okay, what do you know about XYZ? So that has to be quick. Give it in 45 seconds, things of that nature. When I say quick, because if you go long, they'll be like, oh, you know what? Talk to such and such and such, and then they're gonna write on their note, long-winded, don't talk. So quick, you know what? Hi, this is my issue. If you want my vote, where do you stand on this? So you ask them, and then, because they wanna talk. So you ask the question, what do you stand on First Nations healthcare? And if they don't know, so you know what? I'm gonna follow up with you in a week, and I would love to know where you stand then. So just have your question that you know you wanna ask. Mm-hmm.
Hey, next question. I think there was someone in the back. Great, please go ahead.
I'm a data freak, and when you said don't give data, I understand that you shouldn't do it right off the top, but how do you ease into it when there's so much misinformation out there and data really makes the case?
So let me correct myself. I didn't want you not to give data. Don't lead with data. So as earlier, someone talked about the young women, and it was the story of lost and alone. See, I remember the story. Or pregnant and alone. At the end, she said, and there's too many more women like her. So she started with the story, and then she gave the data points after that. So you have to hook them with the story and the emotions, and then you slide data in. So if you can slide it in, but if you start with it, it's like Charlie Brown, want. So start with the story and then loop the data in as towards the middle or the end of the story.
Okay, is there another question? So hard to see. I actually have no idea.
It's over here. Question?
Okay, well, while we figure out the next question, I'm going to ask a question. Do you have any examples of a really effective pitch that you've done? And while you tell that story, I'm going to ask someone to help me figure out this because I can't get the Q&A to pop up.
Okay, so I'm going to start it out with about 20 years ago. I was a young woman trying to do, we were doing youth organizing. And the organization we were organizing for did not want to invest in young people. So basically, I was explaining to them, I was like, this is going to sound really bad, but I was like 19, so it worked then. I was like, look, all people who are voting right now are going to die. And you need young people. Young people, you want them to actually vote. So if we start investing in young people now, you're actually going to get young people to be involved and vote. And I was like, no, seriously. Right now, young people are not voting. So if they don't vote now, they're not going to vote then. So I kept telling them, like, all old people are voting, but they're going to die. I kept saying they're going to die. I know it's bad, but I was 19. I didn't think I was going to get this old. Another conversation. So after that pitch, and after I told them about it, I was able to get this organization to give me $250,000 to actually engage young people. And the next following election, we increased youth voter turnout by 12%. And then I went back to them and said, remember I told you? And I got more money because I came back and said, youth voter turnout increased because you gave me $250,000. Now I need more money. So I told them why it was a problem, why they needed it, and got the money. Quick, that's why. So that's like my first young pitch. So there.
Thank you. That's really helpful. All right, we have a question over here.
Yes, hi, Jonathan from Ottawa. The pitch you were talking about is about a minute-long pitch. What if you have a 15, 30-minute appointment with the minister or deputy minister? How do you structure it then?
Well, if you still have your pitch that's concise, but that's when you ask questions. That's when you want to have him involved. So so you start with your pitch and say, let's talk about this. So if your pitch is about 24-hour ER care, you bring more stories, but then you ask them what has happened. So you have to think about it as a conversation. So make sure your pitch is concise, but have questions that are not yes or no questions, open-ended questions, ask and then have stories. So and never do yes or no questions, because that won't help you at all. Open-ended questions. And I will have about 3 or 4 open-ended questions connected, because what happened then is they'll start talking, they'll go over time, but they don't want to leave, they want to make sure that you talk as well. So you get more time that way. So make sure your pitch is still concise, but then ask open-ended questions. And then also make sure you follow up and say, this has been amazing, let's figure out how we can do a solution. So you can do it that way.
Amazing. All right, we have someone over here.
Hi, I'm Carl from Toronto. My question is, for a lot of people in this room, this is their first exposure to sort of these concepts and to the concept of pitching. What is some other steps they could take to keep refining those skills and keep working on this now that you've hooked all of them?
So when you think about pitching, it's just persuasion. So we're talking about pitching your MP. But if you have a child, a partner that you're trying to actually get them to do something, figure out a pitch to them. Like if you have a child who never actually wants to go on bed on time, what is it? What's the story? So it's about figuring out, getting used to getting the story, getting used to saying, this is how I want. Because a lot of this is just advertising and marketing. It's talking. So when I talk to my 10-year-old niece, who's Nia, she wants to stay up all night long playing Fortnite. You cannot do that. Why can you not play Fortnite all night long? Because you have to go to school tomorrow. Why can't you go? If you go to school tomorrow and you don't learn, you will be homeless. I mean, she knows now she won't be homeless. But I still have to actually have a pitch ready for her whenever she spends the night. So it's all about persuading people to do what you need them to do. And having that right, and you can do that anywhere, whether it's a car salesman, whether it's your spouse, whether it's somebody you want to give you, who owes you money, you want your money back. It's all about persuasion, so get your story together. It's something in the back, right there.
Okay. Yeah, go ahead back there.
Hi. One of the things I found that being useful for me is with my MP or MPP and so on, politicians, they sometimes have open houses or events, and I show up there and sometimes I can get a few minutes with them to pitch a small thing to get a meeting. And just a suggestion for people in the room, there's the federal election going on. There's a lot of candidates looking for volunteers. So that's one way to kind of have a little time with them in the community barbecue or whatever they hold for the volunteers to bend their ear a little bit.
I agree with that completely. And at this point in time, you all have multiple parties. Go to everybody's open house and have the same story and the same pitch to every candidate. Because regardless of who wins, healthcare is important across the board. So even if you don't like their stance on 90% of the situation, show up anyway to make sure they know that healthcare is my thing, the hill I'm gonna die on, no pun intended. But make sure you actually go and so go. Even if you see them in the grocery store, remember MP, healthcare. So go everywhere. Go everywhere, be seen, say same thing.
We have another question, but I want to go virtual for a second because this is a nice follow-up question. Somebody said you talked about asking open-ended questions to MPs, but sometimes that leads them to really dominate the conversation and take it in a different direction. Do you have advice about how to bring it back to the pitch?
Yes, so if you say, and he starts on his stump speech, he's like, Minister, I hate to interrupt you, but when you brought that up, I had an idea, and circle it back. And it's always, I hate to interrupt you, but I only got 15 minutes, and circle it back, because they are the art of getting back to their talking points. So when you have that opening, circle it back. You always circle it back. So it's going to be a game of give and take, because he's going to want to go back to his talking points. You're going to want to go back to, to your pitch and say, Minister, I understand, but your time is important, and there's 5 other people waiting, but let's talk about this. And last week, the great thing about knowing their stance and what they care about is that in last week on Parliament floor, you said this. And they're going to be like, oh, they're paying attention to me. But tie it back to what you want to say. So use their words to tie it back against them. So.
Okay. Wait, somebody over here, I think.
Yeah, hi. It follows from this nicely, actually. I'm looking at that dynamic because we heard from one person about this is all new to them. But some of the people here are actually getting the pitches from a whole bunch of other people. Mm-hmm. So I'd just like to hear a few of your reflections on what if you're not the pitcher, but the recipient? What do you suggest? Because it is that dynamic.
So ideally, if I am receiving the pitch, if you all are receiving the pitch, do not make an emotional snap decision. So you say, thank you very much, I will take this into consideration, and you sit with what they told you. Because oftentimes, the first thing you're going to say is you're going to commit yourself to something that you can't follow up to. And you do not want to make a promise that you can't keep. So take it in, write your notes, say, I will thank you, I will take this into consideration, and I will follow up with you. So especially if you don't know that you can do what you say you can commit to, then they're going to be talking about how you don't follow your word. So never say yes on the first ask. Think about it and follow up after that.
Do we have any other questions in the room?
Also, the reason why it's important, if you do that, because it makes it feel like you have been very thoughtful with your decision.
All right, well, I do see another hand. Great.
Okay, thank you. My name is Matthew. I'm from Toronto. I need $750 million.
Oh, you're serious? Okay.
I need multiple partnerships across the country, and we keep bouncing from federal to provincial to federal to provincial to this person, go speak to the head of this OR. How would you suggest bringing that to a stop, finding a decision maker, and keeping the momentum going, the eye on the prize, but keeping people engaged and focused on the outcome when there's so much bouncing around and lack of accountability?
So there's a rap song that says, if you stay ready, you don't have to get ready. So ideally what happens, and you say you go from this to this to this, you should create a lasting campaign. So regardless of who the MP is or what the climate is, this is your through line. And as an example, in one election that we ran about 15 years ago, everybody who's connected with us, the tagline was culture of corruption. We said that in everything, whether it was dog catcher to Congress, and we said that for 2 straight years. We never got off our message. So when we got in office, that was our message. But when we got out of office, we had said it so much, the persons who came behind us was that same message. What you need to do is don't worry about the different types of elections and just create a lasting campaign with a through line that's going to take it across the country. So whatever and we can talk about this afterwards, I can help you create that. But it has to be something that is going to be classic and sustainable. So because you're asking for so much, you have to be able to make sure that it's like a message box, us on them on us, them on that, that kind of thing. And I can give you the message box, and that's how you come up with your through line, and you just stay with that the whole time.
Okay, we have time for one last question. I see a hand in the very back. No.
Here, coming.
I mean, I heard you ask, can you hear me?
I'm glad you said no. Because I was like, what?
Can anyone hear me now?
Yes.
Okay, excellent. Thank you so much. So from what I heard, it sounds like a lot of the time staffers are also important people to connect with and keep in touch on a longitudinal basis. I'm just wondering from your extensive political experience. What are some techniques we can use to connect to staffers, keep in touch with them, like follow up with them, as well as kind of know how, you know, we kind of fit into their work environment, like what times or schedules or particular like seasons in the year are optimal for particular types of pitches. And you know, when in times when we cannot reach the minister or the representative directly, how do we make our presence known? How do we be a presence in their office?
So that's a great question. I often say that I would rather be the queen maker than the queen, because actually the staffers tend to have more power than the actual elected official. So what I tend to do is, once I actually pitch whoever I'm pitching, when I do my follow-up, I make sure I follow with the MP, well, in your case, the MP and the staffer. And then I give the staffer much more information. So that's where the data can come in. So you can say, you know what, this is what I spoke to the MP about, but because you're involved, let me give you the information. So if you give the staffer, like, know all of the data, all of the information, they'll be tasked, because part of their job is when they're working with this MP is to know more information than the MP does. So they'll be the person reading the information, going through, so when the MP asks them, they can say, you know what, in this area, no, there was a 13-hour wait time, and we lost this. So when you're actually meeting with your MP, you give them the information, but you make sure you have a separate folder that has more information for the staffer, and then your follow-up, you follow up with the staffer. And you make sure the staffer understands, and you talk to the staffer, things of that nature. So oftentimes, again, it's the queen and the queen maker. The queen maker has to know all of her information. Think about Devil Wells' Prada scene, where Miranda Priestley didn't know anybody's name, but her staff knew everybody's names, and everything was happening. You have to make sure you know who the staff is behind them and give them all the information.
Okay, well, that is all the time that we have, but I would like to have a very warm thank you from all of us to LaToya Jones. Thank you so much.
Thank you, thank you, thank you. And I just want to leave you all with one note. Oftentimes, you all don't realize how much power you have. As much as we talk about MPs and elections and things of that nature, these countries don't run without the support and the power and the voice of you all. So utilize your power, utilize your voice, because you have power, and if you use it collectively, you can, keeping with the Thanos thing, when you use it collectively, you can actually change the world, you can save the world. So thank you for having me.
Thank you so much.
Yeah.
Thank you so much, it was so wonderful.
Herky, no herky. Oh, that's it, bye y'all.
That's it, yeah. That was wonderful. I hope you understand why I said that LaToya Jones is someone who can definitely get a message across, and that is why we wanted her here. That was so inspiring. And now we're getting to the wrap-up. So as we wrap up this Health Summit, I just hope that you feel the way I feel. I can speak to more than just this Health Summit. This year in this job as president of the CMA has been one of the best years of my life. And it's because of moments like this and people like you. It is so inspiring, and to be able to be in the advocacy space, representing all of these great pitches, these wonderful ideas, these people like you who are so passionate, who work so hard, has been such a joy. And I hope that today you feel that same joy and energy and inspiration, that you will take all of these tips and tools back to your communities where you can affect change at your hospital, in your city, in your province, or even at the federal level. I want everyone here to be taking this and moving it forward, because we are so much stronger together. We can take small pieces of information and spread them out. So in the federal election in particular, we have a great opportunity to advocate for meaningful change. We can call on our political leaders to follow through on the promises that they make to address healthcare's greatest challenges. We have talked about so many of them today. We have heard patient stories, caregiver stories. We've heard about the long history of Indigenous health issues that come from colonization and the trauma that continues to exist in our system today. And we can make things better. The CMA has a lot of solutions that we're already advocating for, but we need to work with you to make sure first that we're getting it right, that we're saying what you need us to say, but also that we're all saying it together then, and that we push the same message so that they don't just hear from me, but they hear from you at the barbecue when you have the chance to talk to your MP at their barbecue, or the person who runs into them at the grocery store, or your health administrator in the hospital. We need to talk about reducing administrative burden. We need to make sure that we are not wasting valuable time that could be spent between the patient and the doctor or the other healthcare providers. We need to let doctors focus on what they do best by bringing in team-based care. Online, we didn't get a chance to do some of the pitches, but there was a pitch about nurse practitioners and bringing them onto the team. And so I just want to know, for the people online, we're reading those pitches as well. I read at least 2 of them while I was sitting waiting to go on stage. Thank you for contributing those as well. We need to make sure that we cut through interprovincial trade barriers, but labor mobility barriers, so that physicians and other healthcare providers can work where they are needed, anywhere in the country. We need to be looking at how we can improve Indigenous health. We need to work with First Nations, Inuit, Métis peoples to support Indigenous-led healthcare solutions. We need to prepare for climate shocks and build climate-resilient health systems. There are so many things that we already know work, and this room makes me love my job, because I just am coming out of today wanting to work even harder. I have 2 meetings tomorrow. I'm going to barbecues tomorrow for candidates who are running in the election, and now I get to go and be like, I was just at a session and I heard this and I heard this, and I get to bring that to them, and I want you to do the same thing, to go to your local candidates and say, I heard that we need to do A, B, and C. It's so key to our work, and the CMA has a powerful voice. Probably most of you aren't familiar with the Hill Times, but it is a must-read for federal politicians, and they have ranked us as the most active health advocate in the country. But I'll tell you how I know that we have an impact. On March 14th, there was a cabinet shuffle. We've been working really well with Minister Holland, good relationship. But on March 14th, Minister Kara became the Federal Minister of Health. It was a Friday. On that Sunday, Minister Kara called my cell phone because she wanted to talk to the Canadian Medical Association about what are the priorities, what do I need to focus on, what should we be thinking about. And I am not naive enough to think that that's because of me. I know that that's because of rooms like this, and that our voices together matter in Ottawa. And what I promise you is that the CMA does not take that lightly. We are going to take your messages and make it count. When I talked to her, I talked about we need to reduce administrative burden. We talked about tariffs. We talked about the income issues and how that's impacting people's health. It was wonderful to be able to start off her role as health minister saying, like, we want to make the system better. Here's some things you can focus on. But together, not just me talking to the minister, together as providers, as patients, as health experts, as Indigenous health experts, we can hold our political leaders accountable. And when it comes to developing and delivering a health system that works, we can do that together. We're gonna have a video for you.
What does it mean to care? We think of kindness, of course, looking after each other, having compassion, but caring means more than that. It means being fiercely protective of what we have, of the things that matter to us, that make us who we are. It also means looking for a better way, finding new solutions, having the grit and determination to make it happen. Because caring also means never giving up. Staying in the fight, for doctors, for patients, for all of us.
Avoir la santé à cœur, ça veut dire quoi? C'est prendre soin les uns des autres, bien sûr, avec bienveillance et avec compassion, mais c'est beaucoup plus encore. C'est protéger farouchement ce que nous avons, ce qui nous importe, ce qui nous définit. C'est aussi chercher de meilleures façons de faire, trouver de nouvelles solutions et changer les choses avec cran et détermination. Avoir la santé à cœur, c'est ne jamais baisser les armes. Et aller au front, pour les médecins, pour les patients et pour nous tous.
That was my first time seeing that video also, so I got to enjoy it with you. I just got told we were doing a video, and I was like, great, can't wait to see it. As I mentioned yesterday already, if you are interested in getting involved in our advocacy, there is a Stay Informed section on the Health Summit mobile event app. You can sign up to receive updates there. We want you to be involved. We want to connect with you, to hear from you, and also have you going out and spreading the message. So please sign up to get those updates, to stay up to date on the initiatives and details and opportunities to get involved. You can also go on our election webpage. You can scan, there should be a QR code up there. Oh, it went up there too. You can find out what we're doing there. Please check it often, because we will keep it up to date and make sure that the newest information is there. I believe right now our toolkit on the election is already on the website. But we'll also be sending it out in a post-Health Summit email to you as well, so that you have a toolkit for this election, because we want you to stay connected both during the federal election, but beyond as well. The federal election is 4.5 weeks away, so not that far in the future, and we need to keep doing this work for a lot more than 4.5 weeks. So we invite you all to join us as well. We have a virtual AGM on May 31st, and you can hear from and ask questions of CMA leadership and highlight the issues that are top of mind at that meeting as well. So I hope that you join us for that meeting as well. You can register at cma.ca/AGM. And thank you. It is so important that our voices are heard. It is so important that we come together to be heard by the political decision makers. You have to speak up to be heard. I want you all to speak up, to use the tools you learned here, to teach other people, to bring this message out so we can make the system better for all of us. We can make healthcare a priority in this election and beyond. And so thank you to all of you, and I'm going to turn it back to Carl to help end the meeting for us.
Thank you, Dr. Reimer. I feel really inspired right now after all we've heard for the past 2 days. And every time I say that phrase, it brings me back to a talk I've been to a couple years ago, given by Haben Girma, who is a disability rights activist and the first ever deafblind graduate of Harvard Law School. And what she says is, when you say you've been inspired, you have to follow that up with what you've been inspired to do differently. So I want to share with you that I'm inspired to go back to hospital next week and give the best of myself to my patients, my families, my department, my hospital, and also Canada. I'm also inspired to follow up with something. So a couple weeks ago, my MPP came knocking at my door to have a conversation in the context of the Ontario election. And obviously, being a physician, I talked to her about the wait times for surgical patients. I talked to her about ER closures. I talked to her about the needs in medical education. And after seeing that I was very passionate about all of that, she asked me to give her my email, because she asks healthcare professionals for advice from time to time when healthcare issues come up. So I've also been inspired to follow up with her and make sure that my name does get added to that database so that I can get in the conversation. I hope that you also find what you've been inspired to do and you choose what it is that you want to do differently next week. So now, just before our final parting words, I'd like to welcome back Kokum Jenny Tenasco, who will lead us in a prayer for one more time. Thank you.
I just want to say a few words before I do the prayer. First, I would like to thank the Canadian Medical Association organizers and helpers for taking good care of us elders who attended, and everyone that was involved with the Indigenous Guiding Circle. It was my first time here, and they made me feel very welcome. And I hope, like some were talking about in the circle and others were talking about, they were able to provide a special room or a lodge in their hospital or clinic where Indigenous people can gather and meet with professionals and a more familiar space where they can smudge and be with their families. This would be more beneficial to the patients and families that need to meet with doctors. And as the people just spoke the truth, I think Michelle hit the target right on, talking about what we still need today, and all the others also. So it's a good thing that we have somebody here to listen, and that's the most important thing, is listening to Anishinaabe people. Miigwech. Te benjigech. Miigwech waso mamdo sewin. Miigwech gog pap kanama gojik. Miigwech on jemi shomasag. Kakana minope marazawin. Mamawe shawanong wabanong. Ishpinchiguj kiwednon. So we're thanking the grandfathers in the 4 directions for everything that they give us to have a good life. Miigwechonje aki, miigwechonje netauging, mijashking, wayagajeg, kaimetiku kakanamashki kai mijim. Miigwechonje nesewin kamijian kijimino pimadazian. Miigwechonje shkude niki, miigwechonje kakana awensi sag, kaba modejig, kanewakada jig, kaba miswijig, ke majamewjig. Widoka wishin kijinabakayan, widoka wayakasajig, shenwenim nibojig, kidamakasajig ke wawisanajig. Miigwechonje kakana urokaninawag ondejenongom. Ashij kakana udamta wajonje Nigon Pimadasijig, Mie Kichimigwech. We also thank the Creator for all the doctors that work hard for us, and the people that work for the future generation. Thank you very much, Miigwech.
Miigwech Kokomjeni. Again, I want to extend a huge thank you to all the speakers at this year's summit. This is a huge amount of work for not only the CMA, but for every single individual speakers, and I think they all deserve another round of applause for their work. And for everyone who's taken part in the summit, either online or in person, thank you for sharing your time and your perspectives with us. It was very much appreciated, and you all were an integral part in making this summit what it was. There's a lot of political change underway in Canada and North America and around the world even, but change also brings opportunity. I encourage you to seize this opportunity to collaborate and use our voice to keep healthcare near the top of the political agenda, for our benefit, from the benefit of all physicians, for the benefit of patients, and for the benefit of Canada. J'espère que ces quelques jours que nous avons passés
I hope that these few days inspired you for all the things that are close to our heart. So I hope safe travel home and hope to see you next year. Goodbye.